Hello and very good evening to all my friends out there. Is my voice clear to all of you? Can you all hear me?
Yes,
Nabia,
yes,
thank you very much. Thank you. Thank you very much for joining in. I welcome all of you to today's practice of stations from antenatal care. I hope you're going to do well. We started our journey, friends, sexual and reproductive health. Thank you very much, Abir. Thank you, Liana. Uh, Early pregnancy care we did as well. And today we are going to do antenatal care. And next Saturday would be maternal medicine, God's willing. Okay. So I hope you all are ready for the presentation. We have the sequence today instead of Dr. Pallavi from now onwards because some domestic commitments were there. Archana has taken over for the Group D for the active participation. And then we have Dr. Sujata and Dipti, Liana, and Dr. Sabia instead of Dr. Atia. Then we have Abir, Girija, and in the end, we've got Divya. So to all the presenters, again, the reminder, read carefully, please. Be a fast reader. Don't ignore any of the word. That's very important to be a quick reader. Just complete your station in 1 minute time. Do organize yourself. Please see that how you are going to enter into the cubicle, how the introduction would be, what agenda do you need to make, how the information gathering would be smoother, and the management plan, of course, the way I always tell you guys in chunks, check understanding, then chunks, check understanding. Okay, so chunk and check, chunk and check. This is how we all are going to proceed in the management. Okay, so we are here with the antenatal care today. The presenters I've told you already, and the 4 special tasks I would be posting just after the session today. All right. So antenatal care, we did together that the topics important are many in number. As we decided last week that in the second go, we're going to come back to the module when we will be doing the books and then would be completing the rest of the topics because it's very difficult to cover maternal medicine and antenatal care in 1 week's time. So the highlighted ones are the what we are going to cover because they're important stations: obesity, the preterm labor, the Down syndrome. Many congenital anomalies are there. I've taken this from my syllabus, which you all have, and spina bifida in pregnancy. We have to do the inflammatory bowel disease, ulcerative colitis, and Crohn's. Infections and other topics are also important. They're given in many books. Coming back to this module, we have to cover each one of this topic, okay? The related patient information leaflets, friends, that goes from the air travel, alcohol and pregnancy, the PIL number 7 regarding amniocentesis and the chorionic villus sampling, the antenatal care. We do have the Vico stitch as well.
அப்படியா ரிலீஸ் பண்ணியா நான் அது வேற ஒரு பெயின் இருந்துட்டே இருக்கும்ல அதுக்கப்புறம் டெலிவரி
Okay, bro. Let me mute. All right. So chickenpox and choosing to have a cesarean section and corticosteroids, all these are important information leaflets. Continuing with the FGM, genital herpes, which we did in sexual module, the GBS, fetal growth restriction. Despite these, if you don't find any Royal College information leaflet, now you people know that you have to gather it from the NHS and you have to get lines from there. So many information leaflets from the antenatal care are present in our COD. Nevertheless, they are not sufficient because many topics are not covered by the Green Top guidelines, which you have to cover from the NHS patient information leaflets. Okay. So we discussed the antenatal care basic template last time, and let's see how far do you people follow the template. Remember, you have to make the same introduction, the agenda making in the same manner. History of presenting illness, please start with the open question. Don't forget the blood group as it is the safety in a pregnant woman. Obstetric history would be coming first because that's a pregnancy case, all right? Do congratulate her if it's a planned pregnancy and a healthy pregnancy. However, if you're moving towards the termination of pregnancy, avoid that, okay? And the gynae history would come after obstetric history, then ask about the medical problem. If you have not asked in the HOPI, you can ask here in specific if something is left, but if it's part of HOPI, do it in the history of presenting complaints. Then complete your family, surgical, drug history, come to the management plan, address patient's concern, do a closure, arrange for the follow-up, and she should be knowing. Friends, she should be knowing that when she has to come next. So always give a very clear ending to your station. Am I clear? This was just a quick few minutes recap, which we've discussed earlier from the antenatal care, right? Okay, so what we're going to do now is station number 1. And hello, Archana.
Hello, ma'am.
How are you?
Fine. Nervous little.
Oh, don't be nervous at all, my dear. It's going to be a good start. And all batch D is very supportive. And I'm sure you're going to enjoy your practice in batch D. Okay.
Thank you, ma'am.
You're welcome, sweetheart. So everybody, Archana is audible to all of you? Yeah? Bindu, can you hear Archana? Abir, Liana, Archana is audible to all of you, right?
Yes, ma'am. Yes, clearly.
Okay, thank you very much. Thank you. So what we're going to do is that we're going to start the station. 2 minutes going to be first, and then we're going to have the 10 minutes time as we usually do, okay? So let's see what we have to begin with. All right. So Archana, your time starts now, my dear.
Next page, ma'am.
Yes, I've changed that.
Shall I start, ma'am?
Yes, please.
Hello, I'm Dr. Archana, one of the doctor in antenatal clinic today. May I confirm your name and age?
Yes, hi, doctor. Doctor, I'm Mrs. Ellie Wilson. Doctor, I'm 23 years.
How can I address you?
It's okay. You call me Ellie.
Ellie, I had gathered information from your midwife about your scan report and pregnancy so far. Surely in next few minutes, we will discuss more about your pregnancy and possible management option. And together we'll formulate a mutually agreed and safe plan. But Ellie, as we are meeting for the first time, can I ask you a few more questions?
Okay, yes, doctor.
Ellie, please tell me more about your pregnancy so far.
Yes, doctor. Doctor, I'm now 20 weeks in my pregnancy, and pregnancy so far is going good. I just had my ultrasound a few days back, and they say that the baby is fine. But otherwise, I had been through a difficult time in my life, doctor. So I'm a little scared. My baby would be healthy. My baby would be fine.
I can understand your concern. Have you started feeling baby movement?
But not yet, doctor.
Okay. In few days it will start, because in first pregnancy it will start after 20 weeks. So you will feel in next few weeks.
Okay.
Are you taking folic acids?
Yeah, I am taking folic acid, doctor.
And may I know the dose?
A midwife asked me to take higher dose because of my condition. She said that you need to take 5 mg.
Okay, that's good. May I know your blood group, Ellie,
Yeah, that's A positive.
and your height to weight ratio?
Actually, I try to do exercise and all because of that immobility I'm having, doctor, I have a little, I have to fight against my BMI. That is 24, but that's after a long effort of mine.
Okay, I can understand. Now tell me more about your condition. I mean,
Yes, doctor. Doctor, my mom tells me that I was born with the condition spina bifida, and there were like 6 to 7 surgeries in my first month of life I had. Uh, Doctors, they were very happy that I'm alive today, but actually I cannot move my legs. I cannot control my pee or even bowel. I have to wear diapers all the time, doctor. I'm catheterized. I have this tube passed, and this is how it goes.
so do you have any recurrent waterwork infections because of catheter?
I have, yes, on and off, yes, doctor. I have to take tablets for
And
that.
I can understand, Ellie, but don't worry, we are here to help you. Do you have any medicine for which for this condition? Taking any medicines?
Actually, not exactly for this condition, but yes, on and off, I do have some problem with the waterworks. So they give me tablets to prevent the infection. And
Do you
that's,
feel okay? Tell.
yes, doctor.
Do you feel sensation on touch in the limbs?
Yes, doctor. I do feel like cold or hot when I touch with my hands. I do feel, but actually, no, I cannot move.
Okay, so and since how much time you are on wheelchair, can I know it?
From the beginning, doctor, I've never kept my feet on the ground.
Okay. Till it's your first pregnancy, right, Ellie?
Yeah.
Yeah, and how was your periods previously before pregnancy?
My periods are never a problem. They're always on time, doctor.
Any history of vaginal discharge or lower tummy pain?
No, doctor.
Any illness for which you are seeking help with your GP?
No, that's it. I mean, on and off because of my condition. That's it. Otherwise, I'm well.
And have you checked your sugar level before?
No.
And have you done your investigation with your midwife in pregnancy?
Yeah, she said everything is fine from the beginning. She did some tests in the beginning and then ultrasounds as well. Everything was all right, doctor.
Okay, fine. And any surgery other than back on your tummy or below down?
No, that's it. There were multiple surgeries, but that too in the first month of my life. That's it.
Okay. And any known drug allergy or allergy to the latex?
No, doctor.
Ellie, do you smoke, taking alcohol or any recreational drug?
No, doctor, I cannot afford to. I've never taken such. No, neither smoke nor alcohol.
Good to hear that. What do you do for living?
Nothing, doctor. I just stay at home, and that's it. My partner, he earns well, and he also keeps on and off nursing care for me as well. He's very supportive, doctor.
So you are a happy couple, right?
Yeah. Thank you, doctor.
How had you been feeling in last few months, Ellie?
Yeah, everything is fine now. Since my pregnancy, it's been 5 months now, doctor. I'm a little scared because I just read on the Google that this condition can be in the kids as well. I've been through a lot, doctor. I would just pray that my kid, he can just walk on his own. I mean, I look at people and they can walk. I cannot think for my kid to be like this, please.
Yes, I can understand your concern, Ellie, and I'm going to provide you psychological support so you will feel better.
Thank you.
Anything more you want to share with me?
No, that's it. Can you please tell me that my management's gonna be?
Yes, coming to your report, I had confirmed its NHS number and your scan report is good. It's quite reassuring.
Uh-huh.
I can understand what you are going through as you are 20 weeks now and your scan is done, but it's reassuring. So coming to your pregnancy care, we the team of doctor will take care, which include consultant obstetrician, specialized midwife, spinal nurse, surgeon of your back, your blood doctor and physiotherapist. Henceforth, you will be in the consultant-led unit. That's why your midwife sent you here. So your next visit will be with consultant. Am I clear so far?
I get that. Okay.
So coming to your management option, we will continue with folic acid, which you are taking, and it's the right dose you are taking. So we will continue it. We will provide you additional scan to see the growth of your baby. As I have told you that, and you are fighting for your BMI and your restricted mobility. So there are chances of increasing sugars also. So we will have eye on sugar also. So we will monitor your sugars and we will treat accordingly. Is it okay?
Okay.
As you are telling me that you are on wheelchair since beginning, but other than it, no any significant factors. So right now you don't need any blood thinner, but we will assess you again, and if need arises, we will consult to the blood doctor, and we will start blood thinner accordingly. But right now you don't need any blood thinner.
I get that, doctor. Okay.
And as you are telling me that you are on catheter and on and off waterwork infection, so we will start prophylactic antibiotic to avoid early labor. Is that okay for you?
All right. That will be started now.
Okay, we will do it right now, or once your urine test report will come, we will add that antibiotics if it has infection.
Okay.
And as your condition had some effect on you and your pregnancy also can affect your condition. I mean, your symptoms like immobility, difficulty in breathing may get worsen. You can have recurrent water infection and pressure ulcer, or as previously told you, that your sugar level can increase, or you have chances to develop anemia also. But same thing can cause effect on your baby also, that you won't feel any baby movement. There are chances of early or late delivery. Baby can't be head first or maybe malposition. You might won't feel any labor pain also. Or there might be difficulty in breastfeeding also, as this can affect your pregnancy because of your condition. But as I already explained you that we are the team of doctor will help you. So if anything will happen with you, with you or your baby, we will inform you immediately and we'll treat you accordingly. Am I clear so far?
I get that, doctor. Okay. So it's going to be a cesarean section?
No. If a baby is not head first, then we will decide. Otherwise, there is no difficulty in natural birth also. I mean, normal delivery also.
Okay.
But we will share complete delivery plan at 36 of pregnancy. Ideally, we admit at 36 weeks plus 6 days to avoid unattended delivery at home. So we will going to admit you at 36 weeks, 6 days.
All right. Okay.
As I mentioned you that woman won't feel labor pain also. So once you are admitted and you went in labor, we will put you on continuous fetal monitoring to check baby's heartbeat. We will do tummy examination to see for contraction. And once labor is confirmed, we will do gentle PV examination every 4 hourly. And there will be anesthetist and consultant review at that time also. Is it clear?
Okay. I get that, doctor.
Once baby will born, we will connect you to the baby doctor who will take care of your baby. And during delivery, we will give you adequate analgesia to prevent the condition in which there is sudden rise of blood pressure. To settle that condition, we will keep the nifedipine tablet ready to avoid that condition. And once you deliver, we will give you the agent which will stop the bleeding, and we will try to avoid the ergot injection as it can worsen your condition.
Okay. Yeah.
We will encourage you to breastfeed, and we will discuss more about contraception at that time. But many women in this new responsibility may land up into depression. So I will connect you to this support group, that is Spina Bifida Association group, which will help you to cope up the situation. And we will provide you one-to-one support care for you and your baby, and your physiotherapy will continue. Is that any query so far, Ellie?
No, I get that, doctor. Right. So when do I have to come next?
So coming back to today, you are now under MDT care. Next scan date and your follow-up detail will be provided to you with your patient information leaflet. We will see you another 1 month, and I am going to give you emergency number so that you can contact me anytime. Thank you.
Okay, thank you very much, doctor. How did it go, Archana, after a long time hearing you? Yeah?
Yes,
How
ma'am.
was
I
it?
don't know.
No, tell me like, okay, friends, so positive points for Archana. Many things were covered, Archana. In fact, the things which were in spina bifida are very important in applied clinical knowledge and patient safety. They were very well covered, though a little time management issue was there.
Yes, yeah.
1.5 to 2 minutes were more.
But it's too long, ma'am.
Yeah,
It's
it
the
is too long. We have to cut it short. Okay. Yes, friends, what were the positive points in Archana station? And Archana, tell me yourself that what were those things which you did good, and then we are going to come to those which have to be improved as well. Okay. Yes, Girija, it was very well done. Yes. Yes, Archana, what were the good points?
I tried to cover all the things, but in labor management, because of time, I feel
Okay, no problem. But
I'm not
applied
able to
clinical
cover.
knowledge was very good. I mean, you've mentioned almost everything which the talk article says. That was beautiful. So applied clinical knowledge was very good. And okay, so anything else which you would have been done in a better manner, or you could think that this was I could have done it a little better. Any that point of any part of that station?
No, I don't know, ma'am.
All right, let me start with the feedback. Okay, to begin with, Ellie Wilson, she was on wheelchair. Almost in applied clinical knowledge, almost everything was covered, though it was in 12 minutes, but that's not a problem, but you have to squeeze it, okay? You have to shrink few points, you just mention them and move to the next. I know it was a long station because you have to cover the entire antenatal care, intrapartum care, and postpartum care as well. Information gathering, almost you asked everything. So applied clinical knowledge was very good. And similarly, patient safety was good as well. I had given you borderline in patient safety earlier, but when you covered up autonomic dysreflexia, and you said that we give certain tablets to decrease the blood pressure. So that was very good. That was important to tell to this patient who has an spinal cord surgery prior, okay? So the beginning was, at the start, asked about the fetal movement. Sorry, Fawzia, come again with the question. She asked about the fetal movements in the pregnancy or in the start. Fawzia, you can
Ma'am, I
unmute.
had asked in HOPI, ma'am.
Yes, in HOPI it had to be mentioned that asking about the baby movements. Why? Because generally there can be something like which is missed. But reassuring should not be done. I'm just coming to the points which have to be improved. Now, to begin with, in the entire station, Archana, we need to work, my dear, on empathy. Okay? This is in the entire station. See, you're the type of a student I know who is very good in applied clinical knowledge. I know that you know each and every line of the GTG, the NICE, the talk articles, because I know you, I've trained you. And I know that everything if I would be asking like where it is written, and you should be knowing, because I myself have trained you, so I know about that. But firstly, of course, English is not the first line language which you're using in your area. Therefore, there's a little trouble. Of course, we need to work on that. Secondly, empathy needs to be better. For example, if I would be meeting a person who's on a wheelchair, so I would be a little more empathetic from the beginning. 3 to 4 times, she told you about that she wants to, she looks around and she sees people who are walking on feet. So you ask the next question. So you should throw some lines on like this, that I can see, Ellie, that you're a fighter. And I know how difficult it is. We as a team of doctors are here to support you. Something like this, because she's been through a lot. Or somewhere she said, I don't want my kid to be like this. Again, put some empathetic lines there. I understand the level of anxiety.
At that time, I offer
counselor. Yeah?
At that time, I offer her counselor.
Yes, I've written that, yes. So you offered counselor. So in the beginning, even when you made that, the starting was that you've come here, and the midwife has told me about that you've undergone a scan and you're here to discuss about the scan. That was a good thing, rather than saying that, I can see that you're on a wheelchair or something. That is a little embarrassing. So that start was good, but empathy in the sound, we'll work more on that to be more empathetic. Okay. Introduction was all right. Agenda making was fine, but agenda making continuously got connected to the information gathering. So when you start your agenda, you check from Ellie, is that right? So you take a break after agenda and then come to the information gathering. Information gathering, HOPI, you asked about the folic acid, that was very good. You asked about the pregnancy, I told you so far it's going good. You asked about the fetal movement, that was very important. However, I'll tell you that reassuring that fetal movements would be okay, that has to be avoided. Why? I'll just come to this point. You asked about the blood group, that was very good. BMI 24, that was fine for her, and that's a very valid question you have to ask, because if I would have asked, would have told you about the BMI higher, then blood thinners, might have to be started according to the assessment. You asked about my condition without knowing that what actually has happened and all. Avoiding naming was very good, Archana. So you asked about the condition. I told you about the condition. You asked about the next question. Here, I would like you to speak. I'm sorry to see you in this difficult situation. Ellie, something like that, which you feel that, okay, a big story has come to you and she has had multiple surgeries. At that point, empathy was lacking. You started with the condition, and that was good that you asked about the waterworks infection, the sensations that can be felt. These were beautiful questions to assess the level of the spina bifida. And the gynecological history, medical history. You did check about the surgical history. Other than this, the drug, allergy, smoking, and the alcohol, psychological effects, and connected me to the counselor as well. So all these points were good. Then you came to the management plan. Your management through the antenatal care went first, and almost all the antenatal care plan was fine, but the bell was ringing there. Intrapartum was very good, but actually it was after the bell was ringing. And then came the postpartum care. Again, we were over time at that point, but the things which you touched were all perfect, all superb, which many of the students would be missing. But the time management, we'll have to little speed up and make small sentences. One more thing which I've noted is that first, the empathy, that has to be more. Secondly, avoid reassurance that she might not have baby movements depending upon the level of the lesion. Am I right? You remember the talk article, they said that at times there's altered
Yes,
perception
ma'am.
of the fetal movements. When you said it's okay, you will be starting feeling the baby movements after a few weeks because it's the first pregnancy. So asking about the baby movements is fine, but don't give her a false reassurance. She might not feel. So this is one complication which we can have. So don't give a false reassurance. Okay. So then exactly, Fawzia. This is what I mean to say, that she might not have the baby movements at all, right? We don't know about the lesion. And Midhat, she did book to, I said that I did book to the midwife earlier, and she just asked me to come here to the consultant-led. So midwife booking was done earlier. So the consultant-led care has been now. That should have been earlier. You're right. So now midwife has sent to me. That's it, and I'm here. Coming to the point that when I was telling about this aspect, and I was very sensitive on this, that I look around. So say something like, to give her an encouragement that you've been through a lot, and me and my team of doctors, Ellie, are here to support you in this situation. We are going to give our best to take care of you and the baby. Now, first point after the information gathering, as the template says, come to the effects on the mother and the baby.
Yes, ma'am.
You did the antenatal care, then you came to the effects on the mom and the baby, and then you came to the intrapartum care. Am I right?
Actually, I forgot and
Oh, I understand, sweetheart. I totally understand. This is what happens in the presentation. It's absolutely acceptable. But for exam, we have to remember, do the information gathering. Now say that, let me tell you that what it means to you and the baby, and then come to the effects to the mom and the baby. And then you have to continue with this antenatal care, intrapartum, and the postpartum. Autonomic dysreflexia, you can simply ask that in the history as well. Ever in your life, did you experience sudden rise in your blood pressure, which required treatment to decrease the blood pressure, Ellie? So this is what you're asking for, autonomic dysreflexia. In intrapartum, you have to mention again, if at all, there's a rise in the blood pressure at that point, we would be ready with the tablets to deal with that immediately, Ellie. Would that be okay? So these 2-3 things you have to mention there. Now, when I said that it's going to be a cesarean section, you said, no, 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 no. I know this was, why did you say that? No, 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 because you were very confident that it's not going to be a cesarean section, right? But the ideal way, the ideal way is that I respect your concern, Ellie. We are going to decide at that point that do we have any other indication for cesarean section. However, having this condition only does not make us clear that it's going to be a cesarean section. We can aim for a vaginal birth. If any other reason would be there, we will discuss with you in detail. So respect the concern first, respect the anxiety first, the stress first, and then come with the answer that it's way too early to decide about that. If only this condition we have to deal with, we can aim for the vaginal birth. If at all we have any other concern, we might decide for cesarean section after discussing with you, right? The MDT thing you did was very good. Very good that was. And then effect on the prophylactic antibiotics you said that we are going to give. You can simply say that prophylactic antibiotic, it is, you say that we are going to give you medicines to prevent infection of the waterworks. Prevent infections of the waterworks rather than saying prophylactic antibiotics, we are going to say. Just rephrase that, okay?
Okay.
Now, let's see the questions, then I'll go with the slides. Fawzia says, don't know. Okay, let me go up. The chat box says, okay, Midhat, is it clear, my dear, that she came now because midwife mentioned if Midhat in exam, she is having a delay and she's a late booker, always ask about this. So may I know, when did you book to the midwife? And when did she suggest you to see us in the antenatal clinic? So any concern behind the late booking? So she might come up with something, right? So if at all it's late, but she said that like she just had an early booking with the midwife, so it was okay. But if in exam it is a late booker, she's a late booker, then do ask the concern behind booking late. Okay, Midhat? So you might get some family problems for which you have to give some support or something. Now, Fawzia says, since we are not sure about her level of injury, that whether she will feel sensations of the baby and moving. Yes. So that's the question why we ask for the baby movements, because this actually tells us that where is the lesion. Harshiba, folic acid given throughout the pregnancy, don't know, I think 12 weeks, not sure, Girija, okay. Actually, the guideline says about the neural tube defects that it's better that you give at least for 12 weeks, but the previous pregnancy, if it was a neural tube defect, it said that it should be taken completely. So if you say that you continue with that, this is not something which is going to make you fail in your applied clinical knowledge. Okay, right, Fawzia, Girija? 12 weeks is mandatory, but if she's taking at the moment, don't stop in your question. It's fine to make it continued, Harshiba. Okay, because stopping this, it actually makes difference. In sickle cell, it is continued. Previous neural tube defect, it said that do it in the entire pregnancy. Therefore, make it in this point. She's taking till 20 weeks, so let her continue. That's not a problem. In fact, don't mention that. You just confirm that she's taking high dose. That's very important, which Archana did beautifully. That may I know the dose? That's very important. You're telling examiner that I know that mom is having a spina bifida history, so the chances of having a baby with spina bifida is more. Okay, so 5 mg, you have to confirm. That's important. Don't stop that at the moment. Now, yeah, Fawzia, I got that, my dear. She will take folic acid. Okay, right. And Girija, there was a question. Ramya, how to assess level of the lesion with history, Dr. Sidra? Ramya, I'm just going to show you that spinal cord screenshot, and I'll just let you know that what two or three questions can make you assess that. However, that doesn't make any difference in the question. Information gathering has to be there, but management plan would be the same, and I'll just come to that, okay? Right, Ramya? Just in a bit, okay. So let's see. Yes, Archana, before that, let me go with the scoring. Information gathering, I will give you 1.5, my dear. Patient safety, you did, if I give you 12 minutes, then I'm going to pass, but if it's going to be 10 minutes, then it would be around borderline, because autonomic dysreflexia, continuing about this and giving the counselor and the support group, everything was in 12 minutes. So if I take 12 minutes, I would be passing you. If not, then borderline. Applied clinical knowledge would be around 1.5 as well. Communication with the patient, we have to work on this, okay? So I'm not grading you on communication with the patient because empathy has to be really very superb for these types of stations. For this one domain, we'll work on this and I'm sure you'll be perfect. Harshiba, when you practice in the mini group, you people have to work on the communication with the patient for Archana, and definitely you people can use her applied clinical knowledge because she is an encyclopedia. She knows everything what is given there. However, yes, you're going to learn from each other. Okay, Group D, got that?
Yes.
Okay, thank you very much. Right. So let's see what communication with the patient actually had to be there. Rapport building with this patient is very important, and explaining the agenda and understanding. The most important part is establishing spina bifida history in a very empathetic manner. Don't take this patient like any other patient. So the sound should be very empathetic. Okay, the sound should be very empathetic. And avoiding jargons, that's important. And a logical sequence, of course, it has to be there. Now, when we come to the history, the presenting complaints are two. Number one, that she's at 20 weeks of pregnancy, mid-birth, right? And Shaheen, she is having spina bifida as well. So when we talk about the presenting complaints, 20 weeks, how had the pregnancy been so far? May I know about the baby movements? Are you taking the folic acid? And may I know the dose? Ellie? Ellie, may I know more about your condition? Okay, so how many surgeries were done? Do you have any problem with the waterworks or the bowel problem? May I know that do you feel hot and cold in the limbs, and to which extent? I would like to know more about your mobility limitations, Ellie. Any recurrent infections are you going through? Did you ever, in your lifetime up till now, suffer from pressure ulcers? How about the support at home? And do you need any nursing care? Currently, are you taking any medications? Now, support generally comes down in your station, but this patient in your HOPI, how is she managing things? How is the household going? Who does the chores for her? These all things are very, very important. Okay. Then obstetric history. It was
is mobility limitation. We can just ask that to the patient. Is it? Do you have any mobility limitation?
Yeah. So may I know that how far your mobility is limited? So she would be knowing that, okay, I can just extend my leg to this level, or I can turn around in the bed. Why am I saying this? Because it's going to tell you that how far do you need for even for the labor. This is an information which you require. So may I know how far your mobility is limited? So should be coming up with, doctor, I can just raise up my leg to this extent, or I cannot do that, or I cannot bend that, anything like that. So this will be actually giving you a clue that what actually type or the level of the injury is. Therefore, you would be knowing that how much support does she require for simple, tiny things, even in the labor, okay? Now, obstetric history, she was a primary gravida, so we need not do that. The gynae history, asking about the vaginal discharge, lower tummy infection, medical history, family history, any family history of clots in the legs, I would do that. Why? Because she's a patient with immobility. Therefore, if it's a thrombophilia running in the family, so that's an additional factor which we need to take into consideration. Any operations in the past would be okay. Any medications you're taking currently, you can ask earlier as well. The latex allergy is important because some articles, they say, because of long-term being on the tube with the catheter, there is a link of the spina bifida and having catheterized with the latex allergy. So in specific, you can ask that. Smoking, alcohol, recreational drugs, what do you do to live in the support and about feeling in the last few months? So this completes your information gathering about the spinal cord injury or the spina bifida patient who had multiple spinal surgeries. When we come to the patient safety, the best thing which she did was actually the team of doctors taking care of Ellie. Folic acid 5 mg, assessing for the blood thinners because she has a risk of having clots in the legs. We are going to admit you at around 6 days past from 36 weeks. Archana forgot that, but please don't forget that it's going to be a continuous baby heart rate monitoring in the labor. Always remember that you should be ready for the precautions in the treatment of autonomic dysreflexia, which we call it as sudden rise in the blood pressure. And when we'll discuss about the contraception, the combined pill has to be avoided. All these were the patient safety. Out of these, 2 or 3 were missing. Okay, so you all need to remember that these are the patient safety points which you all need to remember and revise them well, because all these, they are going to be important for managing this patient. Now, this is going to be the care and the part which you need to ask for questions for the patient. Now, generally, if it depends upon where was the basically spina bifida. But you need to remember that when you ask about this, that the patient ever had sudden rise in blood pressure, ever in her life, because of stress, it can be ever, right? So that means that the lesion is above T6 at least, right? And if she has some sort of, in the pregnancy, some sort of waterworks infection, and in the late part of pregnancy, if she is having this, at least we have to tell her the risk that the baby can have a position other than being head down, right? So all these points you need to remember. Similarly, if you see on the left hand side, generally it doesn't happen because it's way too higher, that above T4 there's a problem in the breathing as well. Autonomic dysreflexia, it's above T6 level, remember. And the thing which I was talking about, Fawzia, that above T10, my dear, there's an altered perception of the fetal movements. At times they do feel, but at times they do not. Okay, at times they do feel and at times they do not. So that is a point where you need to take care of this thing, that how the baby movements are, and don't give false reassurance. And by saying that altered perception, it does not mean that there's no perception at all. This means that it is going to be altered. So at times they're being felt and at times they're not being felt. So you cannot count on her perception of the fetal movement that the baby is okay, which generally we take for the pregnant women, right? This is what it means, that she has altered perception of the baby movement. Yes, I'm coming to your question, Dr. Bindu, just in a while. Okay, so when we start with the management of spina bifida, how we are going to start with is that it is going to be a consultant-led care, right? And what it includes is the specialized midwife, the nurse, the doctor who deals with the spine, and the physiotherapist, along with that blood doctor, is also taking into consideration, baby doctor, and the anesthesia doctor as well. So this is a combination of team which is going to take care of Bindu. Okay. Now the first thing after spina bifida comes, it's going to be the effects on the mother. That generally the height to weight ratio, because of immobility, there is on a rise, and if it's there, there's a chance of having increased sugar levels, blood pressure, and having proteins in the urine. Ellie, I would like to tell you, for these women, they can have the labor earlier than the due date. Recurrent waterworks infection is there. They can have pressure ulcers, and the baby movement can be altered as well. At times, they cannot feel the labor pains as well. In the advanced labor, when we assess these patients, generally with this condition, there can be a position of the baby other than the head down. A sudden rise in the blood pressure can be at the time of the labor due to stress. During the pregnancy, these patients are assessed because they can have a risk of having clots in the legs, and after the birth, there's a chance of having depression more for the baby. Recurrence chance of having the same condition is there. And at times the baby are smaller in growth as well. Now I will take you through the pregnancy journey to see that how we are going to decrease the chances of these to occur. So it's going to be a team of doctor, and a consultant is going to take care of you with a specialized midwife, the nurse, and the nerve doctor, the spine doctor, the blood doctor, and the physiotherapist as well. In later part of the pregnancy, the baby doctor and the anesthesia doctor will also take care of you. I'm talking generally in the risk, Fawzia. If she is like 24, 25, don't mention that. But like spinal bifida, generally they are, if she's on wheelchair, so you should put that. Maybe in exam she was like 30. If she is more than 30, you should be knowing that what do you have to add, Fawzia, okay? If she is not, then just skip this point, all right? But you should be knowing that what you have to add if she is having a combination of spina bifida, my dear, and a combination of having increased BMI, all right? Then you should be adding this point. Now, during this, we are going to assess you. We'll continue the folic acid. We'll do an additional scan if required. Somebody's mic is unmute, friends. Okay. All right. Okay. So VT prophylaxis, antibiotics to prevent the infection. The delivery plan would be discussed with you at 36 weeks, Ellie, and we are going to admit you around 6 days past from 36 weeks. Now, once antenatal care is done, you're going to discuss with the interpartum care, and you would say that we're going to aim for the vaginal birth, and the baby will be checked continuously for the baby's heart, and we are going to assess through the tummy the contractions of the womb. We would ensure that we do gentle vaginal examination, as it can precipitate and trigger the rise in the blood pressure, as I've discussed earlier. If at all it occurs, Ellie, we would be ready with the tablets and to deal with that situation accordingly. If there is the position of the baby is not head first, we'll discuss the option of cesarean section with you, and then again, baby doctor would be there to take care of the baby at that point in time. After the delivery, there is a chance of having increased bleeding, for which we'll give all the medicines, avoiding certain medicines called ergot, as they can precipitate, again, increase in the blood pressure. We are going to attend, the counselor is going to attend that, and we are going to deal with the depression if at all there is a risk. Afterward, you'll be offered with support as well. We'll encourage the breastfeeding, discuss the contraception, avoiding the combined pills. We'll assess you for the blood thinners again and offer support. So now your journey of spina bifida will get completed. Please give her a patient information leaflet and get her attended to support group Spina Bifida Association so that she feels better. Okay, so this is how you're going through that, but make it a little quick. Empathy part, do make it, because there's nothing like BBN. She knows the situation. But if I make it in this manner, you should be knowing, okay, this point done, tick, 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 now moving to the interpartum. Effects always make in the beginning, because when you do the antenatal care and after that you come to the effects, that makes a little confusion. Why? Because this journey should be like one after the other. Do you people get my point? Fawzia, Bindu, make it like in a go. So effects should be on the top, because when you do the effects in the management plan, you're going to make her come here. No, not 36 weeks. No, Dr. Bindu, she's at 20 weeks, right? So we cannot skip so much of time. We are going to tell her that you will be admitted at 36 plus 6 weeks. So next you can say that with the consultant, the appointment is going to be in 2 to 4 weeks time. Now, one question I have here, which is an important question, that if I ask, I didn't ask Archana, but if I ask you guys that if the scan is done, anomaly scan, right? And it's normal. And if I say that there is like, now my baby is normal, that means it's 100% that an anomaly scan is fine? So my baby is normal?
No, ma'am.
No.
No, it's not. It cannot be 100%.
Okay, so what would be the answer?
After birth, we can tell the baby doctor to check the baby if there is, because there's suspicion of spina bifida occulta.
Okay, so what are you going to tell patient? She says that, okay, my scan has just been done and they say that the baby is normal. That means, okay, I'm now having a sigh of relief, doctor, that the baby is not having the condition. Is that right?
No, we tell her that those conditions that can be found out on the ultrasound are not present in your baby. For now, the baby looks fine. However, we will confirm this once the baby is born. The baby doctor will take a detailed look at your baby and make sure that it's perfectly all right.
Mm-hmm. Okay, so she says that, so you would say that at least spina bifida is not there?
No, I
So we
wouldn't
can
comment
offer
on
her
that.
amniocentesis, I think.
Come again, sorry?
We can offer her amniocentesis. We can tell her that there's a special measures that we can do. We can do for you a needle test. And it
But
can give us
what
an
would
idea.
needle test show? Would it show spina bifida if there's no chromosomal abnormality?
No, that's
But I
fetal
think it-
calprotectin.
Alpha fetoprotein, it will increase in the amniotic fluid.
We'll do a blood test at around 24 weeks, I think, which will detect the chances of the baby having spina bifida.
Would that be diagnostic? My question is, would that be diagnostic? What is diagnostic test for spina bifida, by the way? What is diagnostic? Scan. Very good, sir, with the West. It is scan. So basically, until unless you see it with your eyes, you say that it's alpha-fetoprotein can be raised with many reasons. It gives you a clue that there is a chance of having spina bifida, but it does not necessarily mean that it is raised because of being spina bifida. Do you get that? Yeah?
Yes.
So diagnostic is scan, my dear. So simple statement, you say that, Ellie, I can understand. So far, the ultrasound is normal. However, I would just like to tell you that 5 in 100 types of abnormalities, they're not picked up in scan. So would just like to tell you that 5% of anomalies are missed. So don't reassure. At the same time, tell that 5% of abnormalities are missed on the scan, which we just come to know once the baby is born and is seen by the baby doctor. However, again, would like to tell you that yes, 95 out of 100 babies who have a normal scan, they are normal when they're born as well. But this 5% risk she should have in her mind. Clear? Okay, so 5% anomalies are missed. You simply tell this and you are clear, like in your applied clinical knowledge, that these can be missed even with a normal anomaly scan. They're picked up when the baby is born. Clear, everyone? So that's the answer, simple. So you need not go into detail of but don't say, I've seen students presenting with this saying that, okay, yes, now the baby is fine because the ultrasound is fine. So she would be keeping this in mind. There can be occult as well. There can be a misstep of the anomaly scan as well. There are chances. There's an error as well. So don't reassure the patient at that point in time. Clear, everyone? Okay, right? So admitting at 36 plus 6, remember again, this is your patient safety. You have to admit the patient at 36 plus 6, right? Okay, any questions from this spina bifida? I'll go through the outline. You have to take the station with empathy, please. This station requires empathy, introduction, agenda, information gathering, history, examination, investigation, tell the spina bifida effects on the mother and the baby, go through the antenatal care the way I've told you, intrapartum care the way I've told you, postpartum care the way I've told you, go through the addressing concerns, follow-up plan, PIL and support group, spina bifida association, okay? Girija, if it's normal, it's fine. But yes, if it shows a bifida, then do offer a fetal medicine scan. If it's normal, it's okay. So that means that ultrasound has been done by the radiologist, right? If it's done by the specialist doctor, it's all right. You need not, because anomaly scan is done by the specialist, right? So if it's done, it's okay. Why do you want to talk about the VP shunt, Harshipa? In which scenario?
Ma'am, in case we get a patient which has a VP shunt and we don't know it in our notes, I mean, if we have to like elicit in
what
the
is
history.
the indication of VP shunt? Is it spina bifida?
Ma'am, in certain
yes,
PILs, it's
Hydro-
given that some patients do have a VP shunt and we have to involve the
no,
urologist.
No, VP shunt is basically for hydrocephalus.
Yes, ma'am. But
Okay.
certain
So hydrocephalus
spina-
hydrocephalus patient, if she is getting pregnant and she's coming to you, she won't be like this in on this wheelchair and all this. I mean, spina bifida is something like the spine has been, or the nerve
No, Dr. Sidra. We
Yes.
went through this PIL from spinabifidassociation.org, where they specifically kept mentioning that if the patient has a VP shunt,
So that is
we might
I'll
have
tell
to.
you why.
Yes.
Why is that, Divya? Because there's an association with bifida and that of an hydrocaph. There's a strong association of having this collective having this abnormality, right? So that's why they're saying.
So we should ask every patient about it.
No, when she's telling you about the condition that I had a spina bifida and I was being a surgery, I had a treatment with this and multiple surgeries were being done for this for the first 1 month of life. So why are you going to associate with hydrocaph then? Because you asked her, so may I know more about your condition? So if she says if she says that I had multiple problems, which I'm sure she won't be in a condition to, like, having a hydrocaph and then spina bifida and then pregnancy as well. So if she says that I had associated fluid in my part of the head as well, and then it was in the backbone, there was a problem, and the bifida was also there. So then yes, of course, VP shunt has to be asked. So you are going to ask that how was it treated?
Okay.
So if
then she'll tell us about this.
Yeah, she'll tell about this. But here it was an isolated spina bifida. There was not a combination with that of. Why have they mentioned in the PIL? Because there's very, very common it is for the coexisting spina bifida and that of the hydrocaph as well. Okay.
Okay. Thank you.
Right. Thank you. Okay. So Jyoti joined just now. Why admission at 36 plus 6 weeks? Jyoti, because the talk article says that they cannot perceive the labor pains. So you need to do the examination to see the uterine contractions. All right. So basically it is an indoor. You don't want that they have labor and they are going into labor and they're not perceiving the labor pains. So the article says that you should have the delivery in time. So admission cutoff, they've given 36 plus 6, Jyoti. Girija says, you mentioned prophylactic antibiotics earlier to prevent infection. Do we need to give it? With the patient who is continuously catheterized, Girija, yes. Who is having, because it's a foreign body, right? And she says that I have waterworks infection recurrent. So yes, the UTI thing you need to prevent. Otherwise, there's a risk of her going into the preterm labor. Girija, prophylactic antibiotics is a smaller dose that is taken then throughout the pregnancy, my dear. If you see the talk article UTI as well, you'll come to know about that. Okay, so they say that you have to take that's a smaller dose. Generally, Firdantin is being given for that, and that has to be continued later part of the pregnancy as well. Again, that is to be done by decided by the kidney doctor. Okay, so it's not that you're going to decide that, they are going to decide, because risk versus benefit is, otherwise if she has the waterworks infection, there will be a chance of her going into preterm labor. And this way, if we are trying to decrease that, knowing that she is catheterized, so this would actually decrease the chance, my dear. Okay.
Ma'am, in HOPI, do we have to ask her things like if she's ever had seizures in the past or any renal failure history like that?
Seizures, why?
Ma'am, again, it's a spinal condition if she's had some sort of
Sweetheart,
infection.
seizures, they occur because of the head condition. Hydrocaph, yes, they present with seizures.
Okay, so no seizures. And what about renal condition? Like if she has ever had dialysis for renal
when you ask about the
failure.
waterwork infection, she will tell you her stuff. Because see,
Okay,
the
not
PIL
specific.
you're talking about is about the spina bifida, which is associated with multiple things. So actually the seizures part is with the brain thing. Okay, and the brain is being compressed and then throws seizures. Not with only with the spine, it won't occur because the brain part is fine. It's actually the connection from the below down the nerves. They're having sensation, mobility, all these things, movements, all these are an issue here.
Okay, ma'am.
Okay, any other question, please? Spasms. Yes, Fauziya, what do you want to ask about the spasms? It's okay when you tell her about the condition she's having and she tells you the detail. My point is that you have a lot to cover in the pregnancy as well. So antenatal care, interpartum and postpartum, lots of things are there. If I would be taking history, I will ask about the pregnancy being planned, spontaneous, how had the pregnancy been so far, the baby movements and the folic acid. That's it about the pregnancy. About the bifida, details about the condition. Details about the condition would be one question which is going to help you with everything. So then ask about the surgeries she has had, waterworks or bowel problems, sensation, touch in the limbs, mobility limitation, infection she has had earlier, the pressure ulcers, if at all, support and the current medication she's taking. Liana, pelvimetry, why would you try to take pelvimetry here? What is at the back of your mind choosing pelvimetry? See, the pelvimetry basically is out otherwise from the domain of the labor. They say the cephalopelvic disproportion, if at all, it's there. You come to know in the labor. You can never say, right? Pelvic fracture. Liana, come up with this thing. Pelvic fracture, why, Fauziya? Yes. Because of the surgeries, multiple surgeries of the pelvic has been narrowed down. Yes,
because in TOG, ma'am, because in TOG said if the patients have spinal injury since childhood or congenital, so maybe there's an element of CPD. Therefore, pelvimetry is advised during the antenatal checkup, ma'am.
Okay, don't mention at this point in time. And you say that once you will be in labor, we are going to see that how far the labor is easy for you, and we'll discuss all the options. Don't do in the antenatal care at 20 weeks at the moment, because it's not going to, at the moment, see, pelvimetry is something like which is taken out from even the labor part as well. Why? Because it's actually a relationship between the baby size and the mother's pelvis size. So we cannot say, you know, if the baby is smaller, even the pelvimetry is not adequate, maybe the delivery is fine. Do you get my point, Liana? So this is something controversial. Avoid saying that in exam because it's going to take the story towards other thing. At the moment, she's at 20 weeks. So mention the important essential points from this point and then move forward. Okay, right?
All right. All right.
So generally, because pelvimetry has no role in the management, a smaller baby, a smaller pelvis can be delivered. A normal pelvis, a heavy baby cannot be delivered. So it's something interrelated. So don't mention that because it's something which is not liked by the in the practice now. All right, so just avoid that. Okay, right. So any other questions, please? Now your people are clear about the spina bifida? Anything which you
Dr. please, one question again. As I got the point of the amniocentesis, because it's written in the NHS BIL for the spina bifida. So we have to mention or no need to mention it?
No, don't mention the needle test at the moment. It's not required. If the anomaly scan has been fine, that's okay. All right, don't mention the needle test. No extra information is going to give you at this point. If anomaly scan is fine, you just tell her that 5% anomalies are missed, that's it. And don't go into the needle test. That's not required at the moment. All right. Okay. Any other questions, please? Thank you very much, my dear. Thank you.
Dr. Sidra, please, if the patient is still anxious and cannot accept her baby's normal, maybe we can offer her needle test to ensure there is no other associated anomalies, such as, sorry, not anomalies, such as associated chromosomal or anything.
But Abir, my point is that she's having spina bifida and she doesn't have any chromosomal abnormality. Of course, she's in front of you, right? So the only recurrence chance is that the baby can have spina bifida, right? So if she has a concern, you will tell her that ultrasound is diagnostic. Even if the needle test tells you something about the chromosomal abnormality, that is not something related to her condition. Spina bifida diagnostic is ultrasound, my dear. It is ultrasound. So basically, you have to tell her that ultrasound is, actually we see the defect and we tell that, okay, the problem with the spine is there. But if it's not there, yes, there are chances that 5 out of 100 the anomalies, they are missed on the ultrasound as well. So that's it. Your job is done. Needle test, what extra information would you get from needle test?
Actually, doctor, this is a question in one of 3 sessions that the patient not accept that the baby is normal. She wants another examination.
Okay, she's insisting for something. She's insisting for something.
Yes, she's insisting.
Okay, if she's insisting for something, then of course you don't have anything. You can simply say that for you, if you want that we can have another needle test, that again would give some information for your reassurance. And second thing is that we can do a repeat scan by these specialized doctors. That's it. If she insists for something, 2 things you can do. Refer to FMU for her reassurance, and number 2, if it's amniocentesis. If she insists for that, of course, then this is the only choice.
Okay,
if she doesn't insist, don't give an option yourself.
Okay, doctor.
All right. Okay. Okay, thank you very much. Thank you. All right. So any questions from spina bifida? Claire? How to deal with a woman who comes in early pregnancy 10 weeks and asks the risk to the baby. Same risk, Fawzia. If she comes in 10 weeks, you'll tell the same risks and you'll follow her up after 2 weeks for the down screening first. That is in the 11 to 13 plus 6 time. And then an anomaly scan in detail is going to tell you. Risks would be the same. Having a condition from the mother, spina bifida. Clear? Okay, it's a structural anomaly and won't be detected. Exactly, this is my point, Harshaba. A structural anomaly, amniocentesis is not going to give you any clue. But as Abir is saying, maybe she heard somewhere that the patient is insisting. Now, if the patient is insisting again and again, then you don't have any point. I mean, other than that, what you can do is a repeat scan you can offer and a needle test you can offer, but tell its limitations and then pros and cons as well. Because she would be like, if she thinks that needle test would be telling her that spina bifida is there, it's wrong. Only ultrasound can tell you that spina bifida is there. Yes, refer to the specialized group of doctors for the repeat scan. Yes, Bindu. Repeat scan is something which you can do. And then they say that, you know, the supervised, the specialized doctors, they've done that. And again, it says it's normal. right? Yes, if the mother is having. Girija, if the mom is having. Yes, my dear. If the mom is having, then it's actually 96% normal, right? So she needs to know about that. All right. Okay. So this brings us to a long station. Archana, hats off to you. It was a very long station, I understand. But try to do it in 10 minutes time. You all have to practice next time that you people do this station in 10 minutes and tell me that it's done, right? Because now I've given you this complete algorithm, and this doesn't contain the information gathering. So please do a practice amongst two of yourselves, okay? Any two of you can do. Cover all these points and try to do that in 10 minutes time if it's a repeat station. So you should be knowing that you have to cover all these points and do that in 10 minutes time. All right, would you practice by tomorrow? When you get the recording, you can just revise these points, complete your template, and do that in 10 minutes, just in a group of 2 you people can do. All right? Okay, thank you very much. Right, okay. So let's begin with the station number 2. Thank you very much, Dipti. Thank you, Divya. So only group D is gonna do that? Where are others? Shaheen, Sujata, Dr. Sabia, Ramya, right now.
Dr. Sidra,
Yes.
we in our group, we already talking with each other that in 10 minutes to complete the station and to show sympathy and empathy, they both together is very difficult in 10 minutes.
No, it's not difficult, Dr. Sabia.
Because,
Everybody had been doing that, and
and
inshallah you would be doing
I
that as well. That just demands a little practice and a little, the idea of the exam is you should be knowing that don't go into detail of everything. Touch the point and move to the next. Touch the point and move to the next. When you people start going into detail of one thing, then it becomes a little trouble. Okay?
yes, you are right. Somehow you are right, because I think there are more element of communication should be there.
Yes, so just try to cover the points which are important and move to the next. That's important for your covering in 10 minutes and touching all the points. Because if, see, autonomic dysreflexia, Dr. Sabia, you can speak for 2 minutes if you start explaining everything, and you can touch it for 15-20 seconds and move to the next as well. So you should know that art of touching in 15 to 20 seconds and moving with the treatment. So definitely gradually you guys would learn, definitely yes. So this, with practice, you learn to touch the point, and this comes with the flow that the next point is in your mind. And I understand when I'm practicing with students, what happens is that when they don't know what the next point is, they keep on sticking to one and, making it long and long and long at times. And now when the next point would be coming in your mind, right? Then you would be
Ma'am,
very
how to be so empathetic? I actually not getting.
No, I would definitely tell you, Archana, just giving few lines, like as I told you, giving few pauses and being sorry. They're sorry to see you in difficult situation. I'll give you like 5-10 lines specifically. Okay, you just practice them. Because only empathy is one thing which is short in you, and otherwise the applied clinical knowledge is very good, my dear. Okay, that's very good. The points is very good, but of course, when the communication is not empathetic, then actually the other things get affected as well. You understand? So it should go side by side to polish your other domains as well. All right? Okay, my dear, I'm sure you'll do great. Okay, so let's move to the station number 2, and we have got Dr. Sujata here. Hello, Dr. Sujata.
Hello, Dr. Sidra.
How are you?
I'm fine.
So lots of changes here. So band C and D have more stations today, if I'm not wrong. Yeah. Okay. So Dr. Sujata, can you speak a little louder?
Okay. Now, am I audible now?
Yes, you are audible. Yes. Okay. So let's start your 2 minutes time, and then we're gonna have 10 minutes. Okay. So let's begin.
Next slide.
Yes, I've changed that.
Shall I start? Hi, hello, I'm Dr. Sujata and I case scenario and I'm ready for the discussion.
Yeah. Hello, I'm Dr. Ali. Yeah, you rang me up. Yeah, I'm on call consultant for today. Yes.
Okay, Dr. Ali, I would like to tell you about Mrs. Viola Davis. She's in her 29th week of pregnancy and she has come with, uh, with abdominal pain and she's in preterm labor.
Okay, I get that right. So, what is the background of the patient? May I know a little about the history, please?
Yeah, she has started having pains, and there is no medical or surgical history, and she is allergic to penicillin, and she's afebrile. I would like to ask a few questions whether she had any urinary symptoms before the pain started, and whether she had any previous episodes of pain, and whether she's appreciating fetal movements well, and whether there's any leakage of water or she's having any bleeding. So after taking the proper history, I would like to examine her, and the examination says that the uterus is acting and the fetal heart is good on the CTG, and the pelvic examination shows that she's 2 centimeters dilated. So my diagnosis is she's in preterm labor.
I get that. So, what assessment would you like to do in her, and what are the recommendations? What do you think that we should do now?
Yeah, so what I want to do is I want to give her nifedipine tablets to 10 milligram, 10 to 20 milligram every 4th hourly to stop the labor pains. And I would like to give her injection betnosol 12 milligram IM stacked, and then repeat a dose after 24 hours. And before that, I will take a swab, a high vaginal swab, to rule out any infections. And I would also like to send for fetal fibronectin so that I will know whether she is likely to progress into established labor. Meanwhile, I would like to find out from the nursery if there is bed available for the baby in case our medications don't stop the labor pains and she might end up delivering. So I would talk to the pediatrician also and find out if the nursery bed is available.
But no, I just talked to my friend. The NICU is not available. Actually, we don't have any bed available in the NICU.
Okay. So, sir, we will have to transfer the mother in case the pains are not stopping. We'd like to transfer her to a place where the beds are available, and you will have to talk to the consultant there, sir, so that we can transfer the mother to that hospital.
All right. So, can I know that what are the preparations you need to do before transfer?
Yeah. So She will be accompanied, once I'm sure that there is a bed there, I will explain to the patient that in the best interest of her baby, we'll be shifting her to a place where she will get proper care for her baby if the baby comes out. And she'll be accompanied by a midwife so that she does not have any problem in the way, with continuous monitoring of the fetal heart. And if the pains are continuing before transferring, I would like to start her on Maxelf infusion also. I will give her 4 grams of Maxelf within 15 minutes, and then I will start an infusion at the rate of 1 gram in 24 hours while she's being transferred.
Okay, right. So any other drug you'd like to keep during transfer if you're giving her magnesium sulfate?
Yeah, I would like to keep calcium gluconate also ready in case she has any respiratory problems. And
other than that, all the notes have to be taken along. Yeah.
Yeah, I will make sure that she's catheterized so that we get to see her urine output.
Okay, right.
And I'll be monitoring her fetal heart also will be monitored. The baby's fetal heart will be monitored.
Now, what if your patient refuses to go to any other hospital and she's adamant to stay here? What will we do now?
So we'll have to explain to her that we'll try level best to control the preterm labor. And if in spite of all our efforts, if the baby is delivering, because we have given the shot of steroid, the baby may do well, but we cannot guarantee that the baby will not have any breathing problem or any problems of prematurity.
Okay. Right. So you'll try to do some other transfer thing, right? We call it as extra uterine transfer, yeah?
Yeah. Yes.
Okay. So what does extra uterine care involve?
Extra uterine care, once a baby comes out, we see how the baby is doing, and if it needs ventilation and ventilatory support, we can give the baby surfactant if it is available in our institution, and we can try with bag and mask if the ventilator is not available, and it will be done by the neonatologist. That's all I know.
All right. Okay. So can mother accompany the baby in extra uterine transfer?
Yes. If the mother is well, she will also be sent. As soon as the mother is well, she will be sent to the place where the baby is transferred.
All right. Okay. So what if she is 8 centimeter dilated now? Yeah. And what is your plan? You're still going to go with intrauterine transfer?
This will be very risky. So if the hospital is nearby, we may take a chance, but we'll have to be ready for delivery en route if the hospital is nearby. Otherwise, I will explain to the mother that she'll deliver the baby here, and then we will transfer the baby if the baby needs support after initial resuscitation by the pediatric team here, the neonatologist team here.
All right. Any other management plan would you like to do, because she's now about to deliver?
I will give her support and pain relief.
Okay. Any antibiotic in specific?
Antibiotic centimeters. Yeah, I she's not ruptured her membrane, so I'm not sure whether antibiotics should be given.
What do you feel about the GBS prophylaxis?
Initially, it was given, but we have not proved, we have not had a sample send and GBS proven. So nowadays they are not giving unless you send a culture and it comes as GBS positive, which is already.
She's having a preterm birth at 29 weeks, no?
So by the time we get the culture, we should start. I'm not sure.
Okay, I get that. I get that. All right. Yeah. So anything you would like to add? Yeah.
Oh, that's why it was given as allergic to penicillin. I didn't get a clue. Okay,
Thank you very much, Dr. Sujata. That was one different sort of a structured discussion which happened in my exam, believe me, and many other. It was a repeat station. It was such a difficult station. I'll tell you my story. I entered into the cubicle and I saw the examiner having his hand on the left ear, right? Imagine it, huh? Having a hand on the left ear. And I went inside and I said, yes, I introduced myself and said, I'm ready for this structured discussion. And he said that, hello. And I said that he's joking somehow. And I had a smile. I said, yes, hello. So he said, yes, hello. I'm on phone. You rang me. And immediately I placed my right hand on my right ear and I started talking to her.
Okay.
Actually, this was so funny. He was communicating the entire station with keeping the left hand on the ear. And I then was keeping my right hand on the ear. And it was such a difficult situation that I was not understanding because it was a long station, like 7-8 lines. And in the last line, it was written that you are calling your consultant. No questions were there. And it was a telephonic call. And when I entered inside, and like you introduced me, right? I introduced in the same manner. And he said, hello. And I was like, okay, hello. He was keeping constantly his hand on the ear and said, you rang me. Yes. You wanted to discuss about something? So I said, yeah. And then I realized that, okay, he's on phone, that I have to keep a hand here as well. And then we continued talking, and then actually this completed. Station was not difficult, friends, but actually it was a sequential structured discussion. Your answer leads to the next question. The answer of the student leads to the next question. There were no questions written in front of you. It was the way you discuss and the story goes forward with the station. It was a little difficult. Yeah. Yes, you're right, Sarwat. And if he was doing, I don't know about the other examiners, if he was doing with every student, so then he would have been taking only 2 minutes break of the candidate, reading the station and then putting again hand on the ears. So a good station, Dr. Sujata, despite few patient safety points, which I had to prompt you on, like calcium gluconate, you have to carry with magnesium sulfate, right? Remember, this is your patient safety. Similarly, my dear, no matter GBS is positive or negative in a preterm, you need to give antibiotic prophylaxis. All right, so GBS, interpartum antibiotic prophylaxis, you would say that as my patient is allergic to penicillin, so according to that, it would depend upon the severity of the allergy, right? That you need to give cephalosporin or the vancomycin. But you need to mention this specifically because they want to listen to from your side that, interpartum antibiotic prophylaxis, if she goes into advanced labor, it has to go in the same sequence. Now, the first thing is that Mrs. Viola Davis, she is here in the preterm labor. How do you keep the SPAR thing? Remember that when you're talking to any of the colleagues, I have solved all this station for all of you so that you know that what answers they expect in return of the questions which they make. Situation, background, assessment, and the recommendation you have to do. I'll put you on the mute mode. There's a little distortion. So then in the recording, you people will have difficulty. Just hold. Okay, it's done. Yes, Lana, I just muted that. Probably that was at Dr. Sujata's side. I've done that because in recording, the new people won't be able to listen, sweetheart. Okay. So I will identify the women by name and the reason of your report. This is what you speak. And we'll tell that Mrs. Viola Davis, she's with me. She's diagnosed with threatened preterm labor, requiring an intrauterine transfer because the NICU shortage is there, if you know from the beginning. If it's not written, then you would say that she's in the threatened preterm labor requiring further evaluation. Now, background, what do you say? In background, you always tell about the information which has been provided to you. What is the woman's reason for the admission? If she has some significant medical history that has been given to you. If not, you simply say that you are actually informing that women's background include what is the admission diagnosis. And today she is admitted with threatened preterm labor, and I'm here to discuss with you if she had any prior procedures, if she's taking any current medications, if she has any known allergy, like she was penicillin allergic, if you have been given with some laboratory results, which you need to tell to the consultant on call, you will tell that this is the background for this patient, so that consultant is in the better position to make a management plan for you, right? So she's a primary gravida. She's at 29 weeks, and in the antenatal care, it was uneventful. Oops, the screen is not moving. And you people didn't tell me. Okay.
Yes, yes. Can we ask for history? Like we just make up the missing points on our own, is it?
No, you say that I will ask for these additional points, Divya.
Okay.
Okay, the points which are not there.
But
right?
how do we've already examined the patient's examination findings are there? Do we go back and ask the patient
Yes,
questions?
you say that would like to know more about these points because you cannot make up your stuff, which has not been provided to you, right? Okay,
Yes.
so you say you do that in the S bar position, and you say, always remember that you tell the name of the patient and the reason for which she's with you, okay? So Mrs. Voiler Davis, she is diagnosed with threatened preterm labor, and she requires an intrauterine transfer because there is a shortage in the NICU bed availability. Now, in the background, what do you say? You give the women's reason for the admission, right? You tell about the significant medical history, if at all it's there. You tell that admitting diagnosis is this, and this is the date of the admission. Remember, this is your background. The consultant should be knowing. If she was admitted like 3 days back, it should be known to the consultant. She is admitted today with threatened preterm labor diagnosis. She had some prior procedures. She's currently on medications, allergies, some laboratory tests have been provided to you. All you're going to mention in your background, right? So you're going to make this information very clear to the examiner in the B of your S bar. So first is the situation, what she's here for. B is the background. You would say that she's a primary gravida at 29 weeks. Her antenatal care history has been uneventful. Currently, she had been complaining of the labor pains, and then you'll go with your information gathering story, right? In assessment, you'll say that I would like to do the physical examination in terms of vital signs. What is the pattern of the contractions, clinical impressions, and any concerns? So this is your assessment if it's not given to you. Here, as it was given to you, so what would you speak? She is vitally stable, having a contraction of 2 in 10, which are moderate, and the examination findings, if it's all been provided to you, that she's 2 centimeter dilated at the moment. If not done, at least you should mention that this is what I'm going to do. Why am I keeping these bullets up? You should be knowing what comes in assessment, right? And whatever has been provided to you, you're going to just speak that to your examiner in A. So I'll repeat that again. In situation, what do you say? That is, in situation, you tell what is she here for, speaking with the name, number 1, and then telling about the report, what has been given to you. She's diagnosed with threatened preterm labor. She requires intrauterine transfer due to NICU shortage. This is your situation. Am I clear? What is situation? In the first line, you would say the name of the patient, reason for what you're calling to the consultant. What is your concern? What is the diagnosis? This is what is the situation. If given, yes, Bindu. If given, you're going to say to this. If not given, then you'll move whenever he says so, then you're going to say about this NICU shortage, okay? Now, if the background, you are going to give the reason for the admission. Now we are going back to the situation. Reason for her admission, you would say, explaining what medical history significantly she has, if she has the diagnosis on this admission, and what is the date of the admission, like she was admitted 2 days back, 3 days back, or today. Any prior procedures that had been done, any medications she has been taking, every information gathering would be in the background. I want to tell you guys that what SBAR means. The background contains the information gathering. If information gathering is short, you will do that further. You will do that further and you'll keep it in your recommendations in assessment. So in assessment, what comes is your physical examination. Situation is your diagnosis. Background is your information gathering. Assessment is your physical examination. Am I clear that how you're going to take it as a story, like situation, the background, the information gathering, you're going to tell to the consultant, and in assessment, you'll come to the physical examination. If not provided to you, you would say that I would like to know about the vital signs, the contraction pattern, and this clinical impression. Now comes the recommendation. In recommendation, you speak about the management plan, right? So you always communicate as an SBAR pattern whenever you have to tell to any of the colleague about any situation you're encountering. This can be your junior colleague talking to you. It can be you talking to your consultant. Am I clear about the SBAR? Am I clear that S is situation, B is the background, means the information gathering, A means assessment, that is physical examination, right? And R means recommendation, that means the management. So explain what you need and be very specific and make suggestions, clarify the expectations. This all comes in the R. So patient will need to be transferred to another hospital with NICU facilities. Admit and monitor the patient in the ward while trying to get the NICU place in another hospital. These all would be your investigation, Nadra. In assessment, you will come to the examination and investigations, which you have to send, or if the things which you want that they should be with you. Right? Now, you would say that I'm going to admit the patient and check the neonatal facility, will inform the labor ward coordinator. Dr. Sujata, labor ward coordinator, coordinates for this. The consultant neonatologist and obstetrician as well. We'll discuss with the patient regarding the corticosteroid and tocolytic, administer them if she agrees with that. The corticosteroid betamethasone, you beautifully discussed, 12 milligram, 24 hourly, 2 doses. And the tocolytic, etosiban or difetipan, whatsoever is available. Magnesium sulfate and calcium gluconate would be ready if she goes into advanced labor. I will discuss the dose, the frequency, duration, and the licensing status and the side effects of each drug with the patient before giving her this drug administration. When I asked you that what are the preparations before the transfer, I wanted you to speak that I will inform the consultant obstetrician, neonatologist, labor ward coordinator, because decision of intrauterine transfer should be by on-call consultant after consulting with the consultant neonatologist of referring hospital. So this is a line which you have to speak. In IUT, there is a complete NHS recommendations on intrauterine transfer, which you should be knowing that it is actually the coordination between your consultant on call and after consulting with the consultant neonatologist of the referring hospital. We'll also communicate with the mother and document in notes, communicate with the receiving unit and ensure that the maternity bed and the cot availability is there. Why? Because it's an intrauterine transfer. So we require a maternity bed and the cot availability as well. We'll prepare the relevant data of the patient and complete health records, the relevant notes and the investigation reports and an intrauterine transfer record letter. The threatened preterm labor will document that this steroid dose has been given and she is on this current tocolysis. For ambulance transfer, we'll ensure that the transfer bag contains the magnesium sulfate and the calcium gluconate. I had to prompt you a little here. And she would be accompanied by a midwife and one doctor. Partner may accompany the patient if desired. So this would be the preparations before the transfer. Please note down, because I've solved in a sequence that which you all have to speak in a structured discussion like 1, 2, 3, 4, 5, 6, 7. All right. Now, what if patient refuses to go? Now, I would like to establish a reason of refusing the transfer, explaining the pros and cons of not getting transferred, but in the end would respect her wishes and give her full support available for maximum care to both the mother and the baby. After the delivery, I would let her know that baby has her or his own right and the doctors will act on the best interest of the baby. That means that baby will be transferred to another hospital even without her consent. Did you people understand what I'm talking about? So you should be knowing that the baby can be transferred if required, and we call it as she can decline an intrauterine transfer, but she cannot decline an extrauterine transfer. Did you people understand this point? She has a right over declining the intrauterine transfer, but she doesn't have a right to decline the extrauterine transfer. So transferring a critically ill, premature, newborn baby is not easy, but a specialist neonatal transfer team will ensure that the journey is as comfortable, as stable as possible for them. They will be taken in a special portable incubator to the nearest hospital that has the space and the facilities to care for the baby needs. Staff at the hospital will be alerted and prepared for the baby's arrival in the extrauterine transfer. Now, I asked you that can the mother accompany the baby in extrauterine transfer? You were absolutely right in answering that it might not be a suitable choice. But the way you have to speak is that the fact that when a baby is born prematurely, time is often of the essence, and the team needs to focus mainly on the baby to make the baby stable as quickly as possible. So I will advise her that it is advisable for her to stay in the hospital until she gets recovered well, because her health is important as the baby's health. I would definitely show empathy while saying this, and her family members will visit the baby and report back to the patient about the well-being of the baby. I will make sure that the mother receives enough support from the family members and the hospital staff while baby is away from the mother. So all these points of empathy you have to mention in a structured discussion so that they know and they analyze that if at all you're in this situation, you know that how to deal with this. Now I said to Dr. Sujata that patient is 8 centimeter dilated, so what's your plan? Now at this point in time, intrauterine transfer is contraindicated. So we are going to communicate to the mother and make preparations for the extrauterine transfer through portable incubator. This is the time magnesium sulfate would be given because she is in advanced labor, and maintaining the level between 4 to 7, monitoring the respiratory rate, the urinary volume, and the reflexes as well. And if required, stopping magnesium sulfate and giving calcium gluconate as an antidote would be considered. Intrapartum antibiotic prophylaxis would be given, and that would be cephalosporin for the penicillin allergy. This is what I wanted Dr. Sujata to speak. So this brings to the 5 questions ending. I tried to solve the way we had the important difficulty, and it's not one time. It was like 3 or 4 times the station came, and it was a little difficult, or I would say not difficult. It was a different type of structured discussion which came in exam. Generally, the structured discussions are simple, but this structured discussion, as I say, that your answer leads to the next question. So it's more of a discussion with your examiner, and whatever you answer, the next question comes from your answer basically. So this is how you have to take it forward. Did you people understand that how would S bar be, and how you're going to handle this preterm labor, the intrauterine transfer station? Yes, we don't do that. After 30 weeks, we do that.
Dr. Sidra.
You should be knowing that if she's after 30 weeks, Dr. Bindu, you would say that we'll do a scan for the cervical length as well. For 30, you will directly do the scan.
Dr. Sidra, the patient in...
Stop chatting at the back end. Is it whose mic is on? Hold on. Yes, Dr. Sabia, please speak up.
If the patient is in threatened preterm labor, not in established labor,
yeah,
and we are transferring the patient with the threatened preterm labor,
yes,
then of course we are not giving magnesium sulfate to that patient.
Yeah, we don't know she'll go into advanced labor. That's why we keep it. We are not giving that. But keeping in the bag is very important. This is your patient safety.
Okay.
We are not going to give it all. The magnesium sulfate indication is only if it's going to be like more than 4 centimeter advanced dilatation, or you anticipate that she's going to be delivered in next 24 hours, you're going to give magnesium sulfate. But keeping it in your ambulance transfer is your patient safety. What if she goes into labor? So you should have that. That's it. You should contain that during the ambulance transfer.
Dr. Sidra, in the NICE guideline, it mentioned that magnesium sulfate is to be given when the patient is in established preterm labor.
That is.
Or if you are planning,
yes,
if you are planning labor in the next 24 hours.
Very true. that this is what I mean to say. I said the same. If she's more than 4 centimeter, that is the definition of established labor. Okay.
Yes.
And second thing is that if 24 hours you anticipate that the labor is so strong enough that the next 24 hours she would be delivering, you give magnesium sulfate.
Okay.
Okay, so these two are the indications for the magnesium sulfate, correct. If it would have been an SPT, should we tell the patient that we will check if available or not before admission? It's important to say as buzzword for examiner to hear. Nadra, you would say admission is what you have to do because it's a preterm labor. There's one station in Oxford about the intrauterine transfer. It is clearly you have to remember this thing that you have to say that we are going to admit you, and the baby doctor, I will just talk to the baby doctor to see that if the cots are available. If not, we'll talk to you about the need of the transfer to the nearby hospital for the baby care. Would that be okay? Okay, right? All right, all right. Yes, Sarvat. Fetal fibronectin, you people are saying. Actually, in the sequential structure discussion, in the third question, Sarvat, the examiner made her 8 centimeter actually. Thank you. You're welcome, Nadra. No. Actually, they made her 8 centimeter in the next question, so that point didn't come in the discussion. So may I know what do you people want to say about the fetal fibronectin? Yes, Sarvat Aves, yeah? Unmute yourself.
Hello, doctor. Actually, I am asking that for the, if suppose other scenario, in that patient is not 8 centimeter.
Okay.
The patient is in suspected preterm labor. So whether we need to do the fetal fibronectin before transfer out, means it is a requirement, because I saw in some pill that how to in utero transfer. So in that it was written like this, it's mandatory to do the fetal fibronectin. And although we know that less than 30, we suppose not to do any diagnostic test. Without any diagnostic test,
No,
we need
we will follow the NICE guideline, Sarvat, here. Okay.
Okay.
So
Thank you.
the NICE guideline says that it's more than 30, go with the ultrasound cervical length checking. And if it's less than 30, go in with the treatment straight away till 29 plus 6. So we'll follow that. Okay.
Actually, Dr. Sidra, the Sarvat Aves is talking about, there is one pill shared by you. It's written the contraindication for the transfer. So they mention it, fetal fibronectin is negative. If the fetal fibronectin is negative, then
My
it is a
dear,
contraindication.
I totally understand. But my point is that we'll go with the NICE guidelines. See, pills at times are not following the sequence of the recent. NICE guideline is very recent, you know, for the preterm labor. So we'll follow the NICE guideline recommendation. Patient information leaflets are very important because they give you lines. But when it comes to the recommendation, follow the GTG or the NICE.
Yes.
Okay.
I want to just make clear our mind.
I totally understand. I understand.
Thank you.
Shaheen, you're welcome, my dear. Shaheen, cephalosporin can be given in mild penicillin allergy as per the Green Top guideline. And for severe allergy, you have to give vancomycin. Okay. So there's no point of giving penicillin. Mild allergy, yes, you can give cephalosporin, and severe allergy, you can give vancomycin.
Yeah, so in cases of penicillin allergy, we should ask the patient that whether how was the allergy she went into anaphylactic shock.
In SPT, yes, you can ask that. And in ST, you can simply say, as my patient is penicillin allergic, if in history I come to know that it's a mild allergy, I would give her cephalosporin as per the intrapartum antibiotic prophylaxis, or else would give her vancomycin. That's it. Your job is done.
Okay, thank you.
Thank you very much. Thank you. Okay, any other question? Did you people understand about this, how you have to move with this, this station? All this you can simply write in your notes and make your fixed template for this, because this is how the station went, and this is the a little different type of a structured discussion. So try to memorize all those important points which I've mentioned here, because at times you people don't realize in an intrauterine or extrauterine transfer what examiner wants to hear and how the things would be going. So at least your things would be in mind. And Dr. Sujata, the way I asked you that, please, would you keep some medicine or some other drug in your hand? I was asked the same, and I still remember I was like, magnesium sulfate I'm taking, what do I need to take? I immediately said, oh yes, calcium gluconate I will be taking along. So he had a smile on his face. So this happens. in structured discussion, at times you're not, of course, taking the points from the examiner. So at times they give you a clue, and that doesn't mean that you're actually failing an exam. If you pick that clue and you answer correctly, yes, you're passing that exam. So well done, Dr. Sujata. It was the first station done by you. Next time I'm going to give you a simulated patient task. Yeah, he was Bindu. Yeah, as I passed an exam, so I think all my examiners were very nice. Right? Thank you very much, Divya, for having appreciation for the S-bar. I'll do S-bar
in this patient. We'll do an ultrasound scan to confirm the presentation also, right? Because if it is a breach, we'll have to think of
yeah. So we assume here that it's a cephalic. If this information is not given to you, you mention that in your assessment. I'll ensure that it's a cephalic presentation, or else then the story changes. It's a cesarean section.
And do we say at the end of examination that we will take swabs and take a urine midstream sample for culture?
In history, yes, but it's a preterm labor. It's not a PPROM. It's not nowhere in the station it was mentioned that she's having a leak. So if only dilatation is there with an intact membranes, you can skip this part.
Okay, but just to rule out if she has had a UTI in the past or currently?
Yeah, that's what Dr. Sujata said in the history as well. I would like to rule out the history of preterm labor in terms of UTI, any cause. Okay. So this is how you have to speak as Dr. Sujata did.
Okay.
Right? Okay. So I know S-bar is difficult. That's why I've tried to make S-bar in the station, like putting how you put the situation background and the assessment and the recommendations, and then writing down, because the first question generally of every structured discussion comes as an S-bar. And I know it's a trouble. So I'll be practicing more on the structured discussion, that the first question you people get smooth in, that how you have to keep your SBAR thing and make it in a good flow. All right. Thank you very much, Dr. Sujata, for a very good station, and keep it up. Keep going, my dear. I'm sure in upcoming stations I will be perfect further. All right. Okay. Thank you. Thank you, my dear. Okay. So let's do, so far, Dr. Bindu, there are four STs and 6 SPTs and 4 layman stations. So far the pattern goes the same. All right. Okay. So let's do Dipti station, friends. We've got Dipti here. Hello, Dipti. How are you?
Yeah, I'm fine. How are you?
I can't hear you. I can't hear you.
Right now, am I audible?
The voice is feeble, coming from way too long distance. Is it only with me or is it with everyone? Dipti's voice is feeble to me or with everyone?
Hello.
Yes, hello. Are you with the headphones?
Okay. Yes.
It's very I think you'll have to take off. Bindu says Dipti is soft spoken, that's why we can't hear you, Dipti. Dipti, can you take off your headphones? I think headphones have a little trouble.
Yeah, sure.
Thank you.
Yeah, sure.
Yeah.
Is it okay now?
Oh, that's perfect. It seems that now you're in front of me. Okay, sweetheart. So let's begin. It's gonna be station number 3, friends, and we'll move to the SPT thing. And the 2 minutes they start now.
Okay.
Go ahead, my dear.
Yeah. Next slide, please.
Yeah, I've changed that.
Yeah. Next slide, please.
GP letter you've seen?
Yes. Hello, I'm Dr. Deepthi, one of the doctor in the antenatal clinic today. May I confirm your name and age, please?
Hi, doctor. I'm Elizabeth Keane. I'm 32 years, doctor.
And how may I address you?
Yeah, Elizabeth is all right.
Okay, Elizabeth. First, as I have gathered from your GP letter that you came here for booking your pregnancy. Am I correct?
Yeah, exactly, doctor. Yeah.
I know, Elizabeth, you came here to consult with my consultant, but right now he is away for some emergency work. So is it okay that I will carry on this consultation forward?
That's okay, but I hope you're not a very junior doctor to deal with me.
Yes, Elizabeth, I can understand your concern, but I will be as usual. I try to be as useful as my consultant, and I will definitely arrange your meeting with my consultant in next visit. Is that okay?
Yeah, thank you. That sounds good.
Okay, okay, Elizabeth. So in next few minutes, I will address all your concerns, discuss all your complaints, and then we'll discuss here and we'll come to a safe, acceptable, and mutual agreed plan for you. How that sounds to you?
That's okay, yeah.
Okay. May I ask you a few questions to know more about you, Elizabeth?
All right.
Okay. So Elizabeth, when was your last period?
Yeah, period was around 7 weeks back, doctor.
Okay. And how are your periods?
Always regular.
Okay. And so, is this your first pregnancy? Am I correct?
Yeah, yeah.
Okay. So you booked it with your midwife, Elizabeth. Your pregnancy you booked with midwife.
Yeah, yeah, she sent me here.
Okay. And have you started taking your folic acid tablets?
I have, yes.
And may I know the dose of your tablets, folic acid tablets?
I don't know exactly. I think it's something like 5 mg.
Okay, Elizabeth. Do your midwife give you some other tablets like vitamin D also?
I'm not sure if I'm taking only one, doctor.
Okay, Elizabeth. Any problem till now, Elizabeth, in your pregnancy?
No, so far so good. We are very happy with the pregnancy.
Okay. Are you aware of your blood group, Elizabeth?
This A positive, doctor.
And may I know your weight and height ratio?
Yeah, that's 42.
Okay, Elizabeth. So, are you following any physical activity for you right now? Are you on any physical activity or any dietary regime you are following for you?
Do I require that?
Elizabeth, as I have come to know from you, as you told me that your height and weight ratio is 42. So this is somewhat more, and there are certain complications which occur because of this weight and height ratio. So that's why I'm asking if you are on any with
No, I'm very
management
happy with this. I
plan
mean,
with your
my
labor?
partner, no, I'm very happy with this. My partner, he always loves this bubbly figure, and I'm like very happy with
Right.
this.
Okay, Elizabeth. So, are you following your GP for any medical problem?
No, I'm absolutely all right.
Are you taking any other medication right now apart from folic acid?
No.
Any drug allergies?
Yeah, I'm allergic to penicillin.
Okay, Elizabeth. And what happened to when you come to know that you are allergic to penicillin?
Yeah, once I had a sore throat. I was in my teens. I had an allergy. There was a rash. So doctors told me that I don't have to take penicillin.
Okay, Elizabeth, I will mention this that you are allergic to penicillin in your documents for further reference. Do you have any surgery in your tummy or down below in the past?
No, doctor.
Is there any concern, any family history of concern? There any clots in the family, in the legs?
No, doctor.
Okay. Some of my questions you feel intrusive, but I used to ask these questions to each of my patient, Elizabeth. Do you smoke and drink alcohol?
Yeah, I'm not doing that in the pregnancy, but otherwise, yes, I do.
Yes, good, Elizabeth, that you have stopped your smoking and alcohol drinking. And do you use any recreational drug?
No.
Okay. And what do you do for your living, Elizabeth?
I work as an accountant.
Okay. And how support at home?
That's perfect. My partner loves me a lot.
Okay. And how are you feeling in last few months?
That's perfect.
Okay. Elizabeth, are you updated with your smears?
Yeah, that's all right. They're normal.
Okay, Elizabeth. Thanks for sharing your information with me. Anything else you want to add in this?
That's it. I'm so keen to see and have a healthy baby. I'm just looking forward. So can you tell me that how the management would go?
Yes, definitely, Elizabeth. I will take you to through your pregnancy journey, and in this, I will advise you to continue your care plan with your midwife. But your pregnancy will be. It is important that your pregnancy will be under the specialist. Pregnancy care will be under specialist doctors, which includes your specialist obstetricians, your nutritionists, your dietitians. We are having specialist midwives and physiotherapists, and in this we will give you recommend you screening test for down screening at 11 to 13 and between 11 to 14 weeks. We will advise you anomaly scan at around 18 to 21 weeks. And Elizabeth, before that, I want to tell you that because of your BMI, which is 42, there are certain effects on you and on your baby because of this BMI. May I proceed for that?
Okay, tell me.
Elizabeth, because of the women which are having such a high BMI, although most of the patients they have normal pregnancy and deliver a healthy baby, but there are certain problems which happen in these patients. There are more chances of having miscarriages. There are more chances of having increase your blood sugar, increase your blood pressure during pregnancy. There are chances of having clots in your legs and in your lungs because of increased BMI. And during labor also, again, there are chances that your labor might be get prolonged. There's difficult labor, and while delivering your baby, we need to do instrument. We need to use instrument, or you might have cesarean delivery. Apart from this, Elizabeth, because of this BMI, there are chances that we might feel difficult to examine you from your tummy, how your baby is growing. So we need to do some frequent scan to see the growth of your baby. And also there are chances that when you may have some other problems when we give you the pain injection during delivery. Am I clear, Elizabeth?
All right, I get that. So should I take some medicines to decrease the weight now? I mean, I didn't know that it's so serious.
Elizabeth, the medicine which are used to decrease the weight, these are not recommended for the pregnant patient because it may have some effect on the baby. So, but I may involve the my consultant to discuss this issue with you if you want to start with some of these weight decreasing medicines. But as of now, these medications are not recommended in pregnancy. Am I clear?
I get that. Okay, right. So how would be
Okay.
the delivery?
Yeah, Elizabeth. We will discuss your delivery plan at around 36 weeks of your pregnancy. Till then, we will see the growth of your baby from 28 weeks of your pregnancy to see how your baby is growing. Because there are chances that you may have delivery before the expected date of confinement. There are chances that your baby might grow large in size than the normal baby. So we'll discuss that at that time only, depending on the condition of you and baby. And after delivery, there are chances that you may have loss of weight, increased chance of bleeding after delivery of your baby. So you may need some injections to before expulsion of your afterbirth. Is that okay?
Okay, I get that, right. So when do I
And
have to come now,
that,
and anything I have to start now?
Yes, Elizabeth, I will fix an appointment for a screening test at around 11 weeks. And because there are chances of that you may have the deficiency, there are chances that you have deficiency of vitamin D. I'll start this vitamin D tablets to you. Is that okay?
Yeah.
I will give you some patient information leaflets. So you go through that, and I will fix your appointment to my consultant. So you have a talk with them also.
Okay.
Any questions so far?
No, that's okay, doctor. I
Thank
understood that completely. Thank you very much. Thank you. Yes, Deepti, how did it go?
As usual, I'm fumbling a lot.
No problem, sweetheart. It would be okay. At least you're practicing. As Bindu was saying that you are basically a soft-spoken person, so I tried to make it a little difficult in the beginning, but you handled me well. If to any doctor, if I would say that you're so junior to talk to me. Of course, there's a little fumbling. So very good, nicely done. At least you managed to complete your management of antenatal care, interpartum, and postnatal. Again, like Archana, there was a little delay. It was 12 minutes. So you people need to cut down on your history taking. Dipti, history taking took 6 minutes and 30 seconds. So we have to cut down on the history taking. Okay, we'll do that. Definitely we'll do that. Okay. So friends, before I move to the feedback and ask about the certain good things which Dipti did, can you tell me any specific thing in the management plan you people would like to add, which has not been added?
Aspirin, ma'am.
Thank you very much. Who's this?
Harshaba.
Thank you very much, Harshaba. So aspirin has to be started, Dipti. Why? Primi gravida and BMI 42. So this had to be done. Yeah, this had to be started because this is one thing which you don't mention. Then actually your applied clinical knowledge goes wrong for the reason that she's got 2 risk factors and 2 moderate risk factors that advocates to start with aspirin. Very good. Yes, Pallavi, this is what she has to take. And Bindu, you have to work on history taking less because otherwise maternal medicine and antenatal care is a longer station. So we cannot take time from the management plan. We have to do from the information gathering. Okay? Right. So let's see what the good points were. I had a smile when I said that I said that consultant is away and you're so junior to talk to me. You said I would try to be as useful as my consultant. So that was very cute of you. You tried to adjust that difficult time with this spontaneous answer. So you can simply say that the next appointment is going to be with a consultant, and this part you handled well rather than being in a difficult situation that, you know, you're too junior to talk to me. So very good, Dipti. That start, though you started fumbling, but again, you came up with a good answer. So agenda making was good. You asked about the first condition of the pregnancy. That was good. The LMP asking was good. The priming gravida, folic acid, vitamin D. Emphasizing on the vitamin D, asking about the folic acid dose, that was very good. Asking about the blood group, the BMI. She was a little carefree patient who was not concerned about the BMI. So you had to be a little sensitive on that. You tried to be, that was good. You did ask about the medical history, about the penicillin, allergy. It took you around 1 minute to settle the penicillin thing. From here, you could have used your time for the management. Just say that, may I know what happened actually? I'm going to document that in your notes. That's it. So make a habit of speaking crisp sentences rather than making long sentences. That takes your time, my dear. Then you came to the family history, the personal history, the support. That was all good. After support, you realized about the smear as well. You can skip that in an antenatal care. That's not a problem. Otherwise, she's a low-risk patient, okay? Then you came to the management plan and it started with MDT. That was good. You started with the 11 to 14 weeks down screening, and then like Archana, you realized that effects on the mother and the baby are missing. Am I right?
I realized that I forgot to tell those things.
So, see, you people are missing. Remember, when you come to the information gathering and then understand, you just have to say that, you know, now let me tell you, Elizabeth, that what it means to you and to the baby. So now, immediately after information gathering, tell what condition means to the mother and the baby, and then take her through the pregnancy journey. Archana did the same. She mentioned 2 points, and after mentioning 2 points, she came to the effects, and you did the same. After mentioning 2 points, you know, she came to this effects on the mother and the baby. So do it first, and then come to and take it like a story.
Yes,
then you did tell about the antenatal care and the baby effects, and then you came to the interpartum care. And the postpartum care, again, the time was over. You came to, now it's going to be fixing an appointment with a consultant, an appointment with the screening test, and starting with the vitamin D. Here I was expecting aspirin starting as well. Okay. Yes. So all these points were there. Few jargons were being used. The first thing is that if the patient says that she's allergic, don't waste time on that. Your answer should be ready. So may I know what happens with the penicillin? All right, I'm going to document that in your notes. That's it. Move to the next question. Why to waste 40 seconds on this tiny point? We are ready for this. If allergy would come, we will just speak it up, okay? Second thing is, we heard that when you mentioned about the journey, you said that we are going to have some scan now for the down screening, then an anomaly scan. You say the mid-pregnancy scan to check if the baby is formed normally, okay? We'll do the mid-pregnancy scan to see if the baby is formed normally. This is what anomaly scan is, okay? And one more suggestion, that no need for a signposting before smoking and alcohol, my dear. My few questions would be intrusive, and they might sound personal to you, but I ask to all my patients, that's wasting your time. The 30 seconds they get wasted. So simply ask them, may I know, Elizabeth, do you smoke? Do you drink alcohol? Or pardon me to ask, any recreational drugs? That's it. Because we have to, you know, the point is that we have to take every important second from everywhere so that we can manage in 10 minutes. Already it's a big station, and moreover, you add on unnecessary signposting. This signposting is very important, but before sexual history, before STIs, before multiple sexual partners, all these things are sensitive. You get that? You get my point? So from here, if we'll just snatch few minutes, sweetheart, we'll be able to do that in 10 minutes. Right? Okay. Now let's see what the key says. Communication with the patient. Yes, you've got a soft spoken attire. Rapport building was fine. I would just like you to work a little on the fumbling. Avoid little fumbling. Why does it happen, Dipti? Because when we are thinking more, and the brain and the tongue, they are no corresponding to the signals. So try to make your brain go slow and tongue go faster. And this would happen when you are speaking. take a pause, take a breath in between rather than So we have to avoid these sounds of and we have to take a breath, take a pause, think about what you have to speak next and then come up with this.
Yes.
Okay, right. Okay, so right, Archana. Okay, yes, Girija, thank you very much. I tried to put her in difficulty by saying that I'm not worried about this obesity thing, and I was waiting for she calls me obese. But luckily she didn't call me obese, otherwise I would have been very angry. So Dipti, well done. You didn't call me obese, that was very good. So Greet's appropriate introduction was there, rapport building was fine. Avoiding medical jargon, that was there. And you should somewhere in between ask, like in the beginning, I said that, do I need this? So you should ask in the beginning, so may I know, did you ever try to reduce on the BMI? Did anybody talk to you about this earlier? So you'll come to know about the background of the patient as like, what is the reason she's not losing weight? Yeah? Okay, yes, Girija, she did. So information gathering, may I know more about your condition? Is it a planned pregnancy, folic acid, screening test, obtaining history pertaining to obesity, then medical, family, surgical, drug, personal, social history, and mental history is also important because as per the Green Top guideline, obesity has an increased risk of depression. You did ask me about it and I said that I'm doing very well. That was perfect. Now, patient safety, almost everything was done except the aspirin thing. So this was the only thing which was missing. But if you see the examiner's key, it is an asterisk point. So remember that if you will miss something like contact number, if you'll miss something like emphasize the importance of compliance or something, you might be able to pass. But the asterisk points, examiners are told that the asterisk points are must to be mentioned in the station because besides this, you cannot pass the station, okay? So patient safety has to be there. Remember the aspirin indications because in exam, any one of the station might require that, okay?
Yes.
Then applied clinical knowledge should inform that it's a high-risk pregnancy, folic acid, vitamin D, screening for GDM that has to be done. And now you need to remember that these medicines, they are not safe during the pregnancy. As I told you, now I'm ready to take the medicine. So beautifully handled that these are not the safe medicines. Now how the station would go. Now when we start with obesity and we come to the after information gathering before the management plan, I will tell her that what it means to you is that there can be increased sugar levels, there can be increased blood pressure. Women with this condition can have proteins in the urine, can have difficulty in sleep as well. And there can be a difficulty in labor, failure to progress. At times, it's difficult to monitor the baby's heartbeat, and the pain relief is difficult to have as well. In case of a cesarean section, there's increased chances of wound infection, developing clots in the legs and the lungs. And Elizabeth, there are chances that women with this condition, they can have an increased rate for depression after the birth of the baby as well. When we talk about the baby, women generally who have a higher BMI, the baby either can be smaller in growth than the duration of the pregnancy or can be larger in size as well. At times, they're messed up with the structural deformity that cannot be picked up on ultrasound as well. I will take you through the journey of your pregnancy, and let me tell you that it is a high-risk pregnancy and it would be dealt with a consultant-led care with a team of doctors. The dietitian would also take care of you during the situation. We will ensure that you take high-dose folic acid, and that will continue till the first 12 weeks of your pregnancy. Along with that, vitamin D would also be started, and you will be screened for the raised blood sugar levels during 24 to 28 weeks of pregnancy. Are you with me, Elizabeth? So now antenatal care is longer, so I'll take a break and check understanding, right? In this in between, you're going to tell her that at every visit, you're going to have your height to weight ratio checked again, right? And we'll again reweigh at third part of your pregnancy. Okay, so these 2 points you have to tell as per the Green Top guideline. Now, if you're not giving in this point in time aspirin, at least you have to mention that you will be started with the aspirin from 12 weeks of pregnancy until the delivery. You will be checked with your the womb size from 24 weeks through the tummy. And again, if she asks you about the drugs, you beautifully said that it's not safe. So intrapartum care, the chances of having vaginal birth is more if the weight loss is done. The team of doctors are going to take care of you, including the anesthesia doctor during the labor, and it's going to be a consultant-led care. And after the birth, you will be provided with certain medications. You beautifully discussed that it is going to be to decrease the blood loss. Now, once the baby is born, we are going to encourage you and support you for breastfeeding. We'll assess you for the blood thinners, provide you with the support. After the delivery, we are going to refer you for the weight loss plan, as it is important for your general well-being and for the future pregnancies as well, Elizabeth. Would that be okay? So now she understands that how important it is to have a healthy BMI. Therefore, you can just mentioning refer for weight loss postpartum. Now, coming back to today, as you're at 6 weeks of your pregnancy. So now tell her about the folic acid continuation, vitamin D starting off at the moment. Along with that, you have to tell her about the referral or getting appointment for the screening of the Down syndrome and the aspirin part. So these 4 things you should mention from today so that she understands that well, and fix the appointment with the consultant next appointment so that she is confident, she's comfortable in talking to you, and the ending of the station goes well. Am I clear, Dipti? Slight points are missing in between, my dear, but remember this part. The idea of making algorithm is that you should know that, you know, this, if it comes earlier, this gives a smooth flow to the station. If this effects of the obesity or effects of the spinal cord, Archana, it comes somewhere here, then your continuity is broken of the management plan. Did you people get that? That why this is at the top? Because then you move to the journey and you tell all these things to decrease these effects, right? Otherwise it becomes very difficult that you in between tell about the effects, then the continuity is broken, and then actually it becomes a little haphazard. Did you all get that? Okay. Done. Okay, any questions, please? The outline goes, one more thing I would like to tell you is that in one of the course, it was a structured discussion. And the question they asked me was that what are the antenatal risk factors and the intrapartum and the postpartum risk factors? So I divided the risks into this as well, if at all it is asked from you all, okay? So what you have to mention is that in antenatal GDM, hypertension, preeclampsia, macrosomia, sleep apnea, or undiagnosed fetal anomaly. In intrapartum, failure to progress, difficult monitoring of the heart, inadequate analgesia or emergency cesarean anesthesia risks. And in the postpartum, it's wound infection, VT, and the postnatal depression. So my point is that all these things, if at all they ask you that what are the risks in the antenatal care, or the intrapartum care, or the postpartum care, so you should be knowing that how we have to divide that if this question is asked. Am I clear, Bindu, Girija, Archana? Am I clear? That how you're going to do
about the weight loss, are we supposed to advise her weight loss when she is antenatal?
Actually, it is written in the Green Talk guideline that you refer for the weight loss, which is safe.
Okay.
Yeah, which is safe. That doesn't mean that she's going to do some crash diet. That doesn't mean that she does excessive exercise. But yes, you connect to the dietitian and you connect to the exercise specialist as well.
Okay.
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 All right. Any other question, please? Yeah, Shaheen, this is more. This is international unit is 400 international unit. Yes, according to the SIP vitamin D, it is more, my dear. In fact, I shared that question. I shared that in your group, right?
Yeah. Because we were confused during discussion.
This is vitamin D SIP. What you can do is just take my message and forward it in the main group so that everybody can see the doses. In preeclampsia, in obesity, and in the normal patients, you need to know that. But GTG doesn't say so actually. Vitamin D SIP says so. So you can just put that in the, according to the vitamin D scientific impact paper. Okay. Just forward that message in the main group, my dear. Okay. Right. Any other question, please?
Should we discuss contraception or should we just mention?
Don't discuss. Yes, don't discuss. Just say that after you deliver, you're going to discuss the suitable contraception, avoiding the combined pills. Come back to today. So mentioning that is sufficient.
Okay, and about the blood pressure and urine testing also we have to mention.
In the antenatal care, we mentioned, yes.
Thank you.
No, you're welcome, my dear. You're welcome. All right. Any other question about obesity? Would you be able to do that in time? Dipti, next time, Will it be in 10 minutes? Yeah?
Yeah, sure.
Okay, wonderful. Thank you very much. Thank you. All right, where's group A? Sarbat, Dr. Sabia?
Yes, we are here.
Okay, Claire? Obesity is
Yes.
clear?
Yeah. Obesity is already very clear.
Okay, very Dr. Sabia. Introduction, agenda, information gathering, obesity effects on the mother and the baby, antenatal, intrapartum, postpartum, and go with the same addressing concerns. And this is how we do the station. Well done. Okay. So this is going to be Liana's turn now, and we are going to do the station. Liana, hello. Yes, Dr.
Hello,
Bin.
ma'am.
How are you?
I'm nervous.
Oh, don't be nervous. Everything will be fine. Okay? Right? All right. So let's begin with the station. Yeah, I understand, Rahma. 10 minutes is a problem. And so far, nobody has been able to complete the station in 10 minutes. And that is a problem. And even the maternal medicine, the same template is. So today we are not having a template in the end because antenatal care and maternal medicine, they go with the same template, asking about the medicine and then antenatal care, intrapartum and postpartum. So next week, again, it's going to be a practice and fight against time. So I would see that how far you people go in 10 minutes time next week as well, because we are having maternal medicine on next Saturday, right? Okay, so I'm starting your 2 minutes, Liana. Please check your mic again.
Hello. Yep. Can you hear me?
Yes, I can hear you, my dear. Okay, so let's begin. Go ahead.
Next page, ma'am. Next page.
Yeah, I've changed that.
Hello, my name is Liana, one of the doctor in the antenatal clinic today. May I confirm your name and age, please?
Hi, Doctor. I'm Maria Clark. I'm 33 years.
Can I call you Maria?
Okay.
So Maria, I know that you have come here to discuss about your ultrasound report today with me today. But before we do that, is it okay if I get some of your background information about you because I haven't met you before?
That's okay, but I'm very upset, doctor. I need a healthy baby.
I see. I can see that you are very upset, and I'll surely will address all your concerns in a few minutes' time. If you allow me to ask you a few more questions, is that okay with you?
Okay.
So Maria, is this your first pregnancy?
Yeah, doctor.
So how far along are you today?
Yeah, I've just completed my 23 weeks now.
Mm-hmm. Are you taking your folic acid?
I am.
It's good to know that. Do you have how has you been in your current pregnancy currently?
everything was fine. I don't have any problem at all. And my midwife told me that when you take folic acid, the baby is actually developed normally. I was so happy with that. I didn't miss my folic acid even a single day. But now she tells me that the baby has some condition in which there's some problem with the limbs. I don't know. I mean, I'm taking folic acid, doctor.
All right, it's good that you're taking folic acid. Sometimes the abnormality that we detect is not associated whether you take or didn't take your folic acid. Can't you tell me what the sonographer have told you regarding
I'm not
the scan today?
sure. The midwife, she just told me that it's something like related to the limbs, but she said the doctor's gonna explain further.
Mm-hmm. Is that all that she said?
Yeah.
Mm-hmm. So would you like me to explain regarding that now, or do you want me to let me ask you a few more questions about yourself before
Yeah,
we
that's
formulate?
okay. You can ask questions. That's all right.
All right. So Maria, do you have any medical problem that we need to be aware of?
No, I'm fine.
Are you taking any regular medication?
I'm not taking anything at all other than folic acid.
Mm-hmm. Any surgery done before?
No surgery.
Are you aware of your height and weight ratio, Maria?
That's all right. That's 22.
Mm-hmm. Do you smoke or drink alcohol?
I do not. Specifically taking care of my baby. I've stopped it during the pregnancy.
All right. So is there any conditions that you know runs in the family?
I'm not aware of.
A little bit more about you. What do you do for a living?
I work as an engineer.
What about your partner?
Yeah, we work in the same company.
I see. So how's the support at home? Is everything okay?
It's perfect. I mean, we're looking forward to a healthy baby. In fact, he's done all the he's just shopped for all the clothings and all as well.
I see. So Maria, so now I have confirmed regarding your ultrasound report, your name and also your NHS number, and these reports shows that your baby having a talipes, or what we call as a club foot. You ever heard of it?
No, I've not. What does that mean?
Well, it is actually a birth defect that can affect one or both feet. But in your case, we notice it on the both of the feet. So it's like both feet points down and inwards with the sole of the foot facing backward. Right?
What does that mean? I mean, my baby will not be able to walk.
It's not necessarily like that, Maria. So generally, this talipes can happen by chance, and usually it's in 1 in 1,000 babies. All right. So it's nothing that you do or you do not do causing this condition. So actually, baby can deliver and can grow healthy and live a happy life if we give a full support and good treatment and we compliance to it. Do you want me to proceed with what you can expect in the future?
No, before that, tell me, doctor, because I'm in habit of wearing tight jeans. So is that because in pregnancy I had been wearing tights and jeans? So because of that, there's a pressure on the baby and the feet has turned inward?
Well, Maria, please don't blame yourself. It's not your fault. It can happen, like I said, it can happen by chance. Well, maybe for some babies, they have a normal feet, but because they a bit of squash in the womb, and if that's the case, after delivery, usually they will correct themselves by 3 months of age. But some other babies may need some additional exercise, additional treatment, and we need to refer to the physiotherapist for physio management. All right. So regarding your tight jeans, I would advise for you to maybe you can change to other loose clothing after this for your comfort.
Okay, right.
All right. So well, we're gonna talk about this talipes later, but let me walk you through your pregnancy journey if you like. Maria. So I understand that you are 23 weeks now. It's good that you continue your folic acid. So actually this condition to your baby, the telepace is it's not Liddle congenital abnormality. It means that it's not life-threatening to your babies, and your babies have a good chance of survival in the future. All right. So this condition also will not affect on how you carry the baby and how you will deliver your baby, and you can continue follow up in the midwife-led unit after this. After we get all of this clear. So Maria, regarding this telepace, so after your delivery, so we'll talk to the baby doctor to assess your baby's conditions, and usually if that's the case and confirmed, then we will refer your case to the physiotherapist, and usually the management starts within 1 to 2 weeks after birth.
What are they going to do? They're going to do some surgery on the baby's feet?
Well, that's a good question, Maria. I will explain to you the management one by one. So usually they did what they call as Ponseti method. This is just a gentle manipulation of the feet to better positioning by putting both of the feet into a cast. So this procedure will be repeated every 2 monthly. Then after the cast is off, maybe the baby will go to the minor operation to loosen the tendon at the back of their ankle. So this procedure will be done under the local anesthetic or the local numbing medication. And then the baby may be put on special boots. This is full time for about 3 months to prevent the recurrence of this therapies. So these boots will be applied to the baby up until 4 to 5 years old. All right. So usually by the good support, the good treatment, and the good compliance, it will be pain-free procedure, and the feet will be normal looking. And usually we will have a good recovery on that, because most baby usually learn to walk on their feet as in their usual age, and they can enjoy the physical activity as well. So because this condition, so after delivery, the baby will have a regular follow-up to the physiotherapist as well as the pediatrician to see how's the development and how's the babies respond to the treatment. All right. However, there is a small possibility of relapse, the recurrence of this condition, if the treatment is not followed exactly. So when this happens, some of the treatment level may need to be repeated, Maria. All right, are you with me so far?
Yeah, I am. I'm just scared that I don't want an abnormal baby. What if I just end up this pregnancy?
I can see a concern, Maria. So, like I said, Maria, this condition is not life-threatening condition, and it can be cured and managed until it's fully recovered. So, I respect your wishes. I'll like to give you a patient information leaflet after this and link you to the support group. It'd be good to talk to somebody else who having this same condition as yours. Then I will fix another appointment. Then you can come with your partner together. We can discuss on the best management option for you. If you wish for the termination of a pregnancy, then I will talk to my consultant regarding the decision of yours. How that sound?
Yeah, that's okay. Thank you, doctor.
Thank you, Maria.
Okay, thank you very much, Liana. Very well done. So at least you were on time, huh? This was a smaller station as compared to the others. Very good. Well done. So how did you do? How did you find the station?
Because I haven't practiced this session, so a lot of stuttering, a lot of so I cannot control that.
Okay, so this is the first station, which was almost better as compared to the others, Liana. So thank you very much for doing a very good station. Great going Group C. It is. I know this is a difficult station B. I mean to say, because it is difficult. I know. because when you come to a patient who knows the diagnosis earlier, handling becomes a little tougher because she's already having that in the back of mind, and from the beginning she's upset. So handling this patient is a little difficulty. Nevertheless, you did very good. So credit goes to all the practice you had been doing in the mini group, and despite all the odd timings from Malaysia, my dear. So I totally respect that.
The members of the group D is very helpful and very supportive. I'm very thankful to be in this group.
That's very good. Well done. So the credit goes to all the group people, huh? Yeah.
We have our discussions. It's really late for Liana, and she's putting her babies to sleep. And she'll literally be whispering, but somehow she'll manage to participate every day, no matter what.
I understand. This is a difficulty for all the ladies.
And we'll be like, Liana, wake up. We're discussing, we're beginning. And she'll wake up and she'll participate.
Oh, that's very good, Divya. I understand that she is having a little no difference in time, and that too, she was closest to India, so I placed her in your group, because otherwise she was having like 6 to 8 hours difference from other GMT time zones. So that was the closest where I could place her, but still there's a difficulty because there is a marked difference in the time zone. But thank you very much, Liana, for putting in your effort, my dear. You're already very good, but after discussion, the things, they definitely get polished, because the things you discuss, they ring in your ears. Yeah. So it comes into your mind that we discussed this thing and this is going to be very good. All right. So many good points were there. Your entry was very good. Your talking to the patient was very good. The way you asked me that, would you like to know about the scan first, or is it okay that I ask questions? That was perfect. That was very good. So you realize that she's upset. So whatever she wants first, you're going to put in that way. So that was very good, Liana. You did ask about the pregnancy, folic acid, medical history, about the surgical history, BMI, smoking, alcohol. You did appreciate. You did ask about the partner support and all. When we came to this, you asked me about the background, what I know about the Telepes. So as knowing about this, I was not sure about what Telepes is. So you explained that well. However, I would have a tiny suggestion of doing a little signposting. She knows that earlier, but when you realize that she doesn't know what exactly it is, then do a little signposting, right? I can see, Maria, that you're here alone today. Would you like somebody to be with you during our talk? I need to discuss something difficult with you. This would make your job easier, because see, I know this is not a life-threatening anomaly, but still it is an anomaly, right? And she doesn't have a clue what the extent is, and she does know that there's some problem with the limbs. What the problem is, she doesn't know. So you're the first one to tell her. Okay, so I would appreciate if you do a little breaking bad news signposting, a mild signposting there. Then you took her through the antenatal care interpartum. You told her about that this is not a life-threatening condition, but if she wishes to have the termination, she would be respected in her decision. That was very good point, which you did. Baby doctor is what we say to the pediatrician. Okay.
All right.
So baby doctor, you have to mention how you explained the Telepes was fine. I understood that, but have you people heard about the Pansity, as Liana mentioned? What is Pansity? Group A, Group B, Midhat?
Yes, Dr. Sidra, actually it is mentioned in the pelvic patient information leaflet. This is a small manipulation by which the baby pediatric orthopedics, they manage to manipulate and then put a cast on the foot. So that is called a Ponseti method. This is not a surgery. This is a small manipulation and then putting a cast.
So why do we call
this
it
cast will be changed every week.
Every week, yes. This cast change every week.
At the end of 8 weeks, there will be a tendon release operation by locally numbing the area.
Provided operation is required, right?
Yeah,
Yes.
very small minor
release of Achilles tendon.
Okay.
Yes.
So my question was that when I used to solve this, it didn't come in my exam, but before mine, it came like 2-3 times, and after mine, it came 2-3 times as well. Even in 2019 November, there was a touch station about Telepes as well. So did you people understand that why it's called Ponsity?
No.
It is done by us. A doctor, that his name is Ponseti. I don't know.
Love you for that. Okay. Dr. Dr. Sabia is not wrong. She's absolutely right. Sir Ignacio Ponseti. He is the name of the person who first.
Oh, I'm right. Even though I just.
He first actually learned about the Telepes. His name is Sir Ignacio Ponseti, and he's got a beautiful book on Telepes. When I used to solve that for myself, I read the first cover of his book, and he's got beautiful lines on that, and I learned it for myself because it really helps in exam. Though it didn't come in my exam, but I was praying that Telepes comes in my exam. Because Sir Ignacio Ponseti beautifully says that how you have to counsel the parents with the ultrasound findings of Telepes. And I picked it from there. Why am I giving the reference? Because this is the top cover of the Telepes Equinovarus book by Sir Ignacio Ponseti, in which he has explained everything about the Ponseti, but the starting of the book says that how IGNACIO, Ignacio, IGNA, Jyoti, IGNACIO, PONSETI, and MD is the degree, Sir Ignacio Ponseti. Okay, Jyoti got that? All right. So what he says is, this is what my way of explanation was. Again, all the credit goes to Sir Ignacio because these lines are from his book, that how he talks to the parents, right? What he says is that, I'll do the BBN, okay? The BBN part I'll do myself. That Maria, the ultrasound reveals that the baby is having a condition in which both of the feet may be pointing down or turning inwards. We call it as Telepes or club feet. Liana, I would avoid saying that he has Telepes and what does it mean. I would tell what does it mean first and then explain that this is known as Telepes or club feet. So the better way is explanation first, sweetheart, and then coming to that, okay? Now what I'm going to speak is from Sir Ignacio's line. It would be that, Liana, I would, not Liana, sorry, Maria, I would just like to tell you that parents of infants which are born with club feet, they are reassured that their baby, if otherwise are normal, when treated by the expert hands, will have normal looking feet with normal functioning for all practical purposes. Maria, the well-treated club foot is not a handicap and is fully compatible with normal and active life. How's that? This is what he has written on the top of his book. And I took these lines from there and I used this from this. Why? Because using these lines gives a perfect understanding what parents they have in mind, that the child is going to be handicapped. Or it's going to be something like we cannot treat the child individually or independently, cannot spend the life. So I took these lines from there for my explanation and I added these lines with my BBN, right? So just add, right? Yeah, in 2 sentences he says, the best part is that he says that if otherwise normal. So he clearly says that it should be isolated Telepes, right? And then he says that when treated by expert hands will have a normal looking feet with normal functioning for all practical purposes. And the well-treated club foot is not a handicap and is fully compatible with normal and active life. So these are beautifully lines I took from his book. And I always tell my students just to use these lines with the BBN because that gives a perfect understanding to the parents that what Telepes means. Okay, so just write it down with your BBN and try to rehearse that so that you can reproduce that in exam. All right. When it comes to the management, let's see. Communication with the patient and the relatives, I was very happy. Liana, you've got a very empathetic sound, and this empathy, the way you check, the way you make the patient go with you, you've got a sweet sound which is composed as well as you are empathetic to the patient as well. However, I was expecting you to do a little BBN. So whenever anomaly is there, please don't forget BBN, okay? Never go directly to the diagnosis. Please do a little breaking bad news.
I see. I just missed that because I thought the patient already knows the diagnosis. That's why.
See, when you check my background, what did I say? I just know that there's some problem with the limbs. That's it. So then it becomes a BBN. If I would be saying that, yes, I know that they're inward and, you know, they're turned and this is known as Telepes, then it was fine. Then it would have been fine, okay? Family history, surgical history, you did that. Drug history, personal, social history, the mental history, all was done with you. The information gathering goes 2 by 2, my dear. Very good. Explanation of the correct diagnosis was there. Isolated Telepes is less likely to be a defect with the baby otherwise. It's going to be a team of doctors, a baby doctor in the specialized unit dealing with the babies. There's going to be, together they're going to take care of your pregnancy. If required, you can tell about the specialist scan. If she says that, are you sure about the findings? Similarly, if there is a query about isolated telopees, you can offer a needle test. If required, why I've written here? Because there can be a station in which there's a telopees associated with any other abnormality. So if it's a combination of two, always offer the needle test or refer to FMU, they are going to offer the needle test, right? Now, if she wants termination, you cannot say no to her. You have to respect her wishes, remember, and patient information leaflet you did give. Now, applied clinical knowledge, I've written here in the slide form as well. Ponseti technique is the total thing which you have to speak up for this patient management. At times, they are linked with spina bifida, then it's a chromosomal abnormality as well. Now, remember that this club feet, they do have a recurrence in 1 in 35, right? You need to remember that there's something known as the charity steps. So you can connect them to this lady to them as well for better information and better knowledge, okay? When it comes to the telopees, please do the BBN explanation the way I've told, and then you're going to tell about the recurrence as well. You can also tell about in rare cases, it is linked up with a problem with the backbone or the spine of the baby. If at all it is there, a needle test would be there. That depends on the station. So there are two management options. You tell her that ending up of the pregnancy and continuing the pregnancy. When she thinks about the ending up of pregnancy, Liana, the terminology, sweetheart, which you were using was, it is not a life-threatening condition. What I would use is that it's a treatable condition. You get my point? Yeah, there's a difference in both. Life-threatening condition means that the baby would be like, will be born and would die. That does not necessarily mean there can be like something which is going to have. For example, there is an NCAF, it's a life-threatening, so you offer termination. But similarly, if I say that it's a cleft lip, cleft palate, or something like which I say, I won't say it's life-threatening, I would say it's a treatable condition, something for which we have a treatment for. Do you get my point? Okay, so use the terminology that, Maria, it's a treatable condition. If you want to continue your pregnancy, beautifully you said that antenatal care, it would be same as any other pregnancy. We will refer you to the specialized unit taking care of the baby, and the baby doctor will also talk to you about the situation. It doesn't affect your mode or your plan of birth. It is going to be the same as for any other woman. We will aim for the vaginal birth. If at all we have any indication for cesarean section, we'll discuss with you. You will be encouraged to breastfeed the baby, and we will discuss about your care plan after the birth, about the baby. We'll refer to the specialized doctor, and we'll do the Ponseti technique, which is a manipulative technique that corrects the club feet without any sort of a surgery. So what it contains is, it is a casting. It's a gentle plaster casting, and there are special boots for these child as well. I'm going to connect you to the specialized doctor so that you have a word with them, and we take things forward from there. In very rare cases, babies, they require surgery as well, and the specialized doctor would be in the best position to talk to you about this. I'm going to connect you to the charity steps and the National Congenital Anomaly and Rare Diseases Registration Service as well. You can talk to moms who had the babies with this condition about their experience, and you can make up your mind. Whatever you're going to decide for yourself, Maria, me and my team of doctors will support you in your decision. I would also refer you to the counselor so that you talk to them and feel better. Would that be okay? So this is how I'm going to take the station, and this is how I'm going to end the station. You did beautifully. Your information information gathering goes 2 by 2, my dear. Your communication with the patient, I will give you 1.5, cutting the point for BBN. Your patient safety goes 2 by 2, and your applied clinical knowledge goes 2 by 2 as well. A wonderfully done station, Liana, and it is generally a pass station, sweetheart. Perfect. Thank you very much.
Thank you. I love you, Ratasidra.
Love you more, my dear. Keep going, working hard, and keep it up. I know things become difficult in preparation when there's uncertainty about the dates and about the timings and all, but you given the hard work, and just take my words, it's going to be a pass attempt. Okay, right? So lots of hugs and prayers from my side. So this is the outline, dear friends, for Telepes. Please just note down this line about the Telepes which I've spoken. Go through the recording and just note down this line and just associate it with your BBN so that you can speak it up and it gives a good impression to the patient and to the examiner as well. Introduction, agenda, information gathering. BBN do that, and then antenatal, intrapartum, postpartum care. Address the concerns, follow plan, PIL and support crew, clubfoot.uk, and the steps you're going to refer to the patient so that she has a better understanding of this condition. Any question regarding station number 4, please? Yeah. I'm open to the questions. The Telepes is clear to all of you. Now, tell me that antenatal care in maternal medicine, people say that it is a long station, I understand. But the pattern is the same. I mean, anything in the world, it comes to you. For example, in year 2019, day 1 probably, hyperthyroidism came. And students did not read hyperthyroidism, it's a Graves' disease, because it was a newer station. Now, what I say is that whenever some new station comes from maternal medicine, and you don't know anything about that, but at least you know the pattern. Stick to your basics. Stick to your basic template of outline like introduction, agenda, information gathering, what it means to mom, what it means to baby, antenatal care, interpartum care, and the postnatal care. I mean, when you know these things, at least you're not blank in the station, whatsoever it is. No matter it's the worst or the most, some rare most thing in the world comes to you, at least you know the outline. So don't get disturbed, or don't lose your confidence there. Just pick up the common points and do the station. I'm sure that you won't be failing in the station if you stick to your template. Okay, if you manage the time well, and if you just do the same sequence, anything you would be doing somewhere in between, speaking up some points in between, and you're not going to fail the station. All right, okay, so this was about station number 4, and this was a Telepes. Very well done, Liana. So let's move to the station number 5, and I think we've got Dr. Sabia here. Am I right?
No, I am not here.
So Dr. Sabia is a ghost. Casper, Dr. Sabia, please, we need you here.
Okay.
Okay, there's one question from Bindu, which says, can we say it is due to position? No, Bindu, it can't be due to position. What is in your mind, like about the jeans question? Beautifully, Liana said that it's not because of wearing tight jeans, but you should wear some...
the baby's legs,
yeah.
they have kept like that, no? Like, so
sorry, couldn't hear you. Again, your voice is like dipti, far away.
Yeah. Position of the baby inside the womb.
It can be because of banding. It can be because of oligo, but it can't be because of position. What is your maybe your experience says something? Please guide us about that. Yeah.
No, maybe like the breech position or something
Okay.
Yeah.
Okay. So I think then again it would be something like which we don't know. I mean, we're not sure of that. In her case, it would be because of her. So she would be saying that is it the reason in me? So we would again be blank. So I'm a little against speaking unnecessary in a station because that puts you in difficulty. Because the next question comes for this, So I will not touch any point which would put me in difficulty in making her understand that is it the cause or is it not the cause. If specifically some cause is given to you, you should speak it up. If it's not given, then it's a little difficult to handle that situation. It starts wasting your time, Dr. Bindu. The point is this, another 30 to 40 seconds would be wasted on this point, and it doesn't give any information or a point or a score in the applied clinical knowledge. What do you say about that?
Yeah, perfect.
Yeah, agree? Okay.
Yeah, any muscular dystrophy condition associated with this?
Yeah, so it can be, if it's associated, then it can be chromosomal conditions. You're right. Okay. All right. Thank you very much. Thank you. Okay, friends. So let's begin with the station number 5. Dr. Sabia, please check your mic.
Yes.
Oh, yes. A solid yes, Dr. Sabia. Okay. Let's begin, friends. So 2 minutes starting for Dr. Sabia. Let's begin.
Yes. Next. Next. Dr. Sidra, can it be provided the high risk result? How much high risk? Or this is the this is enough?
Yeah, this is what has been provided to you. That's it.
Okay. Okay. I am Dr. Sabiha, one of the doctor in the clinic today. May I confirm your name and age?
Hi, doctor. Doctor, I'm Mrs. Margaret Herrera. I am 44 years.
Margaret, I have gathered from your GP letter that you are pregnant and you have done screening test that we call combined test, and you are here to discuss your result. Am I right?
Yeah, exactly, doctor. I'm a little scared.
I can understand your concern. Sure, I will be discussing your result and further management plan. Before that, I would like to ask few questions to know more about you. Is that okay?
Yeah, that's fine, yeah.
Can you tell me about your pregnancy, Margaret?
Yeah, the pregnancy has been going fine. I mean, we were waiting for this pregnancy for so long. And this pregnancy is actually a test tube baby. And we just planned for a law, and then we did privately this all management, and now we're just having this pregnancy. It's around 11, 12 weeks now.
And have you been pregnant before?
No, doctor, this is the first ever pregnancy, and that too after 20 years of trying.
Is there any medical condition for which you are following your GP, Margaret?
I'm otherwise fine.
Any medication are you on?
I'm just taking folic acid.
Are you aware of your blood group?
That's A positive.
Any surgery done on your tummy and down below?
No.
Margaret, is there any family? Margaret, is there any family history of genetic syndrome or any special babies?
I don't know, genetic syndromes or something like. No, doctor.
Margaret, do you smoke?
No, doctor, I'm not smoking in pregnancy.
Okay, that's good. And take alcohol or any recreational drug?
No, no, no.
Just 1 minute, this is on. What do you do, Margaret, for living?
Yeah, I am a teacher.
And what about your partner?
Yeah, he has his own business.
Is he supportive?
He is, yeah.
Okay. Margaret, in the last few weeks, have you ever been bothered by feeling depressed, down, and hopeless?
No, it's just now when the midwife, she told me that the results, they show that some abnormality is there, or there's some sort of risk to my baby. I'm just upset. Otherwise, I was very happy with the pregnancy.
Yeah, Margaret, I can understand. So, Margaret, are you alone today?
Yes, I am.
Because I'm afraid I'm giving you some lot of information and some difficult information. So if you need some support, you can call your partner or I can arrange my nurse as well for you.
Nobody
What do
can
you
come
think?
here, doctor. Please tell me, is my baby okay?
Actually, Margaret, we did a combined test, that is a screening test for Down syndrome. We do for all patients around 11 to 14 weeks. And I'm afraid the result came as high risk for the Down syndrome.
What does that mean? That my baby is having this condition? And what is that? What do you say, Down syndrome? What does that mean?
Let me explain to you. Have you ever heard about the Down's babies, or you saw Down babies?
I don't know. I'm not sure of.
Actually, Margaret, Down babies happens whenever there is an extra chromosomes. I can explain to you that the baby has 46 chromosomes, like 23 pairs of the chromosomes in the body. Half comes from the mother and half comes from the parents. Am I clear so far, Margaret?
Okay.
Actually, chromosomes are the thread-like structure that contains the genetic information from the parents.
Mm-hmm.
So usually the babies have 46 chromosomes, like 23 pairs. But in Downs, what happens by chance? There is an extra chromosome at level 21. For that reason, we call it trisomy 21 as well. Am I clear so far, Margaret?
Yeah, but I'm getting confused. I mean, if he has an extra pair, I mean, why did my baby have an extra pair?
It is not. It is by chance, Margaret. Anyone can have Down babies, but the risk increases with the increasing age.
Oh my God. What does that mean? That my babies can't live independently?
It's not like that, Margaret. Your risk is increased. It doesn't mean that your baby is Down. See, this is a screening test. Screening means that your chance is increased, you have a chance more than the other females who have the low risk. But it doesn't mean your baby is Down. There
are chances that the baby would be fine?
Yes, sure. There are more chances of your baby having fine. We have to confirm it. We have to go ahead with other tests. Will I go forward to tell you about these tests?
Okay.
Okay. First, Margaret, I want to tell you about the Down's babies. Down babies, actually, they have some, we cannot predict what will be the correct or the true situations. These babies usually have some learning difficulties, which can be mild and which can be severe. They have some typical facies. They are cheerful babies. They cry normally. They feed. Some have little problem, need support. Otherwise, they are like others. And some have some physical problems, like some have this cardiac defects, which can be corrected. Some have gut problem, which can be corrected by minor surgeries. So not all babies have, at the severe edge of the problem. Am I clear so far, Margaret?
Yeah, I'm clear. But you were saying that there's a chance that the baby is normal as well.
Yes, because this is just a screening test. So what we are going forward, we will be doing confirmative tests, diagnostic tests. We call either amniocentesis or CVS. In both of the tests, we take a sample, either a fluid around the baby or a sample of tissue from the afterbirth. Am I clear so far, Margaret?
All right, but that's safe for my baby and for my pregnancy?
Yeah, let me explain. These both tests are done in the special center, and these both tests done by the experts and experienced persons. Yes, there is a very small chance, that is 1 in 100, of having miscarriage. You can refuse to go ahead for these tests as well, Margaret.
Mm-hmm. Okay, right. So what would they tell if the baby is Down? I mean, I should end up the pregnancy?
It's your own choice, Margaret. whatever you decide, either to continue the pregnancy in order to go ahead with a difficult decision for the termination, we will support you, respect you. But before that, I'm giving you some information leaflets, and I will be giving I will be connecting you with the baby doctor to explain more about these, how these babies having life, and how they yeah, like they are going ahead with their lives. So better have this all information, and after that, whatever you decide, we will support you in your decision, Margaret.
I understand, doctor, but if I'm not ready for this needle test, I'm a little scared of that. Can I have any other test to confirm? Any blood test?
Yeah, there is one blood test, Margaret, that can be done from your blood. This is somehow new. I'm not sure whether it is available in the NHS, but sure there is a test in which we do some, because some of the cells from your babies, they are in your blood. So we can go ahead to test these blood, but still this is a screening. It will not be 100% sure. It gives you somehow more accurate 99.9%, but still you go ahead for the diagnostic test.
Okay, right, doctor. So what do you suggest for me?
I will give you leaflets information. Just discuss with your partner, and then talk to the baby doctor. I'm connecting you with the baby doctor, so that you know about how the Downs have lead their lives. After that, you can decide, because you have still time. Either you want to go ahead with the pregnancy, and or either you want to go ahead with the needle test to have a confirmatory test.
I get that, doctor. I understand that. Okay.
And I'm giving you your next appointment with my consultant, so that you can come and inform us what you are going to have.
Okay, doctor. Thank you.
Thank you.
How is it, Dr. Sabia?
I messed up all.
Okay. Today again, pauses in history were more. So I felt that, after family history, there was a pause of like 15 seconds in between each question. Okay. But that's what we are going to deal with. That's not a problem. Tell me that what good points we did. Okay. So let's start with the good points, so that, yes, Girija, Harshiba, Bindu, Depti, where is group A? Group A. Sarvat, both my Sarvats in group A. Where is Brahma, Abir? Hello, hello. I need your comments, please. Let's discuss what good points Dr. Sabia did. Okay, Girija says that you did well, Sabia. Okay, okay. Right. Okay, anybody else? What were the good points? Let's pinpoint the good points. Finished on time. Yes, Sarvataves, that was good. She finished on time. Yeah. And? Okay, Dr. Sabia, you tell me what good points we did in the station.
I think I finished on time, and not
Yes.
it's very well, and there needs some arrangement, how to
sequence, yeah, being
sequence,
structured.
yes.
Yes.
Yeah, I need to be structured only.
Yes.
For me, I feel I need to be more structured, not more. I need to be structured.
Yes, you need to be structured.
I was little disorganized.
Yes, I feel in the station that you jump from one point to the other. The sequence is lacking. This
is my conclusion as well.
Yes.
Anyway, I'll work on it, because this station is my nightmare actually. And this week I did not have much time to practice more as well. Anyway, I will do, inshallah.
But definitely the things are better. With every passing station, the things are better. Today, voice was a little more composed than the previous. There was some sort of, yes, Divya is absolutely right that your voice is assertive. And Divya, when you ask Dr. Sabia to explain something, she starts explaining like, that somebody is sitting in front of her. But today she has to understand everything. She starts explaining like that. She does that even in the ectopic. She did the same. And today she was like, no. So this is actually what you have to do. So this is how Dr. Sabia goes, because, because of experience, the teaching thing that comes into play of the role player thing, actually, that I have to tell you that this is actually how it happens. Okay. So let's see what things we have to improve. All right, friends, what things Dr. Sabia has to improve? The first thing is history taking, Dr. Sabia. That has to be a little quicker.
It was a smaller station as compared to the others, like spinal cord injury, or for that matter, the obesity station. It was a smaller station as compared to that, right?
Yeah,
So,
yeah, I know. It's
yeah,
a
so when
smaller.
it was a smaller station, even then the information gathering took longer because there were too many pauses in the information gathering. I mean, I don't want you to think for the information gathering. It should like come one after the other. Okay, it should come one after the other speedily, and try to speak more quickly so that it comes like in a sequence.
Like a
Right?
train.
Yeah.
Like a train.
Yes, like Ramya was
Train.
doing the station that time. So just do that. You do that station.
I think you should connect me with Ramya
Yeah,
so
please
that
do
I
that.
know.
Go into the main group and get Ramya and do one station, please. Just do one station like
Okay.
Ramya, so that
I will
you know,
practice some station with Ramya if Ramya don't have any objection.
no, she'll definitely do that. Ramya, please practice 2 or 3 stations with Dr. Sabia, please, so that she catches your speed and you catch her speed. So you both will come to normal. So actually, we have to fight against the time, right? Okay. So Girija, where's Ramya today? Girija, didn't find her question here. Ramya, you're
Yeah,
here?
she's listening in between. She's actually on duty.
Oh, I understand. Okay, I'll get connected to her. Okay, right. So what you have to do is that introduction was all right. You forgot today to ask me that, is it okay I call you Margaret? You forgot that, but you did introduce, you made an agenda. You started your information gathering, and you said that I have gathered here that you've been, you're here about your pregnancy, and you're here to discuss about the test results. That was all right. You came to the medical history and about the folic acid, the blood group, the surgical history, the smoking alcohol. You asked about the profession and the support. This would have been completed in 3 minutes, but still it took 4.5 minutes. That was more for this station. Okay. Then you did the breaking bad news. That was good, but a little fumbling was there. I know that you know the things. Then don't fumble in the station. Clearly say that, yes, Marjorie, I can see that you're here alone today. I need to discuss something difficult with you. Can I proceed? That's it. So don't fumble. These are the sentences which we know. We have just memorized them. So we have to speak. Yeah, we have to speak in a flow. So no fumbling in that, and no break or multiple pauses like oh in these words, because this is what we have to learn, and we have to speak it like in one flow. It should come out spontaneously. Then explanation of the downs was fine, but that again was a little slow. I mean, I will go in continuity. Explanation of the downs was about the chromosome thing came late. Then actually you told about the how you're going to confirm. And then you told about that what do they have in the facies and their abnormalities.
Actually, the patient was eager to know how it is confirmed. For that reason, he made me confused.
Oh.
He was not interested in knowing that how the downs looks and how they do.
Okay,
She is interested more in confirming the down.
Okay, I get it. Oh, actually, patient made you confused, huh? I get.
Yeah.
I get.
This is your fault.
I totally understand. I take all the responsibility, Dr. Sabia. So next time I'll try not to confuse you, but you be superb, huh? I promise. Okay. All right. So, okay. Then you did about the screening and the cell-free fetal DNA. And you did tell about the baby doctor connection. So these were all the good points which you mentioned about all the options. Now, in the points to improve, can I call you Margaret, or would that be okay that I address you as Margaret? Some line like that, as this is our fixed beginning, okay? When I said one line in the information gathering, the doctor, it's been 20 years that we had been trying to get pregnant, to have a baby, and now it was a test tube baby we had. You asked me, so are you generally fit and fine? I would have expected, I can understand your concern. I'm here to support you as a team. So anything like that, you had to say when I, gave you a feeling that it's been 20 years. At least acknowledge that, Margaret, I can see how difficult it would be. And we are here to
forget this supportive sentence.
Just cram it up. Write it down now.
Yeah,
please do that. Always see, listen to the role player. She gives you 1 or 2 opportunities to do that. See, I can understand, Margaret, how difficult it would have been for you. Me or my team of doctors are here to support you in this situation. Full stop.
Yes.
So speak it up. This is something which you have to memorize and speak it up again and again. so that you know that where we have to put this. I was waiting. I told you such a sorrowful thing that it's been 20 years and now we have a test tube baby and you say, are you generally fit and well? That means that this statement doesn't mean to you anything, like it's not important. Okay?
Yes, yes.
So
I can
now,
understand.
yeah, so now between the support and the occupation, there was a 30 seconds break. Listen to the recording. You said that, what do you do to live? I said that, yes, I work as a teacher. He said, what does your partner do? I said, he runs his own business. He said, okay. And there was like, okay, and there was a silence. We don't have much time to give multiple silence in the station. Okay, I have to work on this, that we have to be a little quick on this, okay?
Okay.
Then when you came to the BBN, the things that went fine, explanation was fine, but the sequence was a little broken. See, if I would be having there, I would say that, Margaret, I can see that you're here alone today. Do you want somebody to accompany you? I have a difficult news to discuss with you, Margaret. Margaret, the test which we have done, that reveals that you're having a high risk for the condition, we call it as Down syndrome. Have you ever heard about that before? See, Margaret, we all are made up of billions of cells and that contain thread-like structures and which are in 23 pairs of each cell. In a few of the cases, there are 21. At 21 number, there's an extra coding, an extra piece of information that is present, which makes the babies to have a different appearance, like lowering of ears, like slanting eyes, having a large tongue, some abnormalities with the heart, and some level of disability is expected as well. We call them as Down babies. Am I clear so far? So I will connect the first, starting the story with the cell and this chromosome thing, connecting that to 21 extra coding present, then connecting that to what does it mean to the baby. And again, when I would say this, there was a jargon use of cardiac defects. So that is, Dr. Sabia, what do we call? Heart.
Heart defect, yes.
Okay, so you have to say heart. And then again, when I said that, do you think that my test, if I do go for the needle test, would that be fine? You said that, yes, there are more chances that the baby would be fine. What was the thought behind that?
Because if there is 1 in 50 chance or 1 in 100, it means that the 99 babies will be okay.
But do you think that in 44 years, we should reassure that it would be fine?
But we have to tell the patient that it doesn't mean that the baby...
No, I understand. You should say that at this point in time, it's only the screening test. That means it tells us that how much is the chance of having the Down syndrome. However, when we perform the diagnostic test, that actually tells us that if the baby definitely has the condition, which screening tests have said that they might have. At this point in time, it's very difficult for me to tell you that the baby carries the condition or not. However, the needle test would be telling us in an accurate manner, Margaret, that whether the baby definitely has this condition or not. Why am I saying that, Dr. Sabia? Because even if 1 in 100 is the risk for something, what if that baby is 1 out of that 100? So avoid giving the false reassurance. Go through the recording. There was a very confident voice. Yes, the chances are that more babies would be fine.
I'm sorry.
No,
I'm thinking that I should give her some hope. I'm thinking I should give her some hope. It is 1 in 150 or 1 in 100. At 44 years.
No, I totally understand and I respect that. I love you for that. But the thing is that it takes a false reassurance for the patient. See, even
we will say that at this time it's difficult to say.
Exactly. Always be diplomatic. Always say at this point in time it's very difficult for me to tell you whether the baby carries the condition or not. However, I would suggest that we go with the diagnostic test, which will definitely tell us whether the baby does have this condition or not. How do you feel about that? Can I explain that to you?
Okay.
Right? So now explain that and take the story towards that side. But never give reassurance because that can take you towards the other side, okay? So always remember that whenever something is asked for you, don't say that a baby would be normal. Say at this point in time, it's very difficult for me to tell you the exact situation. However, after the diagnostic test, we would be in a better position to tell you if the baby carries the condition. So, of course, this can be a difficult decision that you may find you feel at times differently from one day to the next. And you can talk to your midwife, your doctor, your family, your friends, and you decide for ending up with the pregnancy, or you decide to continue with the pregnancy. Your decision would be supported. Now, in terms of the diagnostic tests which are available, you beautifully described the needle test, either taking from the afterbirth or taking the fluid around the baby, and test for the extra coding at number 21 chromosomes. Okay, so this is what you have to ask for, that these are the two things which we have to say, but be a little in a sequence. I mean, go one after the other. Try not to jump from one point to the other. Be focused in your what you have to gain from the exam scorecard. All right?
Okay.
There's one question by Dr. Bindu. If IVF, should we ask for donor egg or self? Dr. Bindu, if she doesn't mention here, I will not again open another agenda, because she's saying that it's my baby after a long time. So I will not open another agenda, because again, it would waste my time and going into another story. And they don't keep like too many things in one station. They try to be simpler or straightforward. If she asks needle test 100% accurate, what do we say? Girija, you say that the chances of having the result being interpreted in this is going to be more appropriate as in terms of the screening test. But if she say 100% accurate, this would again be in the results. You want to ask about the CVS, about the placental mosaicism. What is exactly in your point of, I mean, the back of your mind when you ask about the accuracy, sensitivity, and specificity of the test?
Yeah, the sensitivity. Is there any chance that it might not detect false negative, if any?
Yeah, the chances, of course, none of the test is 100%. So you simply say none of the test is 100%. However, it actually picks up maximum cases which are going to be there. If you want to see some percentages, this would be in the TOG article if you exactly want to be accurate in that. But what my suggestion would be, we can say it accurate for the chromosome tested. Dr. Bindu, actually what she's saying is that maybe it is missed. So it does happen, the technique does matter. At times when you're doing a CVS and you don't pick up the proper villi, it gets messed up. So the technical error is also there. So this is what she's trying to say, that if at all she says that it's 100% that it's going to pick up.
But,
so
but
you
Dr.
say
Sidra, what
yes,
I know that usually initially the test is done, that is we call DNA probing, and the result available within 2 to 3 days. And
yes,
after that, they do culture to confirm that result.
And that comes after 14 days.
Yeah, that comes after 2 to 3 weeks.
Yeah, that comes after 14 days. So first is after 48 hours and next is after 14 days. You're right. So that confirms that. But again, there can be some technical error as well. We cannot say 100%, but of course the chances are there that it would be picked up. So communication with the patient, we avoid medical jargons and try to be a little more easy towards the patient. We'll work on this, that how we have to be more in one sequence. Presenting complaint was fine. Information gathering, all the things were touched, but they were in gaps, in breaks. So patient safety BBN was done, diagnostic investigation was done, and explanation of the Downs was fine, providing the support group. This is what we have to do. Down syndrome screening test is either the biochemical test or the ultrasound or the combined test. If at all it is found to be higher in risk, then we go for the needle testing, that is the chorionic villus sampling or taking the fluid around the baby. And this is going to tell us about the Down syndrome. This is the entire applied clinical knowledge of the station. All right, the entire applied clinical knowledge of the station. This explanation about the Down syndrome that goes in the beginning, start your story from the billions of cells. And again, you said that it comes half from the mother and half from the parent. So half from the father, not parent, huh? Okay. Or you can say half from the other parent. So other parent would be fine. Otherwise, it's like father. So one thing more, Dr. Sabria, I said that, what that mean? My first question was, what that mean? Now you're going to answer again, okay? Now you've explained me the Down syndrome, and I would say, doctor, would that mean that my baby can live life independently?
What I have to say? Doctor, so what you are asking actually?
you have told me that it's a Down syndrome, and you've given me
Yes.
the explanation. So my next statement is, so doctor, would that mean that my baby won't be able to live independently?
Yeah, we cannot predict, we cannot say at this stage because
No,
there
I
is,
have always told you that whenever some question comes, how you have to start your line.
I can understand your
Thank
concern.
you very much. Thank you very much. What did you say? I've written your answer. It's not like that, Margaret. And then you started your answer. Okay. So what you have to say is, again, as you said, I understand your concern and I respect the anxiety and stress you're having at the moment, Margaret. So these are the same lines which we speak.
Yes,
Nothing different, but they make the answer so palatable towards the patient that she starts understanding. And then you can say, at the moment, we cannot predict how far the disability would be in the baby. Am I right? This is what you want to speak, right?
Yes, yes, yes.
Yes. So start your statement like, I can understand this acknowledgement I want you to inculcate in yourself. It will become your habit then, you know, that whenever some question comes, start with that. I can understand the concern. I can understand the anxiety. I can understand the stress level. So anything like that, and then come to the answer. Directly answering is a sport without acknowledgement that is not understood better towards the patient side. It's not taken positively. Am I clear?
Yeah, it's clear.
Okay, very good. Now you have to work on this. And Sarvat Awais and Rehma and Abir and my other Sarvat and Atia, please ask Dr. Sabiha again and again certain questions in which you have to say, I can understand your concern. I can understand the anxiety you're having at the moment. I can understand the stress level. However, at this point in time, Margaret, it's difficult for us to predict how far the disability would be because it is a variation in their personalities, their likes and dislikes. The chances increases to have Down syndrome as you get older, but anyone can have a baby with Down syndrome. So all these things you have to speak somewhere or the other, but acknowledge the concern. Okay, so acknowledge the concern first, and then you speak up and come with and avoid doing false reassurance. This is my tip for you, so that we work on these things, and in the next station I can analyze that we have worked on these things. Okay.
Okay,
Right?
Dr. Sidra, I have one question.
Yes, my dear.
This screening cell-free fetal DNA. So cell-free fetal DNA, as I said, yes, it's very like its results are very near to confirm 99.9, but it is still a screening test. It doesn't give you 100%
That's
diagnostic.
the reason I was talking that in group D as well. See, the patient says that I don't want a needle test. We don't have any other option. We can tell you that we have got alternative tests to these blood tests which you have had. However, again, they're going to tell us the risk and not definitely whether we have the condition or not.
Yes, this is
So
still a
this is
screening
the answer.
test.
Yes, you gave an accurate answer, but before I will just cut it short. That was a little longer. I'll cut it short that yes, we do have other options. However, again, it would be screening test that it will tell us the risk of having the condition and would not tell us definitely how far is the chance or is the condition actually there or not. So this would be the answer.
Yes, Dr. Sidra, we have to learn too much.
No, that's
Your beautiful sentences which you are saying and telling us.
No, my dear. You would be
you are trying to refine us.
No, you would be
we are crude.
100% you would be perfect, my dear, and practicing.
Inshallah, we hope so.
Liana is saying, and Dr. Bindu is saying that I've started acknowledging my patients in the clinic, you know. So somebody in the clinic says to Dr. Bindu that, would my baby be okay? So Dr. Bindu says, I can respect and I can understand your concern. Yeah, Dr. Bindu? So start practicing that, okay? So
Yes,
start
yeah, I've started that.
Yeah, so this will actually make your habit, you know, answering that, and before that acknowledgement, that's very important. So you people will do that, and that would definitely help you guys. So this is the outline, introduction, agenda, information gathering, making or breaking bad news, Down syndrome, telling about the diagnostic test detail, the pros and cons. You can take the journey through if she wants to proceed with the antenatal, interpartum, and postpartum care, addressing concerns, follow-up plan, PIL, and support group. There's a charity to contact, which is ARC. Have you heard about that? ARC? Antenatal results and choices. Okay. This is a charity. You can connect her to charity to contact, which is ARC, Antenatal Results and Choices, and also Down Syndrome Association. so that she can talk to moms. She can have an, feeling of that how they live with that, so that it will make her decision easier. So this would be last 30 seconds for her, and things would be perfect. Thank you very much, Dr. Sabia. There was an improvement from the last station.
Thank you, Dr.
Things
Sabia.
were better, but still we have got a long way to cover, and we'll do that together. No problem at all. Okay, right? Thank you very much. That's like my Dr. Sabia. Okay, so station number 6, friends.
Sorry, ma'am, one question.
Please, I'm available for the questions. Yeah.
Ma'am, when we're explaining the tests, diagnostic tests, CVS and amniocentesis to her, do we have to go into detail about sometimes we might not able to get the tissue, or we might need to repeat the test, call you again, these things?
I didn't get the question, Shiva. Come again.
Ma'am, when we're explaining to her about the amniocentesis and CVS, do we need to go into detail about how she will need to we might have to repeat the test again, or we might not be able to get enough tissue to
No, what you have to say is
evaluate
generally it is done in first attempt, one attempt. However, at times there can be a requirement of doing it repeatedly. We are going to talk to you about that. Once you agree with that, we'll discuss about all the pros and cons and detail of the procedure prior, and it is going to be after your written permission signed. So you can talk about these things if the discussion goes towards that side. Today, because I was not agreeing to that thing, so discussion didn't go on that side. If it does go on that side, you can take the discussion towards the consent side.
Okay.
Okay. All right.
Dr. Sidra, I have a question too.
Yeah.
So according to what Dr. Sabia was saying, that yes, there are more chances of the baby being actually not having the disease, not having the condition than having the condition, which is like 1 in 100 if you are explaining. So it's like 1 out of 100 will be having it. And there was a video from you in the group which said that actually. So that I was thinking after seeing the video that, oh, that's a nice way to explain. Is that not the right way then?
No, that's a separate thing. That's an explanation. I said to Dr. Sabia Jyoti, try to get this point. What did I say? That means that there is a chance that my baby would be normal. She said, yes, there are more chances the baby would be normal. So that was very reassuring sound. I respect the percentage thing she says, but reassuring that it can be like at 44 years, it can be normal.
Yeah, but that's exactly what is said in the video. So that's why I also thought that it was a good way to say that.
The video was a younger patient.
Jyoti, there was something like when she said that 1 in 40, something like that. That out of 40, 1.
Yeah, one will be not okay and the others will be okay.
Yeah, so this is not reassuring. This is fact. Saying that 39 babies would be normal and your baby would be from that 39, that is wrong.
Okay.
Explanation is absolutely fine, my dear. I respect that. But I'm saying that my baby can be out of that 140 as well, 1 in 40.
Yeah.
You get my point? Explanation is absolutely right. But don't reassure that she would be having a baby in those 39 babies. She can be, unfortunately, be having in that one baby. So don't reassure. Explanation is absolutely fine, but reassurance is something like which should not be done.
Dr. Sidra,
in the video, they reassured like that.
Yeah. She's so confused. She's so hopeless. She has IVF. So better tell her that 1 in 100 chance means 99 babies are okay. Only one baby.
And Dr. Sabia, when it becomes like 1 in 100, and that one child is unfortunately this one, then you are in a fix,
Wallahi, I was so sympathetic with her. After 20 years of trying, she has IVF, and I will not give her any reassurance.
No. Actually, this is not empathy. In exam, it's taken the other way around.
Yeah. I know. I can understand.
So what we have to do is that, we have to stay in that midway so that we don't give a false reassurance. We say that we're not in the right position to tell you at the moment. However, the needle test will tell us definitely, and we'll be in a better position to talk to you on this. So always get an escape from this situation.
But that isn't it's not a false reassurance. That's correct, isn't it?
Jyoti, you're not understanding the point, sweetheart. See?
Anything. She will think more than what it can be. I can understand.
No. My point is that 1 in 100
if something is there, and you say that, okay, there are chances that 99 babies would be fine and one won't be fine. And she says that, okay, so there is a chance that my baby would be 99. So you say the answer should be, you should say that at this point in time, it's very difficult to us to tell you whether it is, whether the baby contains the condition or not. However, the needle test would tell us. So don't give a false reassurance at this, that the more chances are that the baby would be 99. No, he can be that one single unfortunate baby as well. So
yeah, I can understand your point, Dr. Sidra.
We can't say 99.
Yeah, we can't say. Yes,
so you can say
right.
you can say that this is the general understanding of this test. However, you cannot say that the baby is 1 out of 100. This is one single baby, or the 99 would be. Where does she lie? Only we can tell her after the needle test. That's it. Okay, so just make it this habit so that you're safe in the station. All right, okay. So let's begin with the station number 6. Hello, Abir.
Yes, Dr. Sidra. It's
How
me,
are
right?
you?
I'm good. Oh.
Thank you very much, friends. So this is Abir, and from Group A, Abir is gonna present the next station.
Yeah.
Abir, you've got a very good voice, and you talk very beautifully. And I've seen you practicing in the main group as well. How had the practice been going in the mini group?
Hello. Hello, doctor.
Can you hear me?
Yes, interrupted voice a little bit. Yes, doctor.
Okay, no problem, no problem. So internet's going fine?
You can hear me well?
We can, yeah. Your voice is audible.
Okay, okay.
Okay, right. So let's start the station before your internet gets a little trouble. So let's start with station number 6, okay? So the time starts now.
Okay, doctor. Next page. Hello? Hello?
Yes, Abir, you're audible.
Yes, doctor. FSA what? Sorry?
Femur length, fetal cardiac activity.
Fetal cardiac activity. Okay, okay. Okay, doctor. Yes, doctor.
Yes, Abir, start, please.
Hello, I'm Dr. Abir. I'm one of the doctor in the clinic today. May I confirm your name and age, please?
So, hi, doctor. Doctor, I'm Monica Sanders. I'm 30 years.
How can I address you?
Monica is all right?
Okay, Monica. What I understand from the notes, you are here today to discuss your ultrasound scan. I'm correct?
Yeah, exactly, doctor. This is my first pregnancy, and I just had an ultrasound. I feel that my tummy is too bigger for this pregnancy.
Okay, I can address you, but before we go to discuss the ultrasound, may I ask you a few questions?
Okay.
Then then I want to examine you and running for you a test, and maybe we run for you another scan so that we can discuss a care plan for you. So how this sound for you?
All right.
Okay. Can you tell me more about your pregnancy?
Yeah, the pregnancy is going fine. I don't have any problem at all. I mean, I started my pregnancy. This is my first pregnancy, doctor, and I conceived it naturally. There was no issue in that. I had my initial test. They went okay. And my down screening was done. That was all right. I had my mid-pregnancy scan. That was perfect. There was no issue in that. And so far, so good. I don't have any issue at all.
Okay. So are you aware about your blood group?
A positive.
And this is a planned pregnancy?
I told you, yes.
Yes, okay. And this is the first pregnancy, as I heard from you.
Yeah.
You take folic acid in the first of the pregnancy.
Yeah.
What about your period?
What about my what?
What about your period?
They've always been normal.
Okay, and your cervical screening?
About cervical screening?
Yes.
Yeah, that's okay.
General information about you, Monica.
That's okay.
Okay, and your period is regular, and you are sure about your.
Yeah.
Okay. Have you suffered from any medical disease that you follow with a doctor?
No.
Any surgery in your tummy from down below in your womb?
No.
Any drug history or drug allergy?
No, doctor.
Are you smoke?
No, I'm not smoking in the pregnancy.
Drink alcohol?
No.
Recreational drugs?
No, doctor.
Any family history of concern you want to ask me about it?
Everything is all right.
Okay. And with whom you live?
Sorry, doctor?
With whom you live?
Yeah, I live with my partner.
And he's supportive to you?
He is, yeah.
Okay. In the presence of chaperone and after your permission, can I examine you? I want to examine your height-weight ratio. I want to examine your blood pressure, pulse rate, temperature. I want to examine your tummy and after that, we want to run for you a few blood tests to see if there is any increase in blood sugar and in your urine or your blood. So how does this sound for you?
Okay, that's okay.
Okay. According to your scan, you are 32 weeks according to your last menstrual period and according to your booking scan, but the new scan show your baby is 36. Actually, your baby, it is actually your baby is appear in ultrasound larger than usual size for expected age. You understand me?
I understand, but why is that? I mean, I'm not eating much.
Actually, it is not a matter of what you eat because this condition is related to many causes. Sometimes there is no cause at all. And sometimes there is elevated in a blood sugar, so the baby gain more weight. Sometimes due to excessive water around your baby, maybe due to wrong date, maybe due to something we call fibroid, which is an excessive growth of the muscle of your womb. So now we are running for you test and scan to see what are the cause. So it's okay for you?
I just had an ultrasound, I mean, yesterday.
Yes, okay. Now I sent for urine test and for blood test to see if there is excessive blood sugar. Otherwise, I want to if there is a blood increase in a blood sugar or there is a glucose in your urine, I will run for you a test. We call it glucose tolerance test. This is a diagnostic test that tell us if you have diabetes, so that it will be lead to your baby become bigger.
Okay, I don't have any previous history, but you can do that if you wish, though.
Sorry?
I don't have any previous history for that, doctor, but if you wish to do so, you can do that test.
Mm-hmm. Yes, there is a condition, it's appear in a pregnancy, it's called gestational diabetes. It's a condition start in a pregnancy. And during a pregnancy, there is an elevation of a blood sugar, and this is confined to pregnancy. So if it is occur, your baby become more. And through your ultrasound, we can exclude the excessive fluid around your baby. We can exclude there is an excessive growth of your womb. Just there is an increase of the size of your baby, which is equal to 4 kg. That means you have a baby a little big than the expected one in same age. This is what we call macrosomia. Have you ever been know about it or read about it? Macrosomia.
No, I don't know. But my point is that what to do about this baby? The baby's normal, right?
The baby is normal about this scan, but we want to know why your baby become big, why your baby macrosomic, because of this size, there is a little bit risk for you and risk for your baby. Because of your baby's big, there may be an delay in the labor. There may be an risk of instrumental delivery. So we want to use forceps or vacuum. There is a risk of stacking of shoulder of your baby, and this carry risk for the baby nerve or bone injury. Otherwise, we are follow you. Maybe if there is a more increase in the weight, we need to starting your labor, or we deliver you by a cesarean section to avoid the risk for you and for your baby.
I mean, now you cannot give me the artificial pains. It's going to be a cesarean section for me?
Excuse me?
It is going to be cesarean section for me?
No, it is not definitely now. It is this decision that you deliver normal or deliver by cesarean section. We discuss it after that. I cannot discuss with you the decision for the mode of delivery when you are 32 weeks. I will involve my consultant in discussion the mode of delivery for you, maybe within the next visit. We run for you another ultrasound, and we follow your baby for an increment in size.
Okay.
Okay. You have any idea about, sorry for this question, maybe too late for you, but you have any idea about your height to weight ratio at the beginning of the pregnancy?
Yeah, that was 26.
36?
26.
26, yes. Okay. Okay.
Mm-hmm.
I will give you patient information. I will give you patient information leaflets, and we arrange for another appointment with my consultant to discuss the condition.
Okay, thank you very much. Thank you.
Thank you, doctor.
All right. Yes.
You know, Dr. Sitra, I cannot find literature PIL for large for gestational age.
No problem, Abir. So how did it go? Yes, I know it was a little difficult talking about this patient, but I'm sure we are going to improve together. Yes, Abir. So what were the good points we did in the station?
I think I did not well.
No problem. No problem.
I'm mixing many points.
Mm-hmm.
I'm mixing many points with each other.
Okay, that's fine. So let's see any good thing which we did. Starting from confirming the name and the age, yeah.
Yes.
So that
3,
was,
maybe I did well.
yeah. Come on, friends, come with the good points. Okay. So other than that, if you just work a little more on your flow, your tone is good. I mean, your communication is good, but the flow is a problem. There's a little fumbling, and the points that get disappeared from your mind. That does happen. So okay, let's discuss the points which we have to improve. Yes, what are the points which you have to improve? Yes, Rehma, good start, flow and repetition. Very good, yes. Bindu says she was organized, okay. All right. Okay. So in the applied clinical knowledge, I had a little problem with the LGA. I was thinking that the history has to be a little more organized, right? So let's start with the good points. So introduction was good. Agenda making was fine. That you're here, that you have undergone an ultrasound, and we are here to discuss about that ultrasound report. Is that right? She says yes. You started with an open question. So may I know more about your pregnancy? That was a more point. I gave a star on that. You started with the blood group, and she's a primary gravida, asking about the smears and the medical history, surgical history, family history, smoking, alcohol support, and examination. You told about the large for gestational age finding. You can do a little BBN on this. A little difficult news it can be for her because she's a primary gravida. Of course, you need to discuss about the anticipated complications with this. You told about the LGA other causes like fibroid, like that of wrong dates. So that was that we can avoid that, because here in the history nothing is like that. Neither she gives any history of fibroid, nor the ultrasound tells us about any history. So we will just stick to it. We will stick to LGA. We don't require the other causes. Yes, if on examination, please note this points, friends. If on examination the symphysiofundal height is larger and we do not have a scan, then we will tell about the differential. Am I clear? We will tell about the differentials when ultrasound is not done and the examination is provided to us. That means that yes, now it is actually 4 week size, womb size is 4 weeks larger. Now we need to tell the patient that, okay, what it can be, right? What it can be. So here it is not required to give the fibroid or the other differentials because it's not required, because it's already been, the ultrasound had been done, right? Then antenatal care, you did, you took through the antenatal care journey, and you said that at 36 weeks, we are going to decide. You again said that we are going to do an ultrasound. When I said that it's done yesterday, you said, okay, then we'll take this ultrasound. You asked about the BMI in the end. That would be at the top because that's one of the reasons, one of the cause contributing factors to macrosomia or lag for gestational age as well. Now, consultant was away. Yes. So consultant is away for an emergency. So you said that my consultant is away for an emergency. I would say what? I would say that because of unavoidable.
I should apologize for her for my consultant not present, and if she want to another appointment in the presence of consultant.
So Abir, I would avoid saying that consultant is away for an emergency. I would say that consultant is not available because of some unavoidable circumstances. So I'm here to talk to you. Would that be okay that I talk to you on his or her behalf? Very good, Rahma. Unavoidable circumstances. Okay. Then I told you that it's a planned pregnancy when you asked about that. May I know more about your pregnancy? But again, after 1 minute, you asked about that. Is it a planned pregnancy? That shows to the examiner that you're not listening to the answers. You're just thinking about your template. And it happens with many students, Abir, that they keep on thinking about their template and they don't listen to the answers. If I've told you that it's a planned pregnancy, then you can skip this question from your template, that it's a planned pregnancy. Or you can say, so I've gathered it's your planned pregnancy. So that's it. So you repeated it twice, okay? Then you said that how were your periods? At 32 weeks, would it make any difference about the periods? What I would ask is that, may I know in your early scan, did it match to your dates and the baby size was appropriate according to the duration of the pregnancy? This would be my question, which would make any difference. Right? This would be the question. At 32 weeks, I'm not worried about the periods, please. Yes, at booking visit, I will ask about the periods. At 10 weeks of pregnancy, I would ask about the periods. At 12 weeks of pregnancy, I would ask about the periods. But at 32 weeks, I will just ask one question. So, Monica, may I know, your early pregnancy scan, did it match to your duration of the pregnancy with your periods at that time and the baby size was appropriate to your dates of pregnancy? She would say, yes, that's it. My job is done. So mistaken dates are over. Am I clear? Okay, so this one question you have to frame in this manner, my dear. Then I would ask in the history, did you undergo sugar test in your pregnancy? Any history of raised blood sugar family in you or the family? These things I would speak up. Why? Because these are contributory factors for LGA. I would say that, may I know about your height to weight ratio? Rather than, asking in the end, I would do that in HOPI. Then I will discuss the point of doing ultrasound again, because there's a disparity between SIP and there's a disparity between the TOG article. I'll just come to that in a bit. And when I said that it's going to be a cesarean section, what did you answer me, Abir? What was the answer?
We cannot judge now the mode of delivery because you are just 32.
And what should be the answer, Dr. Sabia?
Hello.
What should be the answer? Doctor, would it be a cesarean section?
Well, it will, you have to, like I'm giving you all the information. And I'm giving
Again, Dr. Sabia?
I can understand the concern.
Thank you very much, Jyoti.
Oh my God.
I can understand your concern. However, Monica, it's way too early to discuss about this. As soon as the pregnancy goes forward, we are going to discuss about this further. After looking at your state of your neck of the womb, we'll be in a better position to tell you whether artificial pain suits you at that time or the cesarean section. That's it. This is what you want to say, both of you, right? But the way I got the answer, Abir, was I cannot discuss with you at this moment. So don't be, whenever there's some question comes, please answer in a very polite manner so that, you get score for that. Your communication with the patient gets passed on that. So you say, I understand your concern. However, it's way too early to discuss about that. As the pregnancy moves forward and we'll have an internal assessment of the state of the neck of the womb, we'll be in a better position to tell you that what is the best choice, either giving you an artificial pains or the cesarean section. At that point in time, we'll discuss the pros and cons of each, and whatever you'll decide for yourself, we'll support you in your decision. Isn't it a better answer? Yeah? So you just have to mold yourself and come to this. I want to transform you. All right? Okay. Thank you very much. So Girija, Sarwat, Shaheen, Bindu, all of you, now you people remember, and I'm sure I'm going to make Abir and Dr. Sabia remember that as well, okay? So we are going to practice the skills of communication with the patient, all right? And we'll do that definitely, okay? So these were the points. Applied clinical knowledge was lacking. I had a lot to say in applied clinical knowledge. I'll just tell you in a bit here, okay? So the strong points of Abir is that she has got a voice which is like more or less, she has that control over her words. A flow is an issue, but when she knows something, she speaks beautifully. So what we need to do is a little more practice, Abir. So your voice is very, I would say there's a command in the voice as well. At the same time, it's composed as well. At the same time, it has empathy as well. But we have to work on our practice more so that we can polish our positives and we can just try to be better than others as well. All right? Okay. So, right, Dr. Sabia, thank you. So communication with the patients and relatives, greet, appropriate introduction, creating rapport with patient, explaining the agenda was fine. Medical jargon, there was no use. And yes, you gave me a patient information leaflet. Obtaining history pertaining to LGA, specifically about the maternal obesity, more than 30 kilogram per meter square. If she's a multipara, previous macrosomic baby, and previous or current diabetes. So all these things are important. And then you complete your other history template. So these 3 questions are only important. Yes, mistaken dates, don't forget, okay? Mistaken dates are very important as well. So ruling out diabetes is patient safety, as Abhi did about the glucose testing, she said. Implications about, again, LGA would be the same as I said earlier. I'm here with some screenshots because there's a disparity between the TOG article and the scientific impact paper. See, it says, the scientific impact paper says that estimated fetal weight with diabetes having more than 4,500, an elective cesarean section should be done. Did you people notice that? And if it's a non-diabetic, they say the cutoff of 5 kilogram. 4.5 kgs for diabetic, please remember. Why am I sharing these screenshots? Because this changes your management plan. Please have a look here. 4.5 kg for diabetic mums, it's the cutoff that you're going to go with an elective cesarean section. And 5 kilogram for other than diabetes, it's the cutoff. So she is at the moment 4 kilogram at 36 weeks. You never know that she has another gain of another few kgs, and she cuts that point where we don't have to give artificial pain. So your applied clinical knowledge should go perfect. The second important thing is that about the timing and the mode of delivery for LGA babies, clear recommendation states that elective cesarean section for diabetic mothers, that has to be there 4.5 again, and 5 for the 5 kgs for the non-diabetic. Please don't make any mistake, because there can be a situation where you're going to offer the artificial pains or the cesarean section, and you'll tell her that because of the anticipated complications, it is suggested that we perform a cesarean section for these women with this condition having a baby weight more than 5 kilogram if she's non-diabetic, or 4.5 kilogram if she's diabetic. Now, another important thing is that the TOG article says that you don't do a repetition of a scan. Please listen to me very carefully, because whatever I'm talking now, it is a disparity, so you people get confused in exam. The routine scan, it is done at 35 to 37 weeks, right? If symphysiofundal height is more. And then you repeat that at 39 to 40. The idea is that we get the last limit of the weight. Why the SIB advocates to do a repeat scan, friends? Because if at 35 weeks, it's 4 kg, and at 39, it becomes 5 kg. So now you're not going to induce her. That is the only reason. However, the TOG article says if it has been diagnosed at 36 weeks as LGA, you should not repeat a scan, and you clearly manage it as an LGA baby. So you can do a midway in exam. You would say that we might have to repeat an ultrasound to see the baby weight, which will guide us that how the plan of birth would be. Is that okay, Monica? So this is a midway. Please don't tell gestation in exam. You say, we might have to repeat. According to your examination, we might have to repeat an ultrasound again, telling us about the weight of the baby so that we can plan the birth accordingly. Would that be okay? Right? Now, another important point is that, sorry, I didn't get your question, Sarvat. Uncertainty about scan after 36 weeks. Sarvat, this is the screenshot from the SciP. Uncertainty about scan after 36 weeks means how to tell. Okay. So what you want to ask is that after 36 weeks, the scan might be uncertain? That's
yes, doctor, because it was mentioned like this, in the guidelines also.
Yes.
That 10 to 15%.
That's why I've put this SIP, which is a draft review. What you have to say is that we might have to repeat. So we might have to repeat would be that you're not repeating at the moment, you will just be discussing this. So we might have to repeat an ultrasound to see the baby weight size, and accordingly we are going to plan for the birth, and we'll discuss with you. So we might have to repeat is a safe statement, because we have to keep a balance between the TOG article and the SIP as well, right? And of course, you know that the recommendation is that induction of labor in the pregnancies that puts the macrosomic neonates. Why do we do that? Because it decreases the risk of shoulder dystocia and the fractures, right? But again, the TOG article says that induction of labor, we do that, but we are not sure about the effects and the decrease. Similarly, ultrasound at 35 to 37 we have done, right? Repeated they say at 39 to 40, as I've told you. This is only in the SIP. They again say that cesarean section is the preferred mode whenever 4 kg is estimated fetal weight is more, and IUL, it is associated with substantial reduction in shoulder dystocia and fractures. Now, one thing which I have to tell you is that 4.5 and 5 kg you have to remember, because there can be a case where they are putting you into this difficulty that you have to do check for the diabetics 4.5 and non-diabetics 5 kg. Otherwise, you'll plan the induction of labor if it is below than that. This is from the TOG article. The TOG article says that LGA at 36 weeks, if at palpation, you go with the growth chart, you do the ultrasound, including the amniotic fluid index, because there can be a coexistent polyhydramnios as well. If it's more than 90th centile, the estimated fetal weight, you will go with the checking of the glucose in the urine, as Abhi did for me. And even if the glucose tolerance test was done, we have to do that check for that if it's not done even, right? One glucose tolerance test is suggested for LGA, remember. Even the TOG article says glucose tolerance test has to be done whenever there's LGA. If it comes out to be normal, that's fine. And if it comes out to be abnormal, then we are going to take the findings of a diabetic mom for the weight, that is 4.5 kg would be the cut off for the cesarean section, remember, okay? Now this is a disparity, friends. I've taken this from the TOG article. No further scans after 36 weeks. This is what Sarvat is asking as well. This says that 36 weeks, the chances of having disparity or the findings not appropriate, that is possible. But SIP says that we should do another scan at 39 to 40, advocating the point that we can have that increase in BMI, increase in estimated fetal weight, that makes us not to choose induction of labor. So after 36 weeks, you would say in exam, we will take a midway by saying that we might have to repeat to assess for the baby weight size, right? And if the baby weight is more, we will discuss the option of cesarean section. However, we are having an option of artificial pains as well. So this applied clinical knowledge, you should be very clear. Another point which I have to discuss with you is that with a favorable cervix, they say, go with the induction of labor at 41 weeks. And with an unfavorable cervix, they say, this is for the obese mums, they say that you go for a cesarean section. So please keep that in mind as well. Now, the other point which I have to discuss the disparity is that the TOG article says 40 to 41 weeks, and the SIP says 39 to 40 weeks for induction of labor. Yes, Girija. So the common thing in both is 40 weeks. SIP says 39 to 40, and the TOG says 40 to 41. So the common is 40. So my way would be taking again the mid, where we are in the safe position. So we would say around 40 weeks, if everything goes well, around 40 weeks, we are going to assess for the state of the neck of the womb, how far it is softened and how far it is dilated. And we will discuss with you the option of artificial pains. So I'll take 40 weeks there. 40 to 41, Dr. Bindu, 40 to 41 there, and 39 to 40 in SIP. So safest is I will take 40 weeks. And what I would say is not accurately, I would say around 40 weeks. Around 40 weeks. So when you say around 40 weeks, you are safe. In exam, you're safe. So this terminology we have to pick up. Why? Because we've got a disparity. So we have to be safe in exam. All right. So around 40 weeks, we are going to discuss with you about the artificial pains, and that too, after assessing the neck of the womb state, how far it is softened and how far it is dilated. Now this is the same, sorry for being blurred. This is from the TOG article, which says the same thing, which I've told you the previous thing as well. The first and the second and the third stage management is given in the TOG article. That is, of course, these patients, they have a high risk of having shoulder dystocia, and also about the active management of third stage of labor because PPH is a risk. Okay. So Abir, how we are going to move as a story. First, again, the same pattern. See, we don't have to change the pattern. We have to move with the same pattern no matter whatsoever station comes in exam. The pattern or the outline remains the same. So no point of being disorganized in the station. The effects of loud for gestational age to the mother is you can have a longer labor, increased chances of cesarean section, increased risk of having a tear down below, increased risk of having a large blood loss after the birth. For the baby, the shoulders, they might get stuck during the delivery. There can be a fracture or some nerve damage to the baby as well. In very rare cases, there can be brain damage, even in the best care hands as well. Now, to begin with your care plan, it's going to be by team of doctors. In each visit, your blood pressure, urine test, the baby's growth, and hot sounds will be checked. Hospital birth would be planned for you. If everything goes straightforward, the artificial pains would be discussed with you around 40 weeks after assessing the state of the neck of the womb. During your labor time, we are going to have the continuous monitoring of the baby heartbeat, and once you get delivered, we will give you medicines to prevent the bleeding. After the delivery of the baby will be handed over to the baby doctor. We will encourage you to have early mobilization, and we'll assess you for the blood thinners if at all required, and encourage the breastfeeding and discuss the contraception plan with you. So this is the outline: introduction, agenda, information gathering, effects on the mother and the baby, antenatal, intrapartum, postpartum, address the concerns, follow-up plan, PIL, and support group. 3 points, I would repeat that again. About repeating an ultrasound, you would say that we might have to repeat an ultrasound to assess for the baby weight before we plan artificial pain. This is 1 point. Nobody is going to fail you if you say this in this manner, okay? We might have to repeat, and saying that to assess the baby weight size to see if artificial pains are suitable for you, or we have to claim for cesarean section. Okay, this is 1. Number 2, induction of labor, because there's a disparity. So we'll say about induction of labor around 40 weeks, so that we are safe from the SIP side as well, and we are safe from the TORC side as well. Okay, so around 40 weeks, we are going to plan for the artificial pains, and after assessing the neck of the womb state, and then we are going to talk about the pros and cons of each option with you, right? So these 2 disparities you have to remember, and don't get confused with the 2 resources available for us. Am I clear, please? If I have any question here, please, I'm here to answer.
Ma'am, I have a question.
Sure.
In this case, if the mother had been a diabetic and she's come to us at 36 weeks and her baby's weight is 4 kgs, do we tell her that we will repeat another scan? And if the baby weight, like in the situation where it remains less than 4.5 kgs, she will have a choice in choosing when she has to undergo induction of labor? Because as the pregnancy will progress, the risk of shoulder dystocia will increase.
No, my sweetheart. Then the patient will shift from LGA to the diabetic guideline, and diabetic guideline says what gestation to deliver, my dear, for a complicated delivery. 38, remember? 37 to 38 plus 6 is the complicated diabetes, remember? And 40 plus 6 for a GDM only, and that too uncomplicated, remember?
Yes.
So the patient will shift towards from LGA source to nice diabetes, sweetheart.
Okay.
Okay, right? Okay, thank you.
Ma'am, I have a question.
Sure.
So in my last exam, I have an LGA station. So in that station, the patient referred to us at 36 weeks. However, they provide us with the growth chart. In the growth chart, they noted there SFH is more than 90 centile. However, by the scan done today, the scan shows baby growing within the centile. So it's not LGA. So how do we manage this patient? Whether just reassure her and discharge, or offer a repeat scan for her?
The growth
asking about the induction of labor.
That was an SPT, right?
Yes, ma'am.
Okay. The growth scan was more than 90% in the 90th centile?
The growth scan, baby within the centile, normal growth. However, the SFH, the symphysis fundal height, is more than 90 centile. However, the pregnancy is very uneventful, BMI normal, no diabetes.
What about the ultrasound?
The ultrasound shows normal baby growth.
Only the examination was larger for this, right?
Yes, only the symphysis fundal height is larger.
Okay. So the position in the ultrasound was given like a phallic or some transverse or something like that?
It's cephalic, normal, liqua, normal. Then
was
the patient
cephalic?
anxious. Yes.
Okay. So this doesn't fit in LGA. This is only for the, that is only the increased examination, right? This is what we were talking about, that the differentials would be there. With a normal scan, what you can say is that we are going to repeat the scan in 2 to 4 weeks time. Now you can repeat that because that is the findings are. Now the fibroid, polyhydramnios, transverse lie, all these things, they come into your consideration. But if an ultrasound has ruled out everything, then you have to see that why the baby size is, the womb size is more. At times even the malpresentation that can go with this.
I see.
Yeah.
Can we mention about any discrepancy between whoever the person who measured the SFH for the lady?
No, I would like not to do that. Why? Because then it becomes undermining of your colleague.
I see.
However, Liana, if the station which I got from the students was that it was LGA diagnosed. I don't know. There's a disparity between you and Sarvat. You had the station as well, right? Sarvat?
Because I clearly
doctor. Yes, doctor.
Wasn't it LG?
Actually, it was LG on the scan on the PA finding, and when she did the scan, it was normal. No, not more than 90th centile. So it was normal, but patient concern was a midwife delivery at home. So
it
the
was
people
a home
who
delivery.
passed, home delivery. So then the past people, they told, means just only we counseled her that because of your baby is on the larger side on the examination, and the scan finding is 10 to 15% discrepancy. So on that basis, they told that you need a hospital delivery. Either in the alongside midwifery unit or in the consultant unit. So they counseled her like this.
I get that. Okay. So basically that was not about the induction of labor. You have to tell her, okay, her BMI was also higher, Girija is saying.
I think.
Girija is saying that was BMI was 31.
31.
Okay. Right. Girija, write the station completely and please send on my WhatsApp all these points, so that I can transform the station for future, right? So we'll just change that to home birth. So you're absolutely right, Sarvat. If this question comes here, you're not going to diagnose her for LGA because the ultrasound is the only diagnostic thing which we have. If ultrasound is normal, even then, because the examination is large of a size, you're going to say that after 2 to 4 weeks, we would be performing the ultrasound again. Telling about these things, mother and the baby risks would be there. Why? Because at least you would be telling about the complications anticipated so that you can at least negotiate with her to have a hospital birth. So these points you have to speak up, right? Again, you would say that if in the next ultrasound we find out that the baby estimated fetal weight that is higher for that duration of the pregnancy, we might have to consider an early artificial pain to decrease the chances of having complication in the baby. So then you would be speaking up this point. At the moment, you cannot tell this is LGA, but the chances are, so we are going to repeat a scan. So it's fine, Liana, if you say that repeating a scan, my dear. Dua, you don't have to tell the percentiles to the patient. Why would you tell that she lies? You say either the growth is in the normal, or you say that the growth is more than the duration of the pregnancy, or you say that the growth is smaller than the duration of the pregnancy. Some 90th centile was there, but some discrepancy was there, like how they are saying. Sorry, Girija, unmute yourself.
Yeah, there was something there, like something, it was normal. Maybe they are right, because even I had got confused. I initially started explaining that the baby is big, and then I saw the scan again. And I said, no, maybe it's not. There was some problem, like it was not completely LGA like how it is in this station.
So that is that if only examination is bigger. And
probably there was an SFH. SFH was more than 90th centile and the scan was normal. Probably it was that.
So that means that it's not an LGA at the moment, but yes, you're going to repeat scan to confirm that again. But the anticipated complications you can tell about the LGA to make her convinced for the hospital birth. Okay, for the hospital birth. And Dua, you don't have to mention about the centiles. You just have to say that it's more than the normal for this duration of the pregnancy. It's normal for the duration of the pregnancy, and it's less than normal for the duration of the pregnancy. That's it, Dua. Okay. Regarding the telepy station, will we repeat? Nadra, don't tell me that you're still on telepys. Regarding the telepy station, will we follow up the patient consultant unit or the midwifery? Both are possible. If otherwise she's fine and there's no complication, Isolated telepiece can be with midwifery, sweetheart. Yeah. Both are possible. It's a consultant decision because it's otherwise an uncomplicated, uncomplicated delivery. Okay.
Dr. Sidra.
Yes,
Dr.
please.
Sidra, as
Yes.
like all LGA or macrosomic babies, like in case of diabetes, or we offer induction of labor, and like in case without diabetes, we are counseling the patient that in case of the baby is large, LGA or macrosomic, whatever. So we are giving the options of induction of labor to reduce the risk of shoulder dystocia. Because what is the risk with big baby? This is shoulder dystocia.
Yes.
For the baby. This is the most like the disaster.
Yes.
So we are counseling, and even we have to counsel the patient that induction of labor does not completely finish, like completely remove the risk of having shoulder dystocia or trauma.
True.
It can reduce. So in that situation, she has to decide whether she is going ahead for induction of labor, or she might choose at 4 kg. No, I don't accept even a small risk, isn't it?
Yeah. That's why we are giving all the options. Yeah, right.
Yeah.
Yeah, we will give all the options. The one option is that it is we are going to give you artificial pains, and the other option is that you can decide for a cesarean section. In fact, we are going to offer you both these things once we examine you and we see that how the neck of the womb state is.
But ma'am, we are giving all these options at 40 weeks only, right? Not before that.
Yes.
Yeah, 40 weeks.
Yeah,
Without diabetes, 40 weeks.
Yes.
Around 39 to 40 weeks, and with diabetes, 30. We are doing induction of labor at 38 weeks. That is
complicated
according to the
diabetes.
guideline.
Yes,
According to the guideline.
Yes, as per the guideline. Very
true. Diabetes with big baby, LGA baby, macrosomic baby.
Yes, complicated diabetes. Yes. Any other question, please, from LGA?
Sidra, if patient denies for induction of labor and she said that I'll wait for my labor pain, it's expectant management like.
Can't hear you, Dipti.
One second.
If patient denies that she doesn't want induction of labor or cesarean section, that she wants to wait for her normal labor pain.
Yes. Again, you will tell about the risk factors, and you say that your option or your desire would be respected. However, the chances of the complication of baby getting stuck up, having some injury to the shoulder, fracture, or the nerve injuries is higher. We can counsel you, give pros and cons for each, and then it's going to be discussed like option.
No, when we discuss about the options of this management, do we have to tell this option also, expectant management? We'll wait for your natural pains to come.
So what you can say is that what you can say is that there are three options. Either we give you the management of waiting and watch, then it is the giving you artificial pains and the cesarean section, and we'll discuss pros and cons of each. The suggested option always is that around 40 weeks we plan for the giving the artificial pains, that too after assessing your neck of the womb state. If at all it's unfavorable, we might discuss with you the option of cesarean section, but it's way too early to discuss about that. We'll be in a better position around 40 weeks to talk to you on this. Would that be okay?
Okay, thank you.
Thank you very much, my dear. Okay. All right, Sarvat, I understand that. So hopefully now when the exam would be, you all would be passing, and we are going to cherish these stations, huh? Yeah? All right, inshallah. Thank you. Okay, so I think it's Girija's turn now. Last two stations.
Dr. Sidra, it's my turn, I think.
Devya?
Yeah.
No, yours is 8, Devya.
Yeah, mine was second last. Divya wants to finish us.
So it's Divya, it's Girija's, and then it's gonna be Divya's. Okay, so both are gonna be done quickly. Don't worry, because they both are the structured discussions, so things gonna be fine. Don't worry. Okay, so let's begin the 2 minutes for Girija. Go ahead.
Okay, next slide. Is there a next slide? Okay, next. How do we manage to read so much in 2 minutes? Ma'am, next please. The previous one, BNF. Okay. Okay, last one. Okay. Hello, I'm Dr. Girija. I'm one of the candidates and I'm ready for the discussion.
How are you doing today, Girija?
Yeah, I'm good. How are you?
Thank you very much. How had the exam been going?
Yeah, it's going good so far.
All right. So please tell me that can you summarize the case you're having?
Yeah, please, first slide. Yeah, I have my patient Mary Williams, who is 14 weeks into her first pregnancy, and she is a known case of ulcerative colitis on infliximab. So I'm here to discuss about her. She's for her booking visit now. So I'm here to discuss about her pregnancy plan, labor, and postpartum as well. So basically, in ulcerative colitis, I would like to know entire details about her condition, since when she has it and whether she has undergone any surgeries for the same, and how well controlled the disease is at present, at the time of conception as well as during pregnancy. And then I would like to move forward.
All right. So what are the effects of the condition on the mother and the baby?
Okay. So inflammatory bowel syndrome, basically it consists of the Crohn's disease and ulcerative colitis. And here in this case, it is ulcerative colitis. So this condition, if it is well controlled at the time of conception, then the outcome is generally good. But in case the patient has an active disease at the time of conception, then there can be some risks to the mother and the baby. So as far as the mother is concerned, usually if it was active at the time of conception, then there is a risk that she can have flare-ups during pregnancy as well as active disease during pregnancy. And also there is a risk of DVT in her. And as such, there can be some nutritional deficiencies like iron, folate, vitamin B12, and vitamin D in her. So we need to do the blood levels, and also she might need supplementation. And depending on what drugs she is, sometimes if she is on sulfasalazine or any similar drugs, then she could develop a folic acid deficiency. In that case, a high dose folic acid 5 milligram would be recommended. And as far as the baby is concerned, there is a risk of preterm birth for the baby, and also it is seen that there is a small risk of miscarriage and low birth weight and fetal growth restriction. And also it is important what drugs the mother is on. And in case these drugs are not safe, we need to check with the gastroenterologist, the IBD specialist, whether it is safe for her to continue the drugs, and decide on, most important is the mother's health. So we need to decide whether she would need to continue the drugs for her health. Basically, the risks and benefits have to be weighed before deciding on that.
How are you going to make an antenatal management plan for your patient, please?
Okay. So antenatal management plan would be, first of all, she needs to have a approach by the MDT management. That is, the IBD specialist doctor would be there, the gastroenterologist, then the IBD specialist nurse, the consultant obstetrician, and also the specialist midwife. And if she has had any previous surgeries, we might need to involve the colorectal surgeon as well. And we would also have the anesthetist to review her towards the end of pregnancy. And this would be a consultant-led care as it is a high-risk pregnancy. And at the first booking visit itself, we need to refer her to the specialist and review her medications to see whether we can continue them. We need to start her on high-dose folic acid, 5 milligram. And we need to assess her for any nutritional deficiencies, and we need to start her on vitamin D supplements, and as well as we might need to give her vitamin B12, iron, and folic acid supplementation. Then otherwise, the routine screening would be done for the down screening at 11 to 13 weeks, and then the anomaly scan would be done at 18 to 20 weeks. But in her case, we would need more antenatal visits and regular growth scans as well, as there is a risk of fetal growth restriction in this case. And towards the end of pregnancy at around 36 weeks, the mode of delivery would be decided. But usually a vaginal delivery can be done in these cases if there is no active anal or rectal disease. In case there is a active perianal or rectal disease, then we would need to recommend a cesarean section for her to avoid any further perineal injuries and causing an effect on the continence later. And also we need to make sure that she has a very good control of the disease throughout pregnancy. So she needs to continue her medications regularly, and we need to do a DVT risk assessment for her. And in case the risk is high according to the RCOG guideline, we might need to give her the heparin injections as well. And after the delivery, there is also a risk of perineal tears, even if we go for a vaginal delivery. Yeah, so for the intrapartum care, if we go for the vaginal delivery, then we would try and avoid giving her an episiotomy, as it could worsen her disease further. And we need to rule out all the contraindications to have a vaginal delivery in case we are recommending that. And there would be continuous electronic fetal monitoring. It would be a consultant-led care, and the specialist would be present during the time of delivery. And also hydration status should be maintained. We would avoid any triggers for having a DVT. And then postpartum, we need to advise her about the breastfeeding. There can be some issues with maintenance and initiation of breastfeeding in these patients, so adequate support should be provided to her. And as well as we need to inform her that breastfeeding is safe for her and also for the baby. In terms of the nutritional deficiencies, as far as that is concerned, still the breastfeeding would be good for the baby, and it is very important for the immunity. And contraception, as far as that is concerned, we would usually avoid estrogen containing contraceptives in order to reduce the risk of her having a DVT. And all other modes of contraception can be given to her. And also this is a chronic condition, so we need to give adequate support to her throughout pregnancy, and we should give her counseling and also help her deal with the symptoms. And if she requires any further support, we should be offering that as well.
Can you please comment on the safety of infliximab use during the pregnancy and the postpartum period?
Yeah. So infliximab is basically a biologic agent. It is a TNF alpha inhibitor. And this drug is generally considered to be safe during pregnancy and breastfeeding. But the only problem is that towards the end of pregnancy, the risk of transmission of the drug to the baby through the placenta is high. So usually it is recommended that we stop the drug at around 30 weeks in order to reduce the amount of drug that is passed to the baby, as this can cause some immunosuppression in the baby later. And in case the patient has taken the drug up to 30 weeks, we usually recommend that the baby is not given any live vaccines during the first year of birth, as it can have some major problems. And also the BNF states that if the drug has been stopped earlier, then it cannot be restarted immediately, as it, if the gap has been more than 16 weeks, as it can precipitate a hypersensitivity reaction. And in the breastfeeding period, it is completely safe to take the drug.
Okay, so what is your future pregnancy advice for your patient, please?
Yeah, so the future pregnancy advice would be to have effective contraception, to have good spacing, and also to have the disease in control by taking her medications appropriately, and preferably to start on high dose folic acid 3 months prior to conception, in case she plans on a second one. And also visiting her specialist frequently to know if there is anything that she needs to change during her course. And also postpartum also, we need to again get the IBD specialist to see her, as there is a risk of relapse that time also, and she needs to be managed that time.
Right. Anything you would like to add in any of the questions?
Okay, thankfully the time is over. Thank you.
Girija, thank you very much for a wonderful station. Beautifully done, Girija. And this BNF thing was a little tough. I mean, 5 pages were there in exam and couldn't read anything because
actually I have seen this BNF earlier in the recalls that you had sent, so I was kind of, but actually it is very difficult to read the entire thing, so you can only scan it probably in that time that
you
they
know,
have.
5 pages, and you're so scared of, you know, the time's gonna finish, and you just put your fingers and you're not reading at all. This happens actually in exam.
Still, this is okay for us because now we know that this is a station that has come, but what this is a new station and we have a new BNF, and I don't know how to read it in that time.
And so the idea is that you should have a good command on the infliximab otherwise, and you know, inflammatory bowel disease otherwise, that you should be knowing what ulcerative colitis has to be taken as how. So beautifully done, very composed voice. So it's undoubtedly a pass station. You made my job easy by
thank you.
Things easier, Girija. So keep going like this. Every station has to be a pass station, because already your level is, you know, you are already on that thing. I just need to do little polishing by these lines and little polishing on the tone. That's it, which you're learning, I know. And you keep on giving me this feedback that yes, you're working on that. That's it. That's required. You keep on going in the same pace and you'll just make this exam, all right? So don't worry about those unfortunate things which had been happening earlier, for the reason that that puts you into that difficulty that, oh my God, what's gonna happen again? So we have to think forward, okay? We have to work on those things which we didn't do earlier, and this time it's gonna be perfect, all right? Very well done. So S-bar situation, she's relatively a late booker with medical comorbidity. The background is that she's a primigravida of 14 weeks, known case of ulcerative colitis, currently on infliximab. So it's a high-risk pregnancy, needs a multidisciplinary team care. This would be your recommendation.
Okay, so here assessment and recommendation is this. Okay.
Yeah, so you have to do that. It's an MDT.
Yeah, I didn't know how to put it in S-bar, so I didn't do it actually.
Yeah, you just summarized the case. When you said they changed the slide, I realized that now you're just going to do a recap. So always remember, when summarize comes, it is going to be situation, background, assessment, and your recommendation. There's going to be an MDT assessment and MDT management. For the mother, if inactive IBD, the risk of relapse is 30% over a year, as in non-pregnant. Generally, the flare does occur, but in early pregnancy, due to discontinuation of medicine, if at all it's done. Already, if it's an active disease, then flare-up risk is there, and deep venous thrombosis is one of the risks to the mother. The fetus, if disease flares up, then there's a risk of preterm labor, low birth weight, and the side effects of the drugs are also there. Now, in the antenatal management, it has to be a multidisciplinary team, including the senior obstetrician, specialized midwife, gastroenterologist, the clinical nurse, if relevant, colorectal surgeon as well. Generally, the folic acid is taken to be 400 milligram, but if the patient is on sulfasalazine, then it's going to be 5 milligram per day. Infliximab, low risk during pregnancy, you may consider stopping around week 24 if in long-term remission patient is there, right? Generally, infliximab, you tend to stop later, but you're not going to stop in early pregnancy. It is safe starting with the pregnancy. You don't have to stop that, okay? You will continue the maintenance medications to keep the disease under control. Smoking and alcohol, if it's being done, you're going to avoid that because smoking can flare one of the type of IBTs, that is Crohn's disease, not ulcerative colitis. Now, the risk of venous thromboembolism, she's going to be assessed by the scoring of venous thromboembolism, and review by the gastroenterologist has to be done within 3 months and few weeks before delivery and shortly after delivery as well. So the TOG article says 3 times at least gastroenterologist has to review the patient. Now, during the antenatal management, I will ensure that the patient knows about the flare of the inflammatory bowel disease symptoms, that's diarrhea, abdominal pain, or the rectal bleeding. During her antenatal period, ultrasonography would be done, including the dating scan, the anomaly scan, and the growth scans, specifically in active disease, steroids, and TAC release. So growth scans, friends, we do not do in all IBTs. Did you all note this point? We don't have to do growth scans in all patients of ulcerative colitis. Remember, the TOG article says the ones who are having active disease, the ones who are taking steroids, please, and the ones who have tacrolimus as a medication being given to them. You don't have to do growth scan in all patients of IBD. That's a point you need to note, and I'll be coming up with the screenshot of the TOG article from where they've taken this point, okay? Because this question they categorically ask you. So the clinical features, this is TOG article year 2016, inflammatory bowel disease in pregnancy, friends, that says that clinical features are cramping mid or lower abdominal pain, diarrhea, urgency of defecation, aphthous ulcers, the passage of blood in the mucus per rectum. The complications and the extraintestinal manifestations, just give a read because they can change. The topic is favorite. They can simply change some of the questions, and you should be knowing that these tables are very important. The risk factors for IBD is that it can be genetic, gut immune system, gut microbiota, and environmental factors can also be there. As I've told you, that cigarette smoking, that precipitates Crohn's disease. Some medications like NSAIDs, some antibiotics, stress, and depression, that also puts a risk towards IBD. This is what I wanted to talk to all of you. Monitoring of fetal growth is suggested in women with IBD who have active disease during pregnancy and in those on steroids and calcineurin inhibitors. Am I clear? Because these 3 points make the baby have the low birth weight. So other than that, fetal growth is not suggested in all cases. Please keep a note of that. So please gladly tell the examiner that you have read the TOG article year 2016, which says that monitoring of fetal growth, it is suggested with women with IBD who have active disease during pregnancy, in those with steroids and calcineurin inhibitors. Interpartum, again, it has to be MDT, aiming for the vaginal delivery. Cesarean section only for medical reason. If on steroids, give stress dose in labor, because we know that it's going to be the break of the steroids that can put the patient under risk. Girija, you said something about episiotomy. Does it go only for Crohn's or does it go for ulcerative colitis as well?
Mostly for Crohn's, I think. Only
Yes,
for Crohn's.
that's only for Crohn's. Why? Because the Crohn's that has that abscess draining sinuses down. Ulcerative colitis restricts to the gut, to the bowel. So now the patient is having ulcerative colitis. So out of IBT, you have to pinpoint your management plan towards ulcerative colitis. Do you get my point? When you said that we are going to avoid episiotomy, I got the point that you're taking this towards Crohn's. You have to take out of IBT. Yes, IBT is a combination of ulcerative colitis and Crohn's, but this patient is diagnosed with ulcerative colitis. So you have to direct your applied clinical knowledge towards that, right? In postpartum, the risk of the flare-up for ulcerative colitis is more. Breastfeeding, all the drugs are safe except if on prednisolone. For that, we have to wait for 4 hours after taking medicine. And mesalazine, bloody diarrhea, has been reported in a few cases. So continuing of the medications after discussion with gastroenterologist would be there, and the metronidazole and ciprofloxacin should be avoided for such cases. Follow-up in the IBD clinic is in 6 weeks' time as per the TOG article. Please don't forget. Now, this is the TOG article 2016 inflammatory bowel disease. It was very small to pick up this infliximab. So what did I do? I just zoomed it up with a click, and it is going to be just this part, that biologics, infliximab, and adalimumab. The first thing you need to know is that this is the category B. This, they say, that use during pregnancy is possible. Now, Harshiba, note down, my dear, that it's possible to use infliximab during pregnancy, okay? So we are not worried about its safety in the pregnancy. The talk article clearly says, I've taken it from this, friends, okay? I've just made a zoom up of this part that shows that we can use infliximab, that's possible. In the breastfeeding, they say it's unclear. However, the benefits likely to outweigh the risk. And there's no association with miscarriage, preterm delivery, stillbirth, low birth weight, congenital malformations, or infections. However, this is what clearly Girija said as well, discontinued therapy by early 3rd trimester. Now, again, we have got disparity here, but there's not much change. Biologics talk article that says 26 weeks. The talk article somewhere in between says 28 to 30 weeks in different lines. So we have to again be on midway. Early 3rd trimester is the safe terminology which you can use, which is used here, because this categorically examiner asks you, when are you going to stop the infliximab? So early 3rd trimester is the safest thing which you people can use for the examination. This table I've taken from the biologics in pregnancy. Right? This is a different talk article than that of IBT. And they clearly says that in mid-trimester or 3rd trimester, the active transplacental transfer of anti-TNF agents puts the neonate into immune suppression. Why am I highlighting? Because from this part, they made the structured discussion. So you should be very clear that from where they're picking up the questions, and you should be very sound in your information that yes, infliximab can be used in pregnancy, but in the end, just in the late mid-trimester or the early 3rd trimester, it should be stopped because it causes immunosuppression. So the pre-pregnancy advice, you would say MDT, mycophenolate or methotrexate, if at all it's being taken for this condition, that would be stopped 3 months prior to getting pregnant. Women should be encouraged to stop smoking, preferably to conceive in the remission phase, and she should maintain a healthy lifestyle. So all these are the pre-pregnancy advice for a patient who did IBT. A very well done station, my dear. Just a few points you can add in your template. I solved the station so that you people know that actually where they're taking the questions from, what are the important areas we should be having a sound knowledge about infliximab, what tables part we need to memorize so that we are confident in answering the examiner in the exam. It's not a trouble to do the structured discussion. Okay, hats off, Girija. Well done. It was a past station, my dear. Any questions regarding structured discussion, please? Thank you very much.
Yes, ma'am.
Yes, please, Harshiba. Yeah.
Ma'am, firstly, I want to ask whether we have to read those pages of information on the drug, or are they just like given
no,
to
actually,
confuse?
you know, what happened was that in one of the page in exam, it was written that it would be stopped at 28 weeks. And I did not revise this talk article like recently in the going to exam. So I remember that I was, thank you very much, Girija. You would be absolutely fine, my dear. You'll be better than me. That's not a problem, inshallah. Just keep on practicing, sweetheart. So Harshiba, I remember he was a very good examiner. And I knew that examiner because I had him in one of the course in Nottingham as well. So when I went into the cubicle and I was looking at him, oh, okay. So he's the same examiner who did the Nottingham course with me as well. So I was very confident. I was like, okay, I had a breath there. So I knew that he's a nice person. When he came to the stopping drug, and I was confused that when do we have to stop, because I didn't revise this talk article the way I've deeply read it for you guys. So he put his finger on one line and he said that when do you want to stop the infliximab? And I was like, oh, and I was just scanning that somewhere in the BNF, it's written, he just put his finger on the postpartum part and it was written there 28 weeks. I said, yeah, it's going to be stopped at 28 weeks. And I had a little smile on my face. So he helped me with that, you know, it's all written. If you're able to be composed, actually, I was late from the previous cubicle, so I couldn't read this completely, but I didn't show insight. I was very confident, didn't lose my confidence. But if you're able to read these 3-4 pages, and that too in a state of mind that you're getting the words, then of course the information is there. The only problem is that we're not getting the words at that time.
Yeah.
You know, you see 4 pages and you're lost. What I was doing was I just scanned the first and then I scanned the second and the fourth and then came to the third and I was like, what am I doing? I don't know what's written inside. And when I went inside, it was also on your table. So kind enough for the examiner, he just guided me that, yeah, so all the headings he was asking from the BNF. So if you get confused in exam, don't worry. Just look at the page because the headings were there. you just be in your composed and be in your senses, and you know that helps you. So just see that postpartum care, they're asking for postpartum is in front of you, antenatal is in front of you. But the only thing is that eyes and the tongue, they don't work together like you're seeing and you're reading, and you know that's a difficult time. But nevertheless, examiners, they're good. I mean, they take care of you, that it's a nervous time, so it's time of stress. So if you are able to read that, my suggestion is put your finger and you start reading the 1 page, 2 page, even if the bell rings, it's okay. So at least 2 pages, you know. Taking look on 4 pages and not knowing even a word out of 4 pages, that puts you in difficulty. This is what maximum people they do. So completing 4 pages and not reading even a single line. So read 2 pages. So even if you get like 1 minute more, you take inside, because it's a tiny structured discussion. You say inside, like, can I complete my station reading? So he says yes. So you read 3rd and 4th, provided you are composed.
In that state of mind.
Yeah,
Ma'am, I didn't understand what to say in assessment in SBAR. In recommendation, you will say that we'll do NDT and it's a high pregnancy, high risk pregnancy. But what will we do in assessment?
We are going to examine the patient. You just say, we're going to examine the patient and assess what is the state at the moment. My recommendation would be, that's it.
Okay.
So you just speak in this manner. Assessment always is your physical examination, or if at all some investigations are required, because it's not a preterm case. So at this moment we don't require any investigation which is going to change my diagnosis or my management plan, basically. Yeah.
Okay. And one more question, ma'am. In infliximab, when we are stopping the drug in early 3rd trimester, we are advising the neonate for live vaccinations, or then also we are not advising, because in certain cases we do have to give infliximab if it is an active disease. It says somewhere in the talk that we don't stop in case the disease flares up.
Okay, the first thing is that you don't have to stop on your own, right? You're going to refer to the gastroenterologist, and he is going to stop or replace or restart, whatever is the decision regarding infliximab. It's not your decision. So in exam, you're going to say that it is suggested to stop it at 28 to 30 weeks. However, that is going to be a decision taken by the gastroenterologist. So we are going to refer to the gastroenterologist, so that if there's some exchange drug required, to a replacement is required. So, you know, the gastroenterologist can do that rather than expecting a flare. And second thing is that it says that avoid live vaccines in the baby.
So even if it is stopped at 30 weeks, we will avoid.
That too, you would say that we will document in the notes that it is stopped at 30 weeks, and the neonatologist would decide for whether live vaccines have to be given. It is suggested to avoid for the live vaccine. So risk versus benefit would be assessed by the neonatologist and decided for the baby. So these are the safest sentences for exam. Everybody has his or her own job to do.
Talk says, it says that if the disease is severe and we have to continue with the infliximab and all, in that case, we'll have to remember to avoid the live vaccines. Not if we stop at 30.
Okay.
So Divya, what you are saying is that we will give the live vaccines?
Yes, that's what it says.
I respect that. My point is that why to say that we will give or we will not give. We would say that we will stop this, and the decision of giving live vaccines would be taken by the neonatologist as per the risks and versus benefit for the patient.
Okay, ma'am, got it. Thank you.
This is safest what you can speak in the exam.
Yes, ma'am.
All right. Okay. All right. So we've heard Divya's voice, and Divya is drained like anything, huh? Yeah, Divya?
Totally.
And I hope today daughter is settled, because you've got last station today, yeah?
No, YouTube.
No worries. So are we done with IBT? Let's begin with the last station, and 2 minutes for Divya's choice now. Go ahead, Divya. Good luck.
Good luck. Thank you. Can't see it. Okay. Next, Dr. Sidra. Hello, I'm Dr. Divya. I'm the registrar in the clinic today.
All right, Divya. So how's the exam going?
The exam's going fine so far, doctor. Thank you so much.
All right. So can you please tell me the risk factors of your patient?
Yes, the patient is in, first is her age factor. She's 40 years old and she's had one previous miscarriage in the first trimester. She's also had large lobe excision of the transmission zone twice for CIN. She's a smoker. She smokes more than 10 cigarettes per day. She's around 20 cigarettes per day. And she has a family history of preeclampsias.
All right. Okay. So what are the indications of history-based cerclage, please?
So there are two main indications for history-based cerclage. One is more than 3 first trimester losses or 1 second trimester miscarriages. However, we can give a history-based cerclage if this is present along with other risk factors like cone biopsy or LEDs or any other damage to the cervix or preterm labor or previous PPROM.
What I get from your answer is that if it's going to be a cone sampling, then it's going to be a history-based cerclage?
No, if the patient also has a history of previous 3 miscarriages in the first trimester or a second trimester miscarriage, then it will be an indication for a history-based cerclage. Okay. And also, she's had LEDs twice here. So I would like to know how much of her cervical tissue has been removed. And that itself would be an indication for history-based cerclage in this case.
So if 2 LEDs have been done, there's going to be a history-based cerclage?
No, not, but in this patient, yes.
All right. So what is the criteria for ultrasound-based cerclage then?
So for the criteria for ultrasound-based cerclage is, it's usually done between 12 to 24 weeks. And if the cervical length is 25 mm or less, and the patient has other risk factors, that would be an indication for ultrasound-based cerclage.
Okay, so what is the indication for the rescue cerclage? When do you apply that?
Is when the patient presents to you with threatened preterm labor. If she's presents with threatened with preterm labor, she's got contractions, not contractions. I'm sorry. If the cervical effacement is there and pulsing membranes, then we would perform a rescue cerclage, and the ours is open.
Any contraindication to that?
Yes, rescue cerclage is contraindicated in the presence of contractions, bleeding per vaginum, if there are signs of or if there's any lethal fistula only, then rescue cerclage would not be performed. Also, if the patient is in established preterm labor where the cervix is more than 4 centimeters dilated, I would perform rescue cerclage.
All right, so can you take me through the antenatal care of your patient?
Yes, this patient, I would start off with, I'll put her on aspirin at 12 weeks because she's at high risk for preeclampsia. Also, she has around, she's at high risk for VTE as well. So I'll also put her on heparin earlier on in the pregnancy. I'll start monitoring her very closely from 12 weeks cervical length. I will do serial ultrasound and keep monitoring cervical length. If and when it comes to 65, then I would perform a cervical length cerclage. I would also like to know how much of the if more than 10 mm has been removed and the cervix is less, then I would go in with cerclage with might be or trans-abdominal. In this case, I think she might have to go in for a trans-abdominal cerclage because of the history. So trans-abdominal, we might have to do it earlier on in the pregnancy. And there are two ways. You can either do it trans-abdominal laparoscopic or through laparotomy. And from 28 weeks, I'll do serial ultrasounds for the baby to make sure that, to check up on the weight of the baby. And if she doesn't go into spontaneous labor, because I would go in for a trans-abdominal encerclage, I would like to take her up for cesarean section and leave the stitch in situ. I'll also remember to keep her on heparin.
What made you decide to choose the trans-abdominal cerclage for her?
Yes, she's got LEDs done twice. That would indicate a shorter cervix, probably. So if the cervix is very short, that is when I would be going for a trans-abdominal encerclage. If the cervical length is appropriate and it's not very short, and if vaginal encerclage is possible, I would always go for that.
So do you have any role of progesterone in the management of such patient?
No, there's no role for progesterone in the management.
Okay, so can you tell me about the contraindications of the cervical cerclage?
Contraindications of cervical encerclage is if the patient is in established labor, if there are contractions, if there's any bleeding through the vagina, if there are any signs of infection like chorioamnionitis, like if there's any fever or if there's any vaginal discharge, or if there's any foul smelling discharge, if the WBC counts are elevated, if the CRP is also abnormal, or if there's a lethal anomaly in the baby, or if it's a dead baby, then there's no point in doing a cervical encerclage.
Okay. Anything you would like to add in any of the question, please?
No, Dr. Sidra.
Okay, you've got 1 minute. Anything in any of the question? Think again.
I would also advise her to stop smoking. I'll offer her services to stop smoking earlier on in the pregnancy, in the first visit itself. And I'll try to convince her, because it itself will contribute to preterm labor and miscarriages here.
This is a tough time when the structured discussion is over and the time is still you're waiting, sitting, huh?
It means I'm not clearing the station. You will not believe me. I did not prepare the station. I had every other station written down, and I was just calling it. Like, what station is left? It's like, X is left.
Harshiba, you people didn't do the station?
Actually, they did, but that day I wasn't involved in that.
Ah, okay, okay. So one thing, I didn't know that, see, and still you got that station. This was tough, actually. All right, okay. So last 5 seconds, and I think now the bell is ringing. So Abir is saying you can do LG, no problem.
Of the other stations today. But that's okay.
All right. No, I understand. This is how we learn. Actually, I understood like the definition you were giving about the history-based cerclage. I understood that you don't know. I mean, you're not prepared well because of these definitions and all, because it was in the table. So nothing to worry. We're gonna do that together. So risk factors, you were absolutely right in telling that it's LITS, the previous first trimester miscarriage she had. She's a smoker. Her age is 40 years, and she has a family history of preeclampsia. So this question goes fine. In history-based cerclage, there was a little problem. You see, the history-based cerclage is only one. That is, with that 3 or more previous preterm births or second trimester losses. When you were saying that first trimester or second trimester, I was asking again. I mean, again, tell me please what histories. You said first trimester or second trimester 3 loss.
I literally have I just went through the talk like 10 minutes earlier, this thing, and I didn't really give it a proper read, so.
I understand. Okay, we'll do it together. See, the indication of history-based cerclage is that history-indicated cerclage is offered to women with 3 or more previous preterm births or the second trimester. We are not worried about the first trimester for the history-based cerclage. We are worried about the second trimester or the preterm births, right? Remember that whenever there are less than 3 previous preterm births or less than 3 second trimester losses, now we do not perform the history-based cerclage. You need to remember that. All right. So this is one thing, that history-based cerclage is only this. Now, the criteria for ultrasound-based cerclage is that women has a history of at least one, can be more, but at least one spontaneous mid-trimester losses or the preterm birth. Now, once one spontaneous mid-trimester loss of the preterm birth is there, you do make her undergo the ultrasound surveillance. Now, if this surveillance says that the cervix is less than 25 mm at gestation, less than 24 weeks, this is very important, Divya, that you have to tell me that less than 25 mm, less than 24 weeks, then it is going to be an indication of ultrasound-based cerclage. So at least one history that advocates you to put her on the cervical screening surveillance on the ultrasonography. Now on that, if it's less than 25 mm and less than 24 weeks, then it means that it's going to be an ultrasound-based cerclage. Similarly, you should be knowing that if they give you a case of a funneling, right? So that does not mean, if cervical shortening is not there, only funneling is there, that does not tell you that it is an indication for the ultrasound indicated cerclage. All right. So ultrasound indicated, again, history indicated, only 3 histories that have to be there. First trimester, no. Second trimester or the preterm, right? Similarly, for the ultrasound based cerclage, you have to say that it's going to be at least one history and less than 25 mm of cervical length and less than 24 weeks. You say that it's ultrasound based cerclage. Now, at times, remember that cervix, you're doing the ultrasound for some other reason, and you find out that it's incidentally less than 25 mm for a singleton pregnancy, and no history is there. So she does not fulfill the criteria for the ultrasound-based cerclage, remember. I repeat that again. At least one history is mandatory, and ultrasound cervical length less than 25 mm, less than 24 weeks has to be there. If history is not there, only cervical length is decreased, it is not an indication for an ultrasound-based cerclage. Am I clear? These concepts you have to be very sure of in exams.
So in this patient, even if the ultrasound shows a reduced length, but there's no history of previous, like this patient has none of the histories, so cervical encerclage is not recommended.
If her second trimester miscarriage is there or the preterm birth is there, it's going to be there. If no preterm birth is there, if no second trimester miscarriage is there, you're not going to do that. She has first trimester miscarriage, right? She has first trimester miscarriage. Am I right? So you just need to see a second trimester loss. It has to be there. All right. Now previous two, I'm coming to the let's point. I'm coming to the let's point, right? Okay. Now, another important thing which you have to tell about these low risk, mid, intermediate risk and high risk, I'll just show you that what about the LETs they have to say. About the rescue cerclage, you need to remember this is a rescue suture which is given when basically the dilatation is there, but it has to be less than 4 centimeter, you correctly said. So this is actually known as rescue cerclage because patient is going into labor and she's going into established labor. So you're trying to rescue by putting a stitch. So it is an emergency procedure rather than an elective procedure. Okay, so it does say that it can delay a birth by 5 weeks time, 5 weeks time. But advanced dilatation of cervix more than 4 centimeter or the membranes are having a bulge, then it is associated with higher risk of failure because the cerclage might not be protective in that case. Now, in antenatal care, what you have to know is that you should be knowing the role of the history or the ultrasound indicated cerclage, specifically in women who have some sort of anomalies or previous cervical surgery. Please have a note, Divya. The role of the history or ultrasound indicated cerclage is uncertain in other high-risk groups like women with having some abnormal and Müllerian anomalies, or previous cervical surgery, cone biopsy, or large loop excision of transformation zone, or destructive procedures such as laser ablation, diathermy, or multiple dilatation and evacuation. So we have to individualize these patients and not as a rule it is going to be indicated. Am I clear? when you said that in cone biopsy, we are going to give a cerclage, so that point I asked again. So cone biopsy advocates to do an ultrasound surveillance. It is not an indication for a cerclage directly on the basis of history. Clear, everyone? Okay, it's uncertain, the recommendation says. Now, we've got high-risk patients, intermediate and low-risk patients. High-risk patients are the ones who had a previous preterm birth or some mid-trimester loss. We say it between 16 to 34 weeks. That means what? That they have chances again to have this. So what do? We tell them that you had a previous preterm labor or rupture of membranes, or there was a previous use of cervical cerclage. Again, you have gone through there was a failure of a cervical cerclage, or there's some sort of surgery on the uterus or the cervix for that of trachelectomy or CS cervix, unfortunate, right? You need to tell her that these are the patients which we need to do the surveillance for the transvaginal cervical scanning. Remember, 2 to 4 weeks. 2 to 4 weeks, we have to do screening for them on ultrasound basis. I would repeat that again. Patients who do not fulfill the criteria, like this patient who does not fulfill the criteria for the history-based cerclage, what are we going to do? We are going to do 2 to 4 weekly cervical surveillance through TVS, doing the measurement of the cervical length. This is what is indicated. Why? Because these are high-risk patients to have the loss, mid-trimester loss again. The question is that would you put a cerclage? The answer is no. They're going to be put on surveillance for the cervix length, the cervical length, and that is going to be decided on the basis of their high-risk history and of the cervical surveillance if at all cerclage is required. If not, only surveillance is done for these patients. Remember, your patient, Divya, comes in intermediate risk. What does that mean? If the patient has a previous delivery by cesarean section at full dilatation, there can be one risk, intermediate risk. And this patient, history of significant cervical excisional event, that is LETS had been done, specifically if more than 10 mm depth is removed, or she fits into this criteria, more than one LETS procedure is carried, or cone biopsy is carried. Now tell me that this patient, is she a candidate for the cervical cerclage direct? Bindu, is she a candidate of cervical cerclage direct?
No, she's not.
Okay, so what are we going to do for this patient? Because now this patient is the case which we are discussing.
Refer her to the preterm birth prevention clinic at 10 weeks.
Okay, so what are we going to do for this again? It is going to be again a scan. A transvaginal scan between 18 to 22 weeks as a minimum. A minimum single scan we would do. This is one thing which you should be very sure of. That minimum one scan we would do. Yes, if you're going to have the decrease in the cervical length, then it is going to be an indication of a cerclage. So you have to be very clear. History-based cerclage and ultrasound-based cerclage. So if more than one LETS is being done, you will do at least one scan to check for the cervical length. Yes, if its cervical length is decreased, you will choose for the cerclage, but not directly with the history. Okay, not directly with the history. This is one point where there was a little confusion. Now, antenatal care, you would say that it's a consensus of the experts from UK Preterm Clinical Network. They've recommended that with a history of significant cervical excisional surgery, that is LETS, one LETS with more than 10 mm excision or more than one LETS procedure or a cone biopsy. I repeat that again, cone biopsy, please don't confuse. Having a cone biopsy does not make her eligible for a history-based cerclage. Please don't forget that, okay? And a scan has to be done for all these three patients. LETS were more than 10 mm excised, more than one LETS done, or previous cone done. This makes her eligible to do a transvaginal cervical scan between 18 to 22 weeks, at least one scan, right? And otherwise, if they ask you that how frequent do you need to repeat, you say 2 to 4 weekly. It can be done between 16 and 24 weeks of gestation for the patients who have Müllerian anomalies in the uterus, we find out. Divya was absolutely right in the progesterone. Routine use of progesterone supplementation following cerclage is not recommended. Even before that, it's not recommended. So this is something if the patient is not in labor, in the preterm labor, there's no role of giving prophylactic progesterone, okay? The contraindications, again, she was fine in this question. It was fine that active preterm labor, clinical evidence of chorioamnionitis, having a vaginal bleed, having a rupture of membranes, fetal compromise, lethal fetal defect, or the fetal is dead. Yes, it is intermediate. Yes, Liana, it is an intermediate in the guideline. Yes, my dear, please.
Why did you ask this question twice? I feel like this was like asked again, right?
No, actually, you were not speaking for the previous question, so I said that maybe you want to add something when I wanted you to speak more on this ultrasound-based cerclage, or so I asked that when you're not going to put this. So that was the reason. So I wanted you to speak a little more with these questions, because I was asking questions and I was getting one-liner answers. So I wanted you to speak more like, remember Dr. Bindu speaking in the structured discussion? Yes, I have.
Gold standard of structured discussions, that was.
So, okay, next time, Devya, we'll do another structured discussion, okay? Yes. Because I feel that you're good in SPTs, but you need a little more practice for ST.
My first structured discussion, even in the groups, I take the SPTs.
Yeah, that's fine. All right. Yes, Liana, I would just show you here, my dear.
Ma'am, trachelectomy is a high risk, no?
Yes, trachelectomy, history of trachelectomy, that goes into the high risk. Where is Liana? Liana, see, please. Okay, that goes in the high risk. As per the this recent.
Ma'am, in these patients, do we have to, after 24 weeks?
Yeah, Girija, this is, I've posted the draft, which is this Green Top guideline had to be published in March. They placed its draft, and because of COVID reason, it's not been published. The draft is there on the RCOG website, Girija. I posted that in your main group as well. Yes, that's a new GTG. Yes, Girija, that's why I've made a station, because the chances are that this would come in exam, because they published in year 2020, and I have placed that in your main group, Girija, it's there, okay? So the tables are very important from this guideline. Yes, please, yeah.
Ma'am, I was saying that in intermediate risk cases, one minimum scan is required. So if the patient comes to be like normal cervical length at 22 weeks, we will repeat one scan after 2 weeks, right?
Yeah, 2 to 4 weeks, they say, yeah.
And then we'll stop surveillance after 24 weeks. We're going to stop surveillance.
Yes, we are going to stop that, because if till then the cervical length is fine, so it's a probable option is that it's going to be fine further as well. Yes.
Okay, okay, ma'am. Okay. And ma'am, one more thing, we will not do any sampling in these like high vaginal swabs in these patients, is it?
No, nothing. No, nothing. It's not required. What's the indication behind that?
Because if a patient is posted for cerclage per se, if the cervical length does come out to be shorter, will we do a pre-op a high vaginal swab?
What makes you decide that? Is she having any vaginal discharge?
No, in an asymptomatic patient.
No, we won't do that.
Okay.
If she doesn't have any symptoms, why would we send that?
Okay, ma'am. Okay, thank you.
Any questions from cervical cerclage guideline? I hope you people have given a read to this guideline, please, because that's very important. That's a new one. Honestly, tell me. Who Harshaba did that? Okay, great.
Yes,
right.
Yes. So these are just peer reviews of guidelines that are yet to be released, right?
Actually, what they gave was that it's a draft, and draft comes always before the GTG. So when they wrote the draft and they published the draft, they said the GTG would be published just in few months, but then the COVID came, and so the publish is still not there. But this is by RCOG, so we can quote that because this is their recommendation.
But where is this taken from?
The same draft which I've posted in the main group. Harshaba, provide Divya as well.
I mean, does RCOG actually publish these drafts?
Yes. This is by RCOG. What they always publish a draft prior to the Green Top guideline.
Okay.
So when they publish a draft, they write down that this Green Top guideline would be published in this much time. So there is a little delay on this publishing of this guideline. Green Top guideline, they've mentioned its number as well, my dear. 70 probably. Have a look. They've mentioned its number as well, that it's going to be Green Top guideline, probably 702.
We'll get cases from these drafts as well.
Yeah, because that's something which has probably been published by them. They're not much. They're not much. They're only two. I think one is this. The other guideline has already been published. The one for the labor, the new guideline for the operative vaginal birth, right?
Vacuum, yeah.
Yeah. So actually, 6 months back, its draft came. So we were reading its draft. So now they've changed that into this. Only this draft is still pending. They would be publishing the guideline.
Okay.
Okay, right. So till then, we have to do from this. Can we do a transvaginal cerclage patient with a history of 2 lets and go for transabdominal? Yes, we can do the cerclage. We can definitely do the cerclage. I wanted to speak the same, that it does not, the 2 lets doesn't mean that we cannot put the cervical cerclage. We can put the cervical cerclage.
No, I mean to ask, transvaginally will we be able
Yes.
to do it?
Yes,
Because
yes,
her cervix will be short.
Yes, we cannot say 100% that it's going to be short. We can do, if not possible, then it's going to be abdominal one. So trying always, it's okay, Archana, I would do that. Harshaba, post this draft again in the main group, please.
Okay, ma'am. Right now my phone has switched off, so I
Okay,
will
no
do
problem,
it
no
in a while.
problem. Dr. Sabia is there. Dr. Sabia. Dr. Sabia, post that,
Yes.
please.
Yes, doctor.
Slowly post this draft in the main group, please.
Okay, I will do.
Dr. Sabia is about to sleep, guys. So let us finish up. All right. So thank you very much for a marathon station. This time I had been very kind. Group A, Dr. Sabia was about to. Thank you very much, Girija. Love you. Okay, Ramya has posted as well. Thank you. Right. Great. So Ramya is back with the after the duty, right, Ramya? Ramya, you have to do 1 or 2 stations this week with Dr. Sabia. Please take out time.
Yeah, sure.
Okay. All right. So this week had been a good week in the mini groups. All my groups went good, and the group A, despite lots of commitments and duties, very well done. So this was the first week that you people went with the 10 by 10 in all days. But I hope, Dr. Sabir, you know, doing in the maternal medicine, but still keep them awake and keep them practicing, right? I want to see change in all of you, that you people keep on going and keep working hard in the right direction. Thank you very much for this group B. This week, Dalia and Nadra, Midhat, Shaheen, it all went better than the previous one. So very well done. I'm really happy the way you had been going. And I hope this gets improved. I can see the change, Dalia. I can see that the way now you're speaking is much better. And I'm sure you all are reading well in between and learning from each other. Very well done, Group C. As always, that went beautiful. And the things, they went good this time as well. You've got Dr. Sujata as an addition as an active participant, and she did really well. So that means that you people are learning well. Very good. Group D as always. So this time, this week was better. Maybe you people were a little stressed up from antenatal care. So you people were a little worried that the things, they would be difficult. I know it's difficult, and even the maternal medicine has even more difficult topics like Charcot-Marie syndrome, like pulmonary hypertension. I know they're difficult. This week, preparation was better. However, I'll be a little honest, this week's presentation standard was a little lesser than last week. Am I right? Do you people feel the same? Last week presentation standard, last week preparation, I had cut scores, but the presentation standard was better. Today, the presentation standard was a little lower. I'm talking about a complete presentation of all the stations. So try to get one step ahead. Try to move one step ahead. The presentation should not go one step back. Even if it's a slight improvement, but improvement should be there. Okay? So practicing in the right direction is very important. I will be posting the maternal medicine 8 topics and the WhatsApp tasks in a while. I would like you all to prepare those 8 topics really well. So whatsoever comes your way, you should be ready to take it as a perfect station. All right. Yes, Pallavi, thank you very much. They all were very difficult stations. I tried to make them easy and organized, but I'm sure once you complete that, it would be easier. So what is the tomorrow's task, friends?
I have a doubt. All your stations are very weird and very difficult. Like, we literally had to gather a lot of information from everywhere. Are you giving us the toughest stations now so that the easier ones are easier to do?
No, the topics are the same. The topics are the same which had been touched in exam. I mean, I'm not cooking them myself. It's all what have been coming.
So this is how the exam will be. We'll have
No,
topics
this antenatal care is like one station. So it's not going to be like 14 stations like that. One tough station out of like 14.
Okay.
See, few topics are important, but actually generally the exam is like 10 stations are very easy.
Okay.
And easy in the sense they're straightforward. 2 stations are very difficult and 2 are mediocre. So 14 stations are like this. 10 stations are super easy stations. Like if you know your template, you go inside and you're very confident that what you did in 10. So 10 stations are very easy stations. Like the one who has prepared will find it very easy. All right. Okay. So don't worry about this. Like today's station, if I see the template, I know the topics are somewhere like out of this world, but if you're not going to prepare these topics, it's going to be difficult for you guys in exam. So you have to prepare these topics. That's why I'm solving myself, that you people know that how you have to continue with this, like speaking and doing this station. All right. Okay. Done. All right. Okay. So tomorrow, what you're going to do, all of you, tomorrow it's going to be completing your antenatal care from the recording. Done?
Yes, sure, inshallah.
Okay, so tomorrow you have to complete your templates from the antenatal care, and day after tomorrow you will start, that is going to be Monday, you will start your maternal medicine. So Monday, Tuesday, Wednesday, Thursday, Friday, 5 days you have to prepare, and Saturday is going to be session, right? This session is going to be on Saturday, but then it's going to be again alternate Friday, Saturday, Friday, Saturday, and then topics are also less because we have got tiny modules. These 2 modules were bigger. All right. Yeah, thank you very much for taking me time. Next week, Girija, next week is Saturday, but after that it's going to be Fridays. Okay, Friday, Saturday, Friday, Saturday. Why next week is Saturday, Girija? Because already it was Saturday. Okay, so you give a little more time for one more day for this. Thank you very much. Yes, please.
Dr. Sidra, at the end of all the modules, I wish we can have one more class for antenatal and one more class from maternal medicine module.
Actually, the stations which I did is around already 150. But again, if you people have any difficulty in that, we can make an arrangement. That's not an issue. Okay, I can see that where you people require that, because the topics of the important stations I would be covering in this, all antenatal care and maternal medicine. But yes, books are way too much. I mean, books are making 500 stations, Dr. Sabia. So if you keep all the 3 books of antenatal care, maternal medicine, of course, and total all the topics, then it's going to be around 500 stations. So of course, that is the preparation which you, I will guide you that how you have to do after doing these important exam stations. All right.
We want to listen you more, Dr. Sidra.
So by the time we finish important stations, it will be October 15th.
So let's see, once we complete with this course, the previous are having more live sessions with these books, then we'll decide. Meanwhile, the exam date would also be in front of us, so we'll be in a better position to make a schedule. Okay?
Yes.
Right?
Inshallah. Inshallah. Thank you very much.
All right. Thank you very much.
Thank you very much. Thank you.
Everyone, take very good care of yourself. I know it was a marathon session, but it was important. Just take good care. Have a good, tight sleep and a healthy dinner as well. We'll meet on next Saturday with the maternal medicine. The topics I'm just going to post. But this time, it is a challenge for each group, please. The next live session presentation should be, the improvement should be there. Today, the standard was a little low. I want my students to have a good standard. Except Girija and 1 or 2 more stations, the standard was a little lower. So Girija only maintained the standard, okay, today. So everybody has to maintain the standard of presentation. That's the reason that I give you templates earlier. Now, you know what maternal medicine template is, same as that of antenatal care. So just try to keep that standard and keep moving forward. All right? Okay, love you all. Take very good care. See you on next Saturday. Till then, bye-bye from my side. Bye-bye. Thank you.